കേൾക്കുന്നുണ്ടോ?
Yes, ma'am.
Morning, Rajni ma'am.
Good morning.
Morning, ma'am. We'll be starting the session by 9 o'clock, ma'am. We are waiting for more participants to join.
All right. I'm already present here.
Okay, ma'am.
Let me check that I am sharing my slides. All right.
Okay, ma'am. Yeah, ma'am.
I'll just check it. You have disabled participants from screen sharing. If you can just switch it on for a while.
Yes, ma'am. I'll check, ma'am.
Ma'am, now you can
Yes.
share your video.
All right. Okay. Is it? Can you see this?
Yes, ma'am.
All right. Now I will just, okay. I will stop sharing it, or I can just leave this.
You can just leave the presentation slide like that, ma'am.
All right. All right.
Okay,
That's
ma'am.
what I'm doing. Okay, fine.
Good morning, ma'am. Asuma here.
Hi, Asuma. How are you?
I'm fine, ma'am.
It's so nice to meet you all. I am simply honored.
No, ma'am, you are one of the stalwart in this area, no? So I was telling my colleagues that we have to get ma'am for this session. I remember your classes for us in Monica, National Institute.
Oh,
In National
yeah.
Institute. Yeah.
Oh, yes. Oh, yes. And you are in, where are you now presently?
I'm here in Kerala, Calicut.
Oh.
Actually, we wanted to have this as a as person conference, but because of COVID, no, That is why we made.
I would have
I'll
loved
call
to
you
come
here.
to I would have loved to come to Kerala, Asma.
I know that. I will definitely call you for the next year if our situation permits, if there is no pandemic and all.
I
You
know
can come and stay with us.
yeah,
guest house
everywhere
here.
it is like this, and yeah, really missing that, contact. But still, being online, we have done some very good nursing leadership programs, and we could connect with participants all over, even internationally, so well,
Yeah.
well. And it has been a good experience. Rather, at least we could manage to do something.
That's something great. I have
Yeah.
seen few pictures of you in that conference through Facebook.
Okay. Yes. Thank you. Thank you so much, Asma. God bless you.
Thank you, ma'am. Thank you. My team will be introducing you, and now they will start with it.
Okay. All right.
Good morning, and we are delighted to welcome you all to the second day of National Conference on Healthcare Management Strategies and Tools for Evolving Healthcare Executives. Now let's get started with our scientific sessions. Without much delay, let's take wing to the first session of the day, Emotional Intelligence and Johari Window for the Leaders in Healthcare Management. I invite Ms. Alflin Jose to tell us more about Dr. Rajni Bagga.
I'm happy to introduce today's resource person, Professor Rajni Bagga. Dr. Rajni Bagga is the former professor and head of the National Institute of Health and Family Welfare, New Delhi. She did her doctorate in psychology and has additional qualification of postgraduate degree in human resource management as well as in public relations. She has more than 33 years of experience in applied research in behavioral sciences and human resource management, and has conducted number of research studies in human resources in health and been part of various research studies in collaboration with various international donor agencies. Having a passion for teaching and training, she has specialized and gained expertise in conducting large number of training courses in human resource management, leadership development, counseling, and communication skill and participatory learning and action. Besides having publication in national and international journals, has also written modules, chapters for other books. With her own aspirations at the professional level as a trainer and researcher, she has been focusing on developing and strengthening the leadership skills of healthcare providers, particularly the medical professionals, as well as nurses and midwives, and helping them to become change agents, become more assertive by voicing the issues and challenges faced by them across the country. Dear ma'am, a hearty welcome to this conference and over to you.
Thank you so much, Ms. Jose. Thank you, Dr. Asma. Thank you, Dr. Shelja, for inviting me for this conference. And I have lot of respect and passion for the nursing professionals in our country, and my interaction with them for the last 15 years have made me more humbled when I have been seeing their working styles and how they are delivering the excellent healthcare services besides various constraints. And I wish you all the luck for this conference that you are doing despite the COVID pandemic. All of you have been able to spare some time. I could see Asma is on duty, and being on duty, being in the hospitals, even then, you are attending this conference, and that shows your passion and your motivation to really enhance your skills every day in your professional as well as in your personal life. Friends, this session which you have given me to talk with all of you that what is emotional intelligence and how emotional intelligence can be enhanced, and we'll make use of Johari window, and how emotional intelligence is so important for leaders in the health sector. I would say not just for leaders, I think this is for each and every person. Emotional intelligence is highly important for your personal, professional, social, in every sphere of life. So let us go further. I would like to share my slides, but friends, I would like to have a lot of participation from all of you. The kind of program sessions that I have been doing, and I don't believe in teaching and doing any lectures. And that is the reason that I never used to develop PowerPoint presentations, because I like to have live discussion, interactions with the participants, and that's how I used to move in my programs. But we have the constraints of this platform. So I'm using my slides, but I want all of you to actively participate. And please start the chat box buzzing. I would be in between looking at the chat box for your comments, for your suggestions, for your questions, and that will help me to move ahead with the session. I don't want to go with my structure style. I would like to have some instances of your day-to-day life where you have faced conflicts and how you reacted. Is there another way by developing emotional intelligence and social intelligence, IQ we all have? So can we alter that reactions to that situations? Can we alter how we deal with ourselves? So friends, for that, I want the comments and suggestions coming from you. So, and if you are comfortable in switching on your videos, I will be very happy to have face-to-face interaction with all of you. The number doesn't matter to me. It is the quality of an interaction with each other. So friends, I would like to have lots of comments on this chat box. So let's start. Let's get going now. And okay, I would start my presentation. I think I am already sharing this presentation. Can you see my presentation?
Yes, ma'am.
Okay, so I think this one, I can also have a look at my presentation, friends. All right. So the session which has been assigned to me is developing emotional intelligence among healthcare in the health sector for the leaders. All of you are leaders. Friends, who are the leaders? The leaders are those who are the change agents. Am I right? You are the change agents. You are the ones who are motivating and supporting the people, the human resources in your hospitals. So all of you are leaders. Let us not say that, emotional intelligence will be developed by my leader who is my senior. No, leadership is not positional. Each one of us, leader is the one who builds people relationship, who motivates people, who's a change agent. So all of you are leaders in the health sector in that respect, friends. All right, so let's get going. And you will be wondering, I don't know if all of you have had in the past any interaction on emotional intelligence and what do we mean by emotional intelligence. In the last 1 decade, this concept has become is increasingly becoming very, very popular, and all healthcare providers need a high dose of emotional intelligence, and we can learn it at any age, irrespective of your age, your sex, and your profession. Each one of us can develop it. Today, we are being judged by a new yardstick, not just how smart we are and how competent we have and how many degrees we have. No, we are judged by how well we handle ourselves and other people in our hospital. Our patients, our patients' attendants, our students, our colleagues, our subordinates. How do we handle our feelings? How do we help the other people to manage their feelings? Now, this is increasingly becoming more and more demanding. And there is a growing body of research findings which have scientifically shown, friends, there's a lot of research which has been going on in the Western world also, and now in India also we have started, which has proved that emotional intelligence predicts how well you perform in your house, in your school, in your hospital, in your nursing institution. And why in healthcare? Friends, all of you nursing professionals are working in a highly, highly demanding profession. Day in and day out, you are working with the either you are building the future nursing professionals as a faculty, or you are working with your staff in the hospitals, you are working with the patient and the patient's attendants. So there is a lot of expectations from your stakeholders. Your stakeholders means your patients and their families and your other clients. You all face wide range of challenges in terms of positive emotions and negative emotions from patients. Thus, high emotional intelligence as a healthcare provider can not only manage one's stress, your conflict, but also manage different situations around by building relationships. And Dr. Asma, is my English comfortable with everybody? Please let me know.
Yes, ma'am.
Yes, ma'am.
Is
Yes,
it?
definitely.
Okay.
Yeah.
Okay, so if anybody feels that I have to make use of Hindi, though I don't know your language, but I am only comfortable with English and Hindi. All right.
English is okay, ma'am. We all
Okay.
are conversant with English.
Oh,
No
very
problem.
good. Very good. Very good. Very good. Okay. Okay. All right. And the slides are easily everybody can read my slides, no issue with that.
No issue, ma'am. Your slides are good.
Okay, all right. Okay. What happened? All right. Now let me show you a very interesting, this model. This is a CASH model, KASH. This model was developed by International Labour Organizations for Human Resource Management, and somehow I found this model very interesting to discuss the difference between emotional intelligence and intelligence quotient, IQ and EQ. You see, in any organization, to manage the human resources as a leader or as any staff member, for building the human resources, there are four most important, processes and factors which are needed. Of course, K is for knowledge. All of you have a lot of knowledge of the health sector. You have knowledge of your nursing. You have done BSc, MSc, or doctorate. So knowledge is nothing but an information of your job, the know-how. And this knowledge, once you are starting practicing, this knowledge builds up your skill, your hands-on skills, your research skills to work on the patients. You sharpen your skills. Now, do you think this knowledge and skill we develop and we build and we keep on building because of our IQ? IQ is your intelligence quotient. IQ is your ability to solve problems, your ability to get new knowledge and new information to grasp. Knowledge, skill, IQ is your mathematical, builds up your scientific skills, your mathematical skills. So knowledge and information comes with your IQ. As all of you know that our IQ is something which cannot be changed over the years. IQ gets fully developed by the age of 5. As a child, the child's IQ can be encashed by exposing them to different talents and different like music, like reading ability, and so many other abilities. But this maximum encashment is by the age of 5. So our IQ gets determined. I remember when I was in PGI, Chandigarh in psychiatry, and we used to have children coming to us in child psychiatry, and we used to measure their IQ. So IQ is like below average or above average, or somebody's, super intelligent or a genius. So this is already determined. It depends upon the opportunities to further encash. So this knowledge and skill comes from IQ. All right. Now, do you think this IQ is sufficient to build and be popular in your work? Your IQ will make you successful, a successful doctor, a successful nursing professional, a successful nursing superintendent you will become. But are you building your organization? Are you building human resources? Are you motivating people to perform better in your department, in your ward? Friends, that is not encashed, is not built through IQ. That happens through EQ. And now on one side, I have shown you K and S, which is knowledge and skill. A is attitude. Attitude comes from your emotional intelligence, concern for people. How do you feel for them? Attitude is not knowledge and information. It is a set of feelings. And these set of feelings are developed over the years through our value system, our belief systems. How do we feel about others? Attitudes are favorable, non-favorable. Attitudes are positive or they are negative, or you have indifferent attitude towards the community, towards your profession. You are just taking it as a job, or you are taking your work as a service. That comes from attitude. Knowledge and skill is not sufficient to run institutions. You can make money with knowledge and skill, but it is not an institution which grows over a period of time and becomes popular among the community. That happens as a leader. It happens through EQ. Now, attitudes come from top to bottom. Your attitude as a leader's attitude, the organizational head's attitudes go down below. Like water flows from top to bottom, similarly, attitudes in the organizations come from top to bottom. And the attitudes get converted into how do you behave. It is my attitude determines if I like to be punctual on my work, and I take my work not as a job but as a service, then my attitude will lead to a behavior of being very punctual, focusing on my work, being very, very compassionate and passionate about my services, to learn new skills, to grow further, to interact with people, to motivate people. So this is my behavior. And a behavior which we repeat over a period of time becomes habit. So H is for habit. And the habits of group of people in your hospital or in your nursing institution, college, the habits of group of faculty becomes the culture of that institution. So what is culture? Culture is determined by knowledge and behavior as to how people are working and interacting and taking their work. That determines the culture of the institution. So I have my understanding that knowledge and skill comes from your IQ, and attitudes and habits or work culture. Work culture of any institution becomes favorable and desirable because of the EQ. Culture is a combined pattern of attitude and habits which become the behavior of the organization. Sometimes you say, you know, that hospital, I really like to go for any problem because, you know, the way people talk to you. If I have to wait, you know, I don't mind because I know I will be heard, I will be treated well. And sometimes you go to a very 5-star hospital, but people are very commercial. They are very indifferent. They may have very seasoned doctors and nursing professionals, but you don't feel motivated to come back there again and again. I'm sure it happens at every place of work. It is the EQ which determines that culture, that feel of that institution, of that college. So knowledge and skill are the technical part of the organization, and attitudes and work culture are the behavioral part of the organization. And I tell you, friends, when we are talking about building emotional intelligence for leadership, so leadership is behavioral. Leadership doesn't come from knowledge and skill. Of course, a leader needs knowledge and skill, but having high amount of IQ does not determine that a certain person is a leader. So leadership is all behavioral. Leadership is not a role. It is not that you are a principal of a college, or you are a nursing superintendent in a hospital, you become a leader. No, leader is the behavioral part of your own self, of your personality, and it is built by what is your IQ. To what extent you are growing and building your EQ, not IQ. So I hope, friends, by drawing this model of COAHS, I'm able to bring about a distinction, a clear distinction between knowledge, skills, attitudes, and habits, mainly the difference between IQ and EQ. Is it? Technical part of yourself is determined by your IQ. Your IQ is your ability to learn new skills, to get more degrees, to get more training. And EQ is your ability to connect with people, to be humbled with people, to motivate people, to support them, to encourage them to understand your feelings and not react and understand the feelings of others. This is EQ. So I hope, friends, this distinction with this model has made it clearer. Can I hear some voices or not? Yeah, can I hear the voices?
Yes, ma'am, it's clear.
It is clear. Okay, and I want the comments in the chat box. I'm very happy there are 73 people who have joined. It's a very encouraging, but I want these 73 people to really write in the chat box. Okay, their concerns, if they have any questions to me, and please keep the chat box buzzing. All right, now I'm moving further. Okay, so in IQ is all about myself. What do we mean by myself? IQ helps me to understand my needs. It helps me to feel for myself. It helps me to just grow in my degrees and get more education. This is all about myself. I'm becoming a doctor for myself. I am earning money for myself. I am building a family for myself. But emotional intelligence is not just about yourself, but focus is on understanding and developing other human resources around. Understanding them, feeling for them, and helping them to grow. That is emotional intelligence. And that is what we discuss, we describe in leadership. There is a comment. Yes, ma'am. All right. That's it. Okay. So let me move further. Okay. So now, but we need to now change. All these years in our health sector, we have been focusing on IQ. When our children are studying, we are only focusing on our children scoring very high marks. Get good marks, so that tomorrow you will get admission in a good college. How many of us tell our children and our students not to struggle with marks alone, but build up your behavioral skill? Do we tell them to first build up your compassionate attitudes, treat other people humbly, be concerned for people, feel for them, understand them, help your friends in your classroom? If your friend has not brought food, tiffin today, and please share your food with them. If your friend has an injury, please share your classwork with them. No, these days, I think children are becoming very, very selfish. They are so focused on themselves only. And I think that has to change. That has to change now. So we have to change our attitudes, our mission, and our perspective. And IQ is there already. Because of the IQ, you have joined these positions. You have become a doctor, an engineer, or IT professional, or you have become a nursing professional. It is because of your IQ. But IQ is not going to determine your popularity. How you are known and remembered. How you build people, because leadership is all about building people, enabling people, developing people. So if you want to become a leader along with a nursing professional, as a faculty, as a tutor, or as a nursing superintendent, as a staff nurse, now is the time to focus on building your emotional intelligence. So it is the capacity for recognizing our feelings and feelings of others, motivating myself and motivating other people. I will now come to each of the emotional intelligence capacities I will be talking. And for managing the emotions of mind and managing emotions of other people. So friends, as I will just repeat again, I am repeating over here that IQ is helping you to build your knowledge for mathematics, for science, for your syllabus, for getting high marks and taking up the jobs. And, it is all about your learning of the technical side. But EQ is to maintain peace with other people, to solve stress, to solve conflicts, manage your time, be responsible to your work, to your goals, and be responsible to growing other people. Be honest to your work. What work we are doing, be honest. Honesty can be in terms of material honesty, or it can be in terms of being truthful. Honesty can be in terms of bringing out the knowledge into the open, sharing ideas with other people, not keeping to yourself, and respecting the boundaries of other people. And friends, now these days we are also talking about the third quotient, which is the social quotient. Social quotient, it is your ability to build network with your friends, acquaintances, with your students, with your colleagues over a longer period of time. I know I have my friends from my since late 60s and 70s. 50 years old friends, we are maintaining such close bonds. So that is SQ. And these days I have seen children, my daughter and her friends, their friends keep changing. It is all WhatsApp friends these days. They may be having high IQ, but they lack in the social. This is the peer group. They don't have long bonds. As the colleges, school change, the friends also change. I'm sure you also have the experiences like I have. And same I have seen in my neighborhood these days. We used to have very close bonds with our neighbors. It used to go into generations. The neighbors used to become your family. But these days, people don't even talk to the next door people. They don't know. They don't want to share. I'm sure you agree with me or not. Do you agree with me?
Yes, ma'am.
Yeah. Okay. All right. What happened? Oh my goodness. There is something in the chat box. Yes, ma'am. Yes, ma'am. Write something beyond. Yes, ma'am, also. Okay. What has happened? Wait, I think. All right. So people that have high EQ and SQ tend to go very far in their life than those who have only IQ. IQ people are not remembered in your life. You always remember people in your life who had high EQ and SQ because you remember somebody, your school teacher, because your school teacher motivated you a lot. Your school teacher helped you to really cover up in the school. That is why you remember. So if you remember and you grow respect in your life, it is not because of somebody's IQ, it is because of their EQ and concern towards yourself. Several institutions today only capitalize on IQ. When we conduct interviews to hire people in our organization, we only look at their, resume, that how many degrees they have, where all they have worked. But now it is changing. It is changing. At least whenever I sit on any interview board, my concern is to really identify through interaction that the person's attitudes, the EQ and SQ, to be able to work even in high stress work. I have seen people with very high IQ cannot bear the stress of their working situations many times. They may have problems, they may have breakdowns, but the EQ and SQ people are very strong, very resilient. They can help themselves to fight the conflict, and they can help the other people. All right. So the research has shown that IQ can help you to be successful to the extent, say, about 20%, but it is your EQ which will rest depends upon your, EQ to make you popular, to make you more desirable. All right. Now, do you understand what motivates other people, even those from different backgrounds? Do you sense other people's feelings? Do you understand somebody has not spoken the norms, but you can send the vibrations of organization? Do you help and coach and mentor your juniors, your team members, your students? Do you give helpful feedback to other people? Do you solicit any feedback from other people? Friend, this is all concerned with human relationships, and building bonds is all coming from your EQ. Now I come to the second part of this discussion is, now you are wondering, what is this EQ? How can I work on my EQ? So friends, EQ has two competencies: personal competency, which is within me, and my social competency, which extends in handling and building and maintaining relationship. Personal competency is built by three levels, three aspects. First is your self-awareness, your self-management. Regulation is your management. And third is motivation. Motivation is commitment. Motivation is helping other people and helping yourself. Okay. And then the second competency is social competency. Somebody has written something. True, ma'am, medium intelligence people are good, hardworking. Yeah, many times I have seen average intelligence people become very popular in their profession. They're very hardworking. They're very resilient. You make them work day in and day night, and they will say, yes, ma'am, there's a crisis in the hospital. I will do the work. I will manage it with less resources also. And the second is social competency, which I'll talk about. It is in two competencies, abilities for empathy and social skills. So friends, now you are wondering that what is, so this is the circle. Personal competencies determine how we manage ourselves vis-a-vis other people. And first is self-awareness. Am I aware of my feelings? How do I manage in situation? How do I react? Sometimes you have been very restless at home and very angry at home, and you come to work and you take out your frustration, anger onto your staff, onto your patients. We are not aware why I am being so nasty with people. People have not given me reason to be nasty. So because we are not aware, it happens or not? Yes, it happens. It is simply knowing who you are and understanding how you are feeling at that moment, how you are thinking. Self-awareness is when we feel our emotional reaction to situations. We don't realize why I am reacting. You know, you are coming to your college, hospital, you don't find a parking, and you start fighting with other people, or you park your car and blocking other people. That is lack of awareness. Our patients come to us with all their test papers not organized, and we start shouting at them. When they speak, we don't listen to them. That is less self-awareness. It is me who has a problem. Patients don't have a problem. The problem lies within us. It is our reactions to the situations which is a problem, because we have very less EQ into ourselves. It is important to stop and ask, why am I feeling stress? Why am I reacting like this? What has happened? There is a reason behind it. All right. This is self-awareness. And self-awareness is in terms of your emotional awareness, your awareness of your feelings, your moods. And self-awareness is, are you aware of your strengths? When you say, no, I cannot take more work. Are you aware you can? Are you underestimating yourself, or are you overestimating yourself? Just a friend, just 1 second. No. Yeah, thank you. So when we are talking about self-awareness, emotional awareness, accurate self-assessment, and confidence in yourself. Many times I have seen people lack confidence. They don't appreciate themselves. If I tell Dr. Asma and Shelja, oh my goodness, you are managing your department so well, and you will say, no, ma'am, not at all. I don't think so. So, you know, people many times don't appreciate and feel a sense of pride in themselves. Oh yeah, I am. I have the capacity. I can grow. So self-awareness is in terms of emotional awareness, self-assessment, and self-confidence. I think I'm running short of time. Can I go on till 10? I will run now. Hello, Asma, Dr. Shelja, can I move further?
Yes, ma'am.
Yes, ma'am.
Yeah. Can I go on till 10?
Okay.
Because it really took me some time, because for many people I have seen emotional intelligence is a very new concept. So it takes time. I just didn't want to show my slides and finish the session. You know, I thought it is important to discuss. All right.
Yes, ma'am. Yes, ma'am. Please go ahead.
Yeah, okay. So now the second level after self-awareness is self-management, self-regulation. It is the ability to control and redirect your disturbing impulses and moods, and hold on your judgment for a while. You know, sometimes we meet somebody and immediately we jump to conclusions. We make judgments of people, and all our interaction is based on those judgments. I think that is our perceptions. Perceptions are nothing but coming from our judgments. So I think we should have a self-control, check our emotions, try to maintain relations of trustworthiness and integrity with other people. Be conscientious, take responsibility for your performance, and be managing change. And I have seen people who are very adaptive to changes, to crisis. I have seen during the pandemic, the nursing professionals have done the abundance of remarkable work. The whole, I think, backbone during the COVID pandemic, it rested with the nursing professionals. Hats off to you all. Just because all of you have a very high adaptability in crisis, unlike many other people I have seen, but the nursing professionals have a lot of passion and adaptability. And next is to innovate new ideas and change, bring about change, do something different. This is all coming from self-management. And then the third one is you are concerned to be aware of your needs and your goals and pursue your goals. Don't be just focused, ki I have got this much, now I am satisfied. No, you should always struggle for more achievement, more commitment, taking more initiative. Be optimistic, be positive about yourself. Yes, I can grow, I can do many more things. I can make big teams also, and we can hold various camps in and around. So be innovative and take more initiative for change and for building people. So friends, I have just talked about personal competency in terms of self-awareness, self-management, and self-motivation. And now we are going towards what do we mean by social competency. There are two competency, personal competency and social competency. So these competencies determine how we handle relationships with other people. And this is in terms of empathy, and social skills. Empathy is extending a part of ourselves, getting into the shoes of the other people. I would say entering into the feelings and emotions of other people. That is empathy. Empathy is not mere feeling of emotion. Empathy is translated into action. When you say, oh, I am so sorry for these patients who are not able to sleep at night because there is a lot of noise coming from outside. That is just sympathy. But doing something about it, doing something about the noise, that is empathy. So empathy is in terms of understanding other people's feelings and taking an active interest in them and developing people. I have seen many hospital administrators, medical superintendent, nursing administrators have really organized and built up a tie-up with the NGO so that there are restrooms for the attendants made. There are free kitchens which is running in the hospitals. That comes from empathy. That comes only from your concern, feeling for the constraints of other people. Whenever your feelings get translated into action to help and grow and empower other people, that comes from empathy. So empathy, service orientation, recognizing and meeting your patient's needs and growing different opportunities, concerned about who takes decisions in your locality, in your institution, that is your political awareness. And because I want to spend some time on Johari window also. So let me rush to the last level of emotional intelligence, that is your social skills, social quotient also in managing your ability to manage relationships, build networks of contacts, network of friends, network with your colleagues, network with your customers. And this is all coming from your social quotient. And how much of influence you have. Influence is not your danda and control and power. Influence is how you can persuade people, how you can motivate people. How do you communicate? Do you listen for ideas, or you are only giving as an administrator orders and instruction, or you are listening for ideas and managing the conflicts? Conflict at interpersonal level, conflict at the organizational level. So friends, we have discussed about emotional intelligence, its difference from IQ, and what are the two competencies, and then the levels in each competency. Now you will be wondering, now what are the methods and techniques by which I can grow and build my emotional intelligence? Friends, for me, I have seen in the last so many years, I have not come across a better model than Johari window for building our what I say, emotional intelligence. That is, I feel, now before I go to Johari window, high emotional intelligence organizations are very positive. They celebrate success. They don't have any harassment and nagging, so on. And I think I can skip these slides, which I had recently made. And now let us come to Johari window. I'm sure Johari window I have seen is a very popular, very popular approach and a method, which is which many nursing professionals have told me they have learned and studied during their BSc in College of Nursing. Or maybe I'm sure you know it. So the best method is Johari window. Johari window was developed, this method, this approach, this technique, which is kind of an intervention, or it is diagnostic also, was developed way back in 1950s by two psychologists of the name of Joseph Luft and Harry Ingham. And they coined it as Johari window. Friends, this is the basic model of Johari window. You can, there are several articles, topics on Google you will do, and you will find much more details on Johari window. Johari window has 4 compartments. And why it is called window? Windows are always meant to be open. We have windows, 30% wall area of our room is window, so that when we open a window, we have cross ventilation. The foulness of the room goes out. We get fresh air from outside. We can see greenery from outside. Now, the same concept of window is applied in building ourselves. It means it helps to become open. It helps to open our windows, our minds, to receive ideas and to share our concerns, my feelings, my anger, my fear. When I share with my friends or with my close bonds, I feel much comfortable, isn't it? But I have seen people who don't share their trauma, their feelings, their anxiety with others, and they keep it bottled within themselves. Bottled within themselves, because they are not aware, and they become very autocratic. They can be very destructive. They don't listen to other people, and they don't manage stress in hospitals. They don't manage conflict because they are not able to deal with their own selves. So such people have very low emotional intelligence. Johari window helps us to identify our emotions and identify the emotions of other people and increase our emotional intelligence. Now, Johari window is based on 2 dimensions: apart me, myself, and others. Because all our life, our communications, our growth is based upon how do we interact and deal with other people around me, in my family, in my society, in my organization. So Johari window has 2 dimensions: me and self and others. And secondly, this me and self is concerned with a part of me which is known to me and it is unknown. So it has known and unknown second dimension. All right, friends. Now, if you look at this diagram I am showing you very clearly, you will see there are 4 different windows, 4 squares, 4 quadrants there are. Okay. The first one is on the top left-hand side. You will see a part of us, which is the information which is known to me, and it is also known to others. It is also known to others. I'm showing you this. An open area. I have no problem in sharing what is my name, my age, what are my educational qualifications, where am I working. People know it easily and I share it easily. This is the open part of myself. But is it you really? No. This comprises a very small part of yourself. But many times we jump to conclusions, we make judgments about people, how they look, what is their height, what clothes they are wearing, how they are speaking, what language they know. So, we just jump to conclusions. But there is so much more about us which is lying in other columns. Okay. So now let me come to the other column. This is at the bottom. That is the information which only belongs to me, but other people don't know. Okay. This part of me, it is known to me, but unknown to others. This is hidden. I have closed the almirah. It is bottled up. What all comes in here? My fear, my anger, my anxiety, my embarrassment, my failures, my past experiences, sometimes domestic issues, domestic violence, child abuse. As a child, somebody was abused. Or it can also be, as an administrator, you have a lot of power within you and you keep all the information. What grants are coming? What more trainings are coming? You don't want to share with other people. So many times I have seen people who have a very large hidden area. Their emotional intelligence is at the lower level. If you want to build your emotional intelligence, then we have to reduce this hidden area. Bring this hidden information out into the open, sense it where you can share it. Try to feel comfortable with yourself. Try to feel that why I am so sensitive to situations, why I'm so impulsive. Is it because I am not able to deal with my own problems? First, I have to deal with my own issues of managing my time, managing my resources. So friends, our large hidden area is a very big barrier in building our emotional intelligence. All right. And now there is a comment. Let me see. Ma'am, as usual, you keep your dynamism, feel proud to be associated with you. Yeah, many times it is positive. You are very right. I say, I have joined a new institution, but I don't want to tell people how talented I am. They will laugh at me or they will take advantage of me. So, we just keep it within ourselves. We don't bring out our talent. And again, it depends upon another colleague's high emotional intelligence to identify and tap your potential and your talent. Am I right? Am I right? We need to be sensitive. Each and every human being has immense potential. Everybody has. But this potential is neither known to me, known to us, nor it is known to other people. Because we live in an area of high IQ and low emotional intelligence. There is another comment. Thank you so much for accepting my information and sharing your thoughts. Okay, now I come to the third window on the top right-hand corner, which is called the blind area. Why I'm calling it blind? This is that part of me which is known to other people about me, but I don't know. You think it is impossible? No, it is not impossible. This is information like, what are my reactions to situation? What is my facial expression? Our actions speak louder than words. Your body language sends a much louder message about how are you feeling today? Why do you always look restless? You don't know, but other people know that you are very restless. You don't know that I have the capacity to take on more workload or to learn new skills, but other people know. Many times I have seen people who have health problems, diabetic, they are very obese, and they say, no, nothing will happen to me. And, they go for medicines, take lot of drugs, and go for surgery. But I always tell them, why don't you do yoga? Yoga will help you. No, I can't reduce my weight. So many times we are not aware of ourselves, but our friends and others motivate us, push us, say, you have the talent within you. You have it. You can do it. That is how our friends and people who have high emotional intelligence, they can help us to reduce our blind area. For blind area, I always give the example of that movie Tare Zameen Par. I don't know if you have seen. In that, this little boy of 8 years old had dyslexia. And his parents were very upset with him. His teachers used to hate him. And this boy was living in trauma. Then he was pushed into a hostel. And there came a teacher who identified this dyslexic boy's talent of looking at 3 dimensions and helped him to grow. And that's how the blind area was broken. So blind area comprises of negative emotions, negative aspects, and lot of talent and positive things within ourselves, which we are not aware. So if we reduce our blind area, if we help other people to reduce their blind area, it helps us to increase our emotional intelligence. Now, friends, when we have reduced the hidden area, when we have reduced the blind area, what is happening? We are increasing the open area. Now, there is a fourth column also, which is very important. A part of ourselves, which is neither known to me nor it is known to others. You will be wondering, oh no, it is not possible. Yes, we all have so much of potential within us, untapped talent, untapped capacity, untapped skills, untapped competencies, which neither I know nor others know. But it can be reduced. How it will be reduced? By reducing the blind area, reducing the hidden area. And once the blind area gets reduced, you can see this hidden area gets reduced automatically, the unknown part of yourself, building up confidence, becoming aware of yourself. Again, Johari window helps you to become aware, self-awareness, self-motivation, self-management. And you say, oh yeah, I can do it. Yeah, I'm sure what you were 10 years back and what you are now, there's a lot of difference. You have grown. You have become more confident. You can speak in public. You recognize your talent and you grow your talent. So friends, this method of Johari window of knowing myself and making it open to others, helping myself to grow, this method is very important to help us to grow our emotional intelligence. All right. Now, I think I have gone beyond 10 o'clock, and I should come back to you for your questions now. Ma'am, can we measure emotional quotient of a person? Yes, Yes, Miss Jose, we are. There are tools where you can measure. Now there are scientific tools which have developed, okay, which helps to measure the emotional intelligence. But you know, there are other ways of, you can do role plays in your institutions, put people into situations, and you can identify their emotional intelligence. All right. You can do it without the tests also. How people react, have a group discussion, and the group discussion will tell you who has good listening skills, who allows other people to talk, who is not throwing tantrums. So you can identify that a person has low EQ or high EQ, and you help somebody to grow their EQ by helping them with Johari window. Johari window is a very important method, friends, for you. Use it on your students, use it on your staff nurses, and help them to increase their emotional intelligence. And that means you are a leader. Very informative and understanding. Hope we all try to build our EQ after your talk, motivating to look into ourselves. Thank you, friends. This is very interesting, and I feel very motivated to get your comments.
Thank you, Dr.
Okay.
Rajni.
Yeah.
Thank you, Dr. Rajni, for your motivating session and for keeping us well informed on the significance of emotional intelligence for the leaders in healthcare management. Thank you, ma'am.
Yes.
I also want to say thank you, ma'am. Thank you so much.
Thank
Asuma.
you, Asma. Thank you so much, Asma. We are connected on Facebook.
Yeah.
And thanks to Dr. Shelja. And we had been communicating with each other. And God bless you all, and best wishes. Hope to meet you all sometimes in near future physically. All right. Okay. So do I sign out now?
Yes, ma'am, you can.
Okay. All right. Thank you so much. Thank you.
Thank you, ma'am. Thank you so much. Now let's move on to the next session. We are proud and lucky to have with us Dr. Somu Ji, who will be leading the session on the techniques of quality assurance in healthcare management. I invite Dr. Shijala CH to introduce Dr. Somu Ji.
Good morning to all. I'm happy to introduce Dr. Somu Ji, who is currently working as a professor in the Department of Hospital Administration, KMC, Manipal. He is the coordinator for MHA program at Prasanna School of Public Health, Mahi, Manipal. Dr. Somu has completed his MBBS from Kasturba Medical College, Mangalore, MD in Hospital Administration from Kasturba Medical College, Manipal, and he has completed FAMER Fellowship in the year 2021. He has served in KMC Manipal in various positions, starting from junior resident to professor and head of Department of Hospital Administration. He has more than 30 publications to his credit, and he is actively involved in various research projects and guiding MHA students. He has attended and organized many workshops and conferences in her organization. He has published 2 books and an active member of Indian Medical Association and Academy of Hospital Administration. With this brief introduction, I invite Dr. Somu to take a session on techniques for quality assurance in healthcare management. Over to you, sir.
Thank you, ma'am, for that generous introduction. I hope my screen is visible and I'm also heard.
Yes, sir. Your screen is visible, but your screen is a little bit dull, sir. Your face is a little bit dull. So it looks dark surroundings of there. So
is that fine now?
Your
I
face
think
is
it was
still
a light.
dull, sir. Yeah.
Now?
Now it is
Okay, but it's okay. I suppose, if the screen is visible, that's fine. So,
yes, sir. Okay.
So, first of all, thank you for this opportunity. And without wasting much time, let me go through this session on techniques for quality assurance in healthcare management. So, most important aspect is that I'll be discussing through this presentation, as I'm just going to sensitize everyone to the various techniques or tools that are available for ensuring quality assurance, and that which we generally adopt in our healthcare scenario. So my flow of presentation goes back. I'll just give a brief background about quality in healthcare, quality assurance, what exactly it means, and then we will go through some tools which will ensure quality assurance, and then we take few insights from the healthcare industry. Now, quality improvement, if you look at the term quality in healthcare services especially has just come over maybe over the last 20, 30 years. Much before that, it was just curative services and nobody really bothered about having quality in healthcare services. But then what happens is the term quality or the various tools of quality also have been borrowed from other industries. So primarily why we focus so much on quality is because it helps to enhance our safety. So that is one aspect. And then to look into the effectiveness and then efficiency. So quality tools help people to understand and improve the processes. So the most important aspect here is the skill lies in the ability of application of various quality tools or techniques which are from the other field. So as you know, there is no such, we can apply any form of a quality tool, and the whole idea of applying these tools is primarily to bring about a change in the system by enhancing the quality aspect. So in the healthcare domain, what we primarily look at is the ensuring and enhancing the patient satisfaction levels or patient care levels. Now, the benefits of this quality improvement system, which we adopt, is basically to ensure and bring about enhancement in the safety of our activities, and to ensure that from the administrative point of view, to see that the effectiveness is achieved, and all these things are to be revolved around the patient. And it is also a proactive mechanism, because what happens is when we talk, it's not we measure the quality at a later time, but it has to happen continuously. So it will also be cost effective, and it brings about efficiency in the system. So overall, improving the quality and performance in the healthcare environment can help the providers to ensure that it is cost effective, the system is reliable, and there is sustained care processes. And also there is the overall goal ultimately is to improve the care delivery process. Now let's talk about quality assurance before we go into the quality tools. And all the tools that are there, the quality tools that we apply, all resolve around this quality assurance. Now, quality assurance is basically the planned and systematic activities implemented in systems so that quality requirements for a product or service can be fulfilled. This is as per the definition of quality. Now, when we talk about quality assurance, it's an act or a process of confirming that a firm's quality requirements are being met. So, managing the quality of production involves planning, fulfilling, and monitoring activities. So, basically, what I would like to emphasize here is that when we talk about quality assurance, now quality assurance basically would not just involve about the outcome, but it's also looking into planning of the services, fulfilling the needs, and also by monitoring. So there are three components that actually frame the quality assurance aspect, and this is the difference between quality assurance and quality control. I'll come to that in the next slide. So quality assurance encompasses the processes and procedures, systematically monitoring different aspects of a service or a facility through audits and other form of assessment. Quality assurance efforts detect and correct problems or variances that fall outside the established standards or requirements. So if I can just explain this, I have put two pictures. One aspect is to talk about quality assurance, what is quality assurance, and the other aspect is quality control. I have also put here the input-output process. So when we look at this, what I'm trying to explain in this is that when we talk about quality assurance, okay, Now, anything else that you can think of when I put the input output process? Any other concept is coming to the participants' minds? If it is, probably you can share, or you can put in the chat box. Okay, when we look at this input process and output part, it is also what I'm trying to emphasize here is a control mechanism. There are two methods of controlling. You can have a feed forward type of a control or a feedback control. Okay. Now, when we talk about quality control, now quality control usually comes in a system of, let us say, it is more applicable in the production industry, manufacturing industry, where the product should actually comply to certain requirements or standards. So if it is applicable, so what happens is the output is actually measured against a set standards, and then what happens is it sees whether it passes the quality test or not. But when you talk about quality assurance, it is more like, what happens is about your feed forward control. When I'm talking about feed forward control, I'm trying to tell that what happens is that you are trying to make up corrective mechanisms right at the level of, it's not only at the output level, but it is also at the level of input and at the process level. So when here, what happens is quality assurance aspect basically looks at this. That's why I was just trying to tell you that when you talk about quality assurance, it is more of trying to put in your mechanism in place at the level of input. So you should ensure and see whether the right inputs are being fed in. So that is where you talk about the planning phase. Now, when the planning phase itself, you're taking an active step. So that is where they tell that it is proactive. And not only that, what happens is that even the system during the processes also, you are trying to take a feedback, and then also before the final output, there is an audit mechanism also. Now, the difference between quality control and quality assurance is generally adopted in a service industry where the process is very important. Whereas in a quality control aspect where the product is important, you can leave it to quality control because the actually measured against standards. So this is the basic difference between quality assurance and quality control. Now, there are various methods or tools that we can adopt for ensuring that there is quality assurance in the system. Now, I'm sure that all of you all would be aware of these basic tools that are generally adopted to bring about enhancement in the quality. So most of these tools which are adopted are all adopted to ensure either it would be to bring about changes at the input level or to bring about changes at the process level. So these 7 basic tools which are there, I'm just telling them that these are only the basic tools because a combination of these tools can also give rise to other aspects which can be adopted for enhancing the quality aspect. So flowcharts, check sheets, cause and effect diagram. This is also called as Ishikawa diagram or the fishbone diagram, simply because it represents the structure of a fishbone. And then we have Pareto chart, histogram, and then control charts and scatter diagrams. Now, what happens is when we talk about the applicability of these 7 basic quality tools, it depends upon the situation. Either a single or a multiple of these quality tools can be adopted in a hospital situation to bring about a change in the quality aspect. Now, let's go through these tools one by one. Now, we talk about the flow chart. Now, flowchart basically is a graphical tool for the process of understanding something. So when we see that in a particular situation, in a hospital situation or in a healthcare domain, when certain processes need to be understood because we want to bring about a change in the process, you want to enhance the output, or you want to bring in effectiveness or efficiency to the system, the first and foremost thing is that you need to understand the process of how a particular thing functions. So a flow chart is basically the one in such instances you use a flow chart. It is also called as a process map. And basically a flow chart creates a map of steps in a process, documents the inputs and outputs for each step, and it also gives a picture, and it's also put in such a manner that it is in a sequential. So a process, when you talk about a process is something that comes one after the other. So you will understand the steps of what is the preceding and what is next. I've seen then there are various ways in which it can be represented. Okay, so now we will see as to when we use the flow chart. When do we use a flow chart is basically, as I told you, when to develop the understanding of a process. For example, let us say, for example, you want to understand in a hospital situation, you want to understand either a procurement process. There are various places where you can use this. You want to understand the procurement process. You want to understand the process of how a system works in a pharmacy, or maybe even if you want to understand how the process happens in a, the patient flow, the flow of patient, what happens. Now, all these aspects, sometimes what happens is where you want to adopt this flowchart is when you suddenly find that there is some problem where I feel that I can bring about a change. Now, let's see a simple example I will give you. If there is a crowding in the OPD, can we use a flowchart for that? And in what way, by using this flowchart, how does it help? If there is a crowding in the OPD, can a flowchart be used? Okay, so okay, now let us take, for example, when you are actually having when we want to use a flowchart for a crowding in the OPD, does a flowchart help? So the most important thing is what are the various, once you understand the process of how this particular thing, why the crowding is happening in the, let us say at the outpatient department, or let us say at the registration counter. Now the whole aspect is that right from how the patients flow and then where actually what is the various steps that they undergo. So that helps us to find out whether, okay, so many patients are coming, why the crowding is taking place. It could be either because of, let us say, reduced counters, or maybe there could be a process of some particular time where there may be where you can try to automate certain aspects. Okay, so basic idea of a flowchart is basically to identify the process, the first thing, and second thing is to ensure and see that if we can redesign the process of how it is, so that we can attain a form of, let us say, effectiveness or efficiency in the system. So these are some of the places where you can actually use a flowchart system, and it can also be used for planning of a project. So what is existing also you can track it in the form of a flowchart. Or another thing is that you want to explain to somebody, or you want to probably design something new. There again, you can try and use a flowchart, so that you will be able to encompass and see that with the flowchart, you will be able to see that certain steps are not missed, and you are going to look at the completeness of the entire flow. Okay, so these are some of the situations where you actually use a flowchart to bring about efficiency. Another tool that can actually be used is a check sheet. Now, before we get into this check sheet, how is a check sheet different from a checklist? Any idea? See, a check sheet and a checklist. Now, a checklist will actually have all the parameters. The observer's intention will be only to see whether a certain parameter has been completed or not, whether it exists or whether it is completed or not. So that is basically a checklist. A checklist will have all the facts that are there, that are supposed to be recorded or documented for a particular process. And only thing is that the observer will have to only ensure that each of these points are available. Whereas when you talk about a check sheet, it is basically you're trying to record. It's a structured, prepared form for collecting and analyzing data. Here, what happens is you collect the data, and based on that data, you will be able to make an interpretation. So that is actually a check sheet. How many, and a check sheet is usually used for what type of in which situations do you use a check sheet? Generally, you use this check sheet to see repeated activities. So when you find that there are certain repeated activities, there in such cases you can use a check sheet, because it only tells, or for example, we say about these studies. So a time and motion study is more of a check sheet, where you will try to, let us say, first aspect is to map the process, okay, and second thing is that you are trying to look at the time or a duration that each process or step, where you can actually divide the process into minute steps or measurable steps, and then the process is repeated, so you will be able to record certain processes, and then you want to try to bring about a change in the let us say duration or other things. So some places where it may take more time, where you want to reduce the time, or maybe any activities wherein you feel that there are certain activities which can be reduced, or the time duration in certain areas can be reduced. So a check sheet can also help in certain areas where you want to find out why the duration at a particular time is taking more. If something like that is happening, what alternatives that we can, what changes we can bring about in that particular area. So most important aspect of checklist is that one is that the process should be repeated activity, and then what happens is that when we collect and interpret, we want to know about the frequency of that particular activity. So if it is more frequently happening, then we want to bring about a change, or we can take some corrective actions in that case. Then we have cause and effect diagram. So I'm sure that all of you would know about this cause and effect diagram, and it is also called as a Ishikawa diagram, or it is also called as a fishbone diagram. Now here, the most important thing is when we talk about this cause and effect, so we want to identify what are the causes, and then how to, and is because of that cause. First aspect is to identify the cause and why this particular cause is having a, and what is the effect of this particular cause. So how we go about it is basically we are trying to see how a particular aspect is impacting the other thing. So there are several examples where you can actually implement the cause and effect diagram, but the most important aspect, see that there is a cause, we have to identify the cause, and then the effect is what actually we usually see in the system. So the effect is something that bothers us, or something where we feel that you have to take an action. So the most important aspect when you want to do a cause and effect diagram is, especially in a hospital situation, you identify what is the problem that is of concern. That is most important. The problem, it should be a burning situation, not a simple, it's no point, you can do a cause and effect diagram for everything, but you have to identify if there are certain things that are something where you have identified the problem, but you are not able to find out how to eliminate the problem, or what are the reasons for this particular problem. So once you identify the problem, the next thing is to define the process or the issue to be examined. So that will be, but let's say, for example, I'll give you, I will not take the hospital situation. Let us say, okay, let's assume that students are constantly coming late for classes. Okay, I'm just giving you this particular an example. If students are constantly coming late for the class and the teacher is getting delayed to take the class, I'm just giving this. Now, what could be, see, the whole problem is that why it becomes a burning problem is because attendance may be a small. When you have less attendance and then you have to over and over again do the same topics, that could be a problem. So in order to overcome the problem, you have to identify and see why students are not coming on time for the class. Now, if that is a burning problem, now you have to define the process, why that has, what are the cause behind this. So the situation may be multiple. There may be students who are day scholars, there may be students who are in the hostel, whatever it is. So identify the cause why they are coming late. And if they are coming from a distant place, maybe they have to travel all the way. So that could be a problem. So another aspect is that maybe few students are not, another aspect is that, okay, they do not know that there is a particular class that is going to happen at that point in time. Or maybe some of them are habitually getting up late. So these are some of the things that can actually, I'm trying to say, we are identifying various problems or various, we are identifying various causes for addressing a particular problem. So in such instances, you use this cause and effect diagram. And this particular thing of identifying the various causes and other things can be done only through a brainstorming session. Okay, so there is a problem. Now, to overcome that problem, what could be the possible reasons for that particular problem and how to address those issues? So both these aspects should be done through a brainstorming session. So when we have after having a brainstorming session, then the next step is to discuss the possible causes and group them into categories. So broadly, what happens is you will be able to identify and group that activities. Similar problems can be grouped under one activity. So like that, we have to categorize them. For example, if I have to take a healthcare situation in this particular thing, now let's say the number of there is a delay in the receiving of samples, receiving of test reports in the hospital. Now what happens, that becomes a serious problem. So you want to identify how we can actually resolve this problem. So what could be the problem? So again, what happens is when you see the problem, maybe the sample collected is not sufficient or the sample is not collected properly. Then that is one. Then the second thing is maybe there is a delay in moving the samples from the site of collection to the processing place, that is to the labs. Another aspect is maybe there is a problem with the lab itself. There are certain features of the lab aspect that are actually creating a delay in the reporting mechanism. So when we identify all these things, we can classify them as, let us say, some are process related, some are equipment or machine related, some are people related. So all these aspects can be a delay in the reporting mechanism. So when we identify after a proper brainstorm session, and then what happens is you can try to identify these, which are all the situations cannot be addressed. Means I'm telling, when you have a problem and you have identified the causes, all the causes cannot be addressed. But then at least what happens is we can see that few of those causes which are there can be addressed so as to bring about a change, so that the problem to a great extent is resolved. This is one step of how you can bring about an improvement in the process or trying to resolve the problem, so that there is an improvement in the quality of service. Okay, so this is an example that they can give for the cause and effect diagram. So once you identify all the causes, you put it up in a form of a fishbone that I had. It's almost like this. The fishbone represented with something similar to this. So you have identified the problem, and then you have identified the various causes. Now each of these causes could have a sub cause also. So that is, you can go into much more detail. You can see that, okay, if there is a problem, is there a secondary, this problem has arisen secondary to what else? So there could be a sub problem. So whatever can be addressed should be addressed at this level so as to bring about some improvement in the system. So this is the cause and effect diagram where you can use. Then another tool that is available that we can commonly use is the Pareto chart. Now Pareto chart is actually used, Pareto chart is developed, and actually it is used because of the Pareto principle. Now Pareto principle basically tells that 20% of the problems lies with 80% of the causes are basically creating 20% of the problems. Okay, so it's basically that 80-20 principle. Now what happens is that it says that if you can address 20% of the causes, then 80% of your problems will be resolved. That's what it says. So when there's a problem situation, the problem can be because of multiple factors. So which factor actually to address and how do I address? So that is the whole thing. The Pareto chart helps to bring about, to identify those 20% of the problems. By addressing, you can't address the problem 100%. You can't take it head on. So what you will do is that you are going to address only 20% of the problem, which is actually which will help you. Sorry, you are going to address 20% of the causes, which will help you to address 80% of your problems. Okay, so that is where this Pareto principle or Pareto chart can be applicable. And this Pareto principle was first used by Wilfred Pareto. I'm sure that all of you will know about the background of this. Wilfred Pareto was an Italian economist, and he was primarily he was concerned to see why there is so much of divide between the rich and the poor. So then after that, he tried to understand, analyze the situation, why there is so much of divide. So he kept one aspect of it was to look into the, after he did his research, he found that there is 20% of the wealth that was accumulated with 20% of the wealth distributed with 80% of the population, and 80% of the wealth was concentrated in 20% of the population. So that's why he found that there are few families or few people who were very rich, and there were few people who were extremely poor. So there was a wide gap. So that's why he proposed this 80-20 principle. And that 80-20 principle that he had proposed at that point of time was later adopted into the industry, and then it has undergone certain changes. So in the quality scenario also, when we find that there are a lot of problems, then we will say that by addressing 20% of the causes, by addressing only 25, because you cannot address all the 100%, as I told you in the previous slides. So by addressing only 20% of the causes, 80% of your problems can get resolved. Okay, so again here, by Pareto chart, by putting, it will help you to analyze and put things like, which is the most, according to the number of frequencies, which is the most situation that is problematic, which needs to be addressed first, and which needs can be which can be taken at a later time. So that is how it is. When you look at this, I think you can see this chart below. Up to the frequency has been put, and then you are trying to look at, let us say, only the first two parameters. If you address, that means almost 80% of your 80% of your problems are getting resolved. So this is basically the Pareto chart that can be used. And where can it be used, especially in our hospital situation? Again, the same thing. When you look at the causes, there are multiple causes. You will find, when you identify, there are multiple causes. Now you want to find out which cause is which factor is more frequent than the others. So you again look at the frequency part and see those factors which are more. Then you know where to start from. I'll give you a simple example in this Pareto chart. Now, let us say, for example, we had this medical records audit process going on. So when you look at the medical record audit process, an incomplete record, as far as what you know, is that there are several parameters which will always be missing. Okay. So now, when you just audit a few records, you will come to find out that there are history sheet is missing, or doctor's order sheet is not properly dated, timed, and signed. These are some of the things that I'm trying to look at. Or maybe you find that there's a missing consent form, or there is something like this. So these are some of the parameters that you are actually, after auditing a medical record file, you may identify these things. So when you look at it at the start, you don't know how to go about it, and because what happens is a multiple cause. All that we know is that, yes, as far as the medical record is concerned, it is incomplete. But how to make it complete, where to start, could be a problem. So then you have to identify that which is the factor that can actually be addressed, or how to address the factors that is glaringly seen in all the files. Those things have to be taken first. But there is also another method. You can also see that, or maybe another way of looking at it is, in fact, even before going into Pareto chart, you will have to address those which are mandated. Okay, it is something that is very essentially needs to be documented, or something that comes in the way of, let us say, illegal. It is something that is illegal. So everything should comply to the statutory, or those features that should comply with the statutory requirements have to be applied to. So in such cases, you can start with that. And once, let us say, those statutory requirements are all addressed, then you don't know how, from where to start. Then you apply the Pareto chart and see, okay, one by one, I will try to address. So you try to take corrective steps based on, let us say, which is more important. Okay. Now, let us say, for example, if people are not putting their date and time and other things, may not be as compared to having the consent form in a medical document. The issue is to address all the statutory requirements, and subsequently what you do is that you look at the other parameters. So this is what I was trying to tell you, analyzing data about the frequency of problems in a process. And when there are many problems or causes, you want to focus on the most significant. So that's how you develop this Pareto chart and analyzing the broad causes for looking at a specific components. So this is also one way that where you use this Pareto chart, and also when communicating with others about the data. Now what happens is that if, let us say, for example, after doing a particular activity, you want to tell people as to how to, or you're advising people how, where we should put the intervention. So that this Pareto chart also helps you to identify that. That is, you will be identifying that 20% of the 20% of the causes, sorry, 80% of the causes which are addressing your, which will take away their problems. Okay, so that is Pareto chart. And the next is we have histograms. Now in histogram, basically what happens is these are charts that group numerical data into bins. So here, when you look at a histogram chart, it will basically be a continuous, continuous bar graph, let us say, and it will help you to tell about the distribution of a data set, how well it is distributed. Now, generally, histogram, where can we identify or where can we adopt the histogram part in a hospital situation? If you look at our outpatient department, the number of footfalls that come into the outpatient department, you want to identify, there may be, what happens is on all the days you won't have an equal number of people coming through for the hospital visit or visiting your outpatient department. There may be days where there is high numbers, more numbers, and then there may be days when there is less. So what happens is, by trying to either classify the day, the footfalls, and let us say, like say Monday, Tuesday, Wednesday, either that way, or an alternate thing is that you want to identify in a day also during which time the footfalls are more. So you can try to identify you by classifying as which range or when the number of patients are more in number. So by trying to identify these things, you will be able to plot a graph, and then by taking the help of that graph, you will identify as to which day there may be more number of footfalls, or which time in a day where there are more number of footfalls. By trying to develop a histogram, it gives you a rough idea. Okay, over several weeks, let us say, it gives you a rough idea as to say how I can redistribute my facilities, healthcare facilities. Like, let us say, on crowded days, I will put in more people. On less crowded days, I don't want. I want to ensure that these people are used better, are more optimally used elsewhere. Or same thing is that during the day, if in case the crowd is during a particular duration of time, I will add additional facilities and additional manpower to ensure that outcome, let's say, to enhance the service levels of the patient. So these are some of the decisions that can be taken based on, let us say, your histogram. Same activity, same histogram can be used. One aspect I told you is in outpatient department. Anywhere else that you can think of using a histogram? Okay, I'm not able to see the chat box. Okay, let me continue. So the most important aspect is, but one thing is that when to use the histogram is also important. Now, in order to use the histogram, you cannot observe a process. Okay, so the data should be a quantifiable data. It should be in numbers. Okay, you have to make it in numbers. Otherwise, you cannot use histogram. So most, as I told you, we talked about the as I told you, we talked about the footfalls. So similarly, what happens is, in any place, you can also look, let us say, how particular in the pharmacy or in your stores department, how the stocks are being reordered. There also you can use a histogram to ensure and see how you can redistribute your stocks. Let us say your ordering levels or maybe your period of orders and other things can be changed. The next is the control charts. Okay, so control charts again are what can be used is when you need to know when you talk about a control chart, it is basically SQC, statistical quality control charts. So you have a particular acceptable level of quality. Okay, that is the what is expected, and then what is the available variation that can be. So that is what has to be defined, and then based on that you design. You see how your processes whether they comply to the expected standards or what is the level of deviation. Now, if there is a level of deviation, and what is the accepted level of deviation. So this is what can where you get your control charts. I'll give you a simple example for this. Now, let us say if you feel that a particular patient has to be seen within the waiting time, let us say in any of the place, either for the consultation checkup or maybe for the pharmacy. If the waiting time is what is expected is around 15 minutes is your consultation time for waiting or maybe for the pharmacy. Now, when you make a study, you can find out how much the variation will be. So if there is a variation, what you can do is that your upper control and lower control maybe plus and minus 2 minutes or 5 minutes, something like that you can keep. So the maximum available or allowable waiting time is 20 minutes, and maybe so the range can be from 10 to 20 minutes. Now all the other things, if you find that the observations, when your observations are all falling outside the range, now this control chart will help you to bring about changes so that you try to bring in all those observations have to come within that range. So that is the use of control charts. So you have an acceptable level of what is acceptable level, and then you give a little bit of variation plus and minus, and then all your observations have to come within that. Okay. Now again, you have when you are trying to look at, if one is univariate control data. The example that I gave you now was for a univariate control data, wherein you have to just look at one particular characteristic or process, and then you are trying to manage it. Now, if you are trying to identify two, then it becomes a multivariate control data. Okay, if you are trying to, because there may be two processes that are related to each other. So you are trying to, it's not just one process, but then you are also taking the other factor also into consideration. So in such cases also you can, it's a multivariate control data. So there also you can make use of these control charts. So when to use, to differentiate between special cause and common cause variations. Okay. To assess effectiveness of changes, again you can use, you have brought about a change, and then you are going to see whether, now the first step is to have a baseline data, and then second step is bring about a change and see whether these changes are effective. Then also to communicate, so monitoring basically. Then in preliminary research of formulation studies. Now this particular thing is given, especially when there is, it's got nothing to do with quality as such, but yes, it is got to do with quality of, let us say, your quality between two drug interventions. Okay, which drug is better than the other? So primarily you can see that there are two formulations. So you can use this particular control chart to find out which drug has got a better efficiency over the other. So there also we can use the quality control chart. And the percentage of defects in the parental products. So that's what I was telling. So once you understand the defects are there, you can bring about the changes and try to bring in or bring most of those, reduce the defects by trying to bring all the things into the compliance range of the upper control limit and the lower control limit. As part of this thing, there's a Six Sigma concept also. Many a time we see that Six Sigma is a concept. So this is a statistical concept that represents the variation present in the process related to the customer requirements or specifications. So when you want to, the difference between this control chart and Six Sigma is, in Six Sigma, what happens is that you are trying to reduce the number of defects to that extent that it is acceptable. So see, to a level of 6. Okay, so most important steps in Six Sigma process is that, again, it's the same thing, very similar to what you have in your cause and effect diagram. You have to define the problem. Okay, so most important thing, the same concept comes here. First aspect is that you have to define the problem. Now, once you have defined the problem, you have to measure it. Okay, now here what happens is we are not looking at the cause for the problem. We have identified the problem. So you have defined the problem, you have identified the problem, and then you have to measure the problem. Okay, and once you measure the problem, that means to say you have identified what are the reasons for this problem. For this policy, how I can bring about a change. So analysis. Then you bring about improvement. I think one of them has, please mute yourself. Okay, so this Six Sigma methodology, it basically helps you to identify a problem, measure that problem, analyze, bring about a change, and then what
Sorry
happens
to
is,
interrupt. Ms. Naufa, please mute yourself. Okay, so you can continue.
so in the Six Sigma methodology, the first aspect is to define the problem, and then after that you measure the problem, see the intensity of that, and then you analyze how you can bring about a change. A simple example that a Six Sigma methodology generally followed is, let us say, the same thing they can use even a medical records department, where you want to bring down the number of non-compliances in the medical records, or alternatively, I think places are again in the billing or registration process. You want to ensure and see that there is no delay. Another place where you can use the Six Sigma is, again, talk about the labs facility, the lab tests and other things, wherein you want to reduce the turnaround time. So that is the thing that you have to identify. Let us say where you want to bring about a change. If it is on the turnaround time, I'm just give an example. So you find out what should be your turnaround time. You define the process, what is happening, and why there is a delay in the turnaround time. Then you measure. When you identify the process, then you will have to measure. See here, actually, what in this Six Sigma part, I'm using all the tools. And the first step, when I'm going to define this problem, I'm going to map the entire workflow. I want to find out how the process, the flow of, let's say, right from collection, after collection till I get the results, what all activities take place. I don't know. So I have to identify it with the help of a workflow. Then I also time it, okay, to find out time is taking for each of this activity that is taking place. I will also see if I can reduce any of the process times, or if there is any unproductive step that is taking place. Then I try to reduce those things. So that is where I do the analysis of those aspects. And then what I do is I try to bring about a change. Now, let us say I want to see that, okay, manually the blood is collected and how it is transported to the lab, and then in the lab it is processed. Now, can I bring about some change in this entire system so that I can bring about an improvement? It could be either, let us say, the transportation problem. So can I bring about a change in how the way the samples are transported so that it becomes time is much less? Or maybe let's talk about the machines. So the processing time. Can I bring lab services? If you generally say there is something called as pre-analytical, analytical, and post-analytical. So there could be a problem in the pre-analytical phase. So I will try to look at all the problems in the pre-analytical phase also. The analytical phase, if there is some problem, then I try to address those issues. And even after that, whether there is a change, whether there is a delay. I'll give you a simple example. Now, there could be a delay in transporting the samples from the site of collection to the lab. So now what happens is I can think of various mechanisms. Either I can increase the number of runners, frequency of which the samples are moved, or I can adopt technology to move the items. So that is one. And the second thing is that when I talk about processing at the lab, it could be a manual or you can have automated. So now what happens is everything is, there is a little bit, once the entire the machine is capable of generating the result. And once the result is coming, I will also try to bring in, I can bring about a change there also to ensure and see that the results are automatically read. So what I'm trying to bring about is like, I'm trying to help in trying to establish an alliance. Now, whenever you talk about a improvement system, it could be minor, it could be small changes, or it could even result in, using technology and other things which are, cost intensive. So it again depends, but all at the same, my only aim at this time is to bring about a change and bring about an improvement in the process. And once that improvement has taken place, I don't leave at that. I also have to bring about control mechanisms. So what I do is I also have a what I do is I bring about and I frame the control mechanism so that there should not be a change. It's not just I do one particular change and it has improved. How to sustain the change is also very important. So in this Six Sigma methodology, we look at even sustaining the change. So in short, it is that DMAIC. Now the next tool that can be used is a scatter chart. It is also called as a scatter plot. Okay. So now in a scattered plot or scattered chart, now what happens is it is a display of values for typically two variables. So here in a scattered chart, you are trying to bring about a relationship between two situations. So you are only going to study the relation, how one particular intervention is related to the other. Okay, so here you can either have a positive correlation, you can have a negative correlation, or two things may be totally different, and there may be no relationship between two aspects. So two interventions. So that's where the scattered chart can be. Now scattered chart can where it can be used. Now, where totally different, and there may be no relation. I can use the scatter chart is basically when we are trying to measure or trying to take a decision between two different interventions. Now, if they are related to each other, then what happens is there could be a positive correlation which shows an upward trend, or it could have a negative correlation. Sometimes, if there is no relation, then what happens is that when you see the scattered plot, it will have a wide dispersion. Okay, that means these two factors are not related to each other. If they are very closely represented, then what happens is there is a relationship. Now, whether it will have a positive relationship or a negative relationship depends upon whether you have an upward running chart or a downward running chart. Okay. So this is another one for a scattered chart. So all these relation chart are various tools. Now, as I told you, these are just the basic tools that are available. Now, in order to bring about a quality improvement, we can use either a single tool or multiple tools in various situations, depending upon where these tools can be used. As I told you, some of them are quantifiable data, some of them are observable data. So, depending upon the situation, we can use these tools to bring about changes in the quality of any system. Okay. So now let's say some insights from healthcare industry. As I was telling you, to bring about changes, administrative services, we can use this, like we can use the monitoring of discharge process. So when your discharge process becomes too much, so then you understand the process, you try to identify, you apply various methods. Okay. You can also find out, you can put a gap analysis. You can make a gap analysis, that is a cause and effect. You can use that part of the tool, or you can also use a Six Sigma process to bring about variation in the timing of discharge process. Okay. Another aspect is the patient waiting time. So the patient waiting time, again, here you can also adopt for the patient waiting time. You can also adopt the workflow part, so that you can time each of those activities and see where exactly the sum total of the waiting time, and where you can bring about a change to reduce the patient waiting time. Okay, we can't make it zero, but then at the same time, you can ensure that you can at least improvise the, bring down the waiting time. And as I tell you about the footfalls in the OPD also. Now, in clinical services, yes, operation theater utilization rate. So here again, you can use any of these tools, or OT cancellation rate. What is the cause for acquired infection rates? Now, when we talk about hospital acquired infection rates, there are certain parameters that we monitor to come out with the hospital infection rate. But if we want to find out about any relationship between those things, okay, so there again, you can use a scatter plot to find out that if there is any relationship between these factors which are contributing to the hospital acquired infection rate. Then for lab and diagnostics, where you can use LIS implementation and turnaround time identification. Okay, we can make use of these tools. So to find out what is the TAT, and then also to later how to control or reduce the TAT process. So I'm open to questions.
Hello, sir.
Yes. Yeah, go ahead, please.
Yes, sir. It seems like we don't have any questions in the chat box. We don't find any questions there. So participants, if you have any queries, you can just type your queries in the chat
no
box.
problem. Any questions?
Okay, sir. So thank you, sir, for your very informative session. And I think there is no questions from the delegates, sir.
Okay.
Okay.
Thank you, ma'am. Thank you for the opportunity.
Thank you, sir. I repeat, now the participants can take a break for 5 minutes and you can be back by 11:05. And please stay online. Once again, welcome back everyone. We appreciate you for being with us. Here we have our next session on the quality indicators for best practice in nursing. We are lucky to have with us the most appropriate person to handle this topic. It is none other than Dr. Lada Mandal. I invite Ms. Alfian Jose to add more about Dr. Lada Mandal.
Lieutenant Colonel Lata Mandal has completed her doctoral study as a full-time research scholar under a fellowship program of Sri Ramachandra Institute of Higher Education and Research, Chennai. Her research project on holistic patient care was funded by the Department of Science and Technology, Government of India. After serving in the military nursing service for almost 2 decades in the role of a clinical nurse and nurse educator, she took voluntary retirement from armed forces to devote herself completely in academics. Since then, she taught as visiting faculty at National Institute of Orthopedically Handicapped while immersing herself in research and other academic activities. She has a number of projects and publications to her credit. At present, she is a member of the Executive Committee of the Nursing Research Society of India. She sees her role as a nursing educator and motivator and dreams of establishing a research academy for nurses in near future. We welcome you, ma'am, and over to you.
Good morning, delegates.
Good morning. Welcome to the conference, Leda.
Madam, thank you so much. Good morning, Madam Asuma. Good morning, delegates, and good morning, the organizing committee. I must thank you for entrusting me with the responsibility of discussing the topic of quality indicators. I'll just go into sharing screen and is it visible to everybody?
Yes, ma'am.
And
Yes,
am I audible, clear?
Yes, ma'am. Clear, ma'am.
Okay, thank you. With your permission, I start. When I was deliberating on this topic of quality indicators for best nursing practice, I was reminded of an event in my life when I was a student nurse at College of Nursing, Armed Forces Medical College, Pune. We were not called student nurses, we were called nursing cadets. And nursing cadets, we were taught the art and science of nursing by one of a very renowned teacher in armed forces. Everybody knows her. She was Madam Lindo. She used to teach us nursing. And then what happened after we learned some part of it, we were sent to the wards in the clinical field when we were rendering patient care. And she was always beside us, always in front of us. And we were aware of the quality of our work by her facial expression. One nod, one frown, and one smile, everything told us whether what quality we are doing. So I'm just reminded because, I wish that type of quality indicator is present in front of us all the time when we are giving care. But sadly, that's not possible, I know. So I start with the topic. Quality indicators, this field in healthcare and in nursing has been growing considerably in the past few decades. And it has attracted the growing interest of professionals like us, policymakers, the general public, and researchers. Obviously, quality of care, especially in nursing, is a very difficult concept to measure directly because I think it is a theoretical concept which can encompass different meaning for different people. Like when I am rendering care to a patient, what I perceive as a quality care may be perceived quite differently by the patient who is receiving the care. Moreover, this quality of care, it differs with the context of measurement. For example, if you see in an acute care settings, if we are rendering care, it can be the quality of that care can be easily measured by maybe the rate of nosocomial infection of the patient or the incidence of pressure sores. But think of another setting when you are a public health nurse. Now you are not giving care in that way. You are giving preventive care to the people, and you want to prevent tuberculosis in a particular area. Now, what is the outcome criteria? You cannot measure mortality rate of people with tuberculosis. So the context changes and the measurement changes and the quality indicators changes. So it is a very dynamic concept. And I think with that only, the indicators of quality of care, we are trying to make a sensible meaning out of it by defining it as a quantitative measures that provide information about the effectiveness, safety, and patient-centeredness of nursing care. I will draw your attention to few things in this definition. One is quantitative measure. This is important. It is a numeric, or you can say it is something which you can easily objectify, you can easily measure. And the three words which I have put in bold are the effectiveness, safety, and patient-centeredness. Now, if you see, nursing care is something which is a very huge, I understand it in a holistic concept. So there are so many dimensions in that, but what all nurses all over the world and the healthcare per se have decided and have come to the consensus that these are the three dimensions in which we are going to measure the quality of care by using certain indicators. That is, how effective is the care, and how safe it is for the patient, and how it is patient-oriented or patient-centeredness. Now, in line with this, once we know about these indicators, the meaning of it, let us understand the different purposes with which we use quality indicators. Now, mainly, I understand there are mainly two purposes, but for me, the first one should be quality improvement purpose. And I think you will agree, all nurses, all professional nurses, be a nurse leader or a nurse practitioner, everybody will agree with me that the main purpose of using quality indicators is for improving ourselves. And the second reason, which is very important nowadays, because we have accreditation agencies here. So this is for quality assurance, where we are going for external accountability of our quality and for verification. In this case, what we are trying to do, we are using quality indicators to assure the public, the government, the policymakers that, see, we are having a sufficient level of quality. So these are the two purposes with which we use quality indicators. Certain organizations will be using with both purpose in mind. And I think that is quite a wise decision. Now, let's get into the historical milestones of quality indicators. I think you will find it interesting. Let's see the history. If we look into this and we try to understand how the concept of quality indicators in healthcare and in nursing per se have evolved over time, we have to start with a nurse. And she is none other than Miss Florence Nightingale. I think all of us are aware that in 1854, when the British troops were miserably dying in the Battle of Crimea, where the British troops were trying to push back, push back the Russians from the Turkish territories, they were dying not because of the battle. They were dying in hordes, mainly because of the infection, cholera, diarrhea, and all sorts of problems. And the British government had sent Miss Florence Nightingale and a group of nurses to take care of these people, of these British troops in the hospital of Scutari. And what followed is known to all of you. It's history. And I am not going to say what specific nursing interventions she or her nurses did. But most importantly, she documented the reduction of mortality from 42.7% before nursing interventions to the reduction to 2.2% after they have started giving the interventions. Now, that was, I think, one of the first attempt to use quality indicator to reflect the quality of what we are doing, nurses. If you see, after that, there were many attempts all across the world to indicate quality in nursing and healthcare, but prior to 1970s, the history you find is quite fragmented. The attempts were sporadic here and there. What happened 1970s onwards was that efforts to measure quality became more streamlined. And in this, we find that nurses all over the world, they started taking lead in measuring nursing care quality. I will come into the Indian scenario because here we are practicing in India. If you look at our National Health Policy 2017, the buzzword is quality care. If you remember the Prime Minister's speech at that time, he was mentioning that the government, they were trying to urge the healthcare sector to promise, to assure to all stakeholders, I mean all citizens of India, that they will be given quality care. And I think that's a very, very important thing which has rolled the stone. It has, it has given tremendous speed and momentum to quality improvement efforts in our country. And therefore, I think it is no doubt, and it is not a surprise that we all are sitting here today in this conference. We are discussing quality improvement. We are discussing quality indicators for nursing. So now that we have seen the historical milestones, let us get into different classification, the classification of quality indicators of nursing care. Now, there are many options for classifying quality indicators. However, I will be focusing on the most frequently used framework for distinguishing between different types of quality indicators, and that is the Donabedian classification of structure, process, and outcome indicators. So let us start with this structure indicators. Structure indicators are actually trying to indicate the quality by giving the indication that the environment within which where the nurses are functioning is good enough. We have many structural indicators. We all are aware of them, like adequacy of staff, adequacy of facilities, infrastructure, equipment, medicines, the mixed skill level of staff, the existing policies in the hospitals, the the established communication chain between the nurses and other healthcare providers, then the teamwork within which the nurses are functioning, or the ethical environment and the ethical constraints that the nurses face. These all are indicators, which are structure indicators for quality nursing care. If you look at the structural indicators, you will find that something is really advantageous. Like, they are very, very evident. They are in front of you. They are easily reportable. They are easy to observe, and they're comparatively stable. Isn't it? Like the structure of a hospital or the infrastructure or maybe the policies, they don't change every day. They are there, you can measure them. So it is easy in that way. But of course, there are weaknesses to structure indicators. And one weakness is the link of structure indicators with nursing care quality. Now, I hope you are understanding this. Researchers have tried to prove this link, that there is a link between structure indicators and nursing care quality, and they have established link. But somehow, if you go through the literature, you will find the link is not very strong. Second is, it is subjective to bias. Bias meaning there can be always a chance of over-reporting of resources. You all are aware this happens, especially when we have external accreditation agencies, and the attempt is to make to show an ideal condition. We try to over-report things. So this is a small weakness in structure indicators. Basically, structure indicators are nothing but they're trying to show the power of the nurse, of the nursing faculty or the nursing staff. It is like, 26th January parade, where we try to show how India is powerful in military way. We show our tanks, and you see so many fighter aircraft, such smart soldiers. So we are trying to tell the world that if you come and have a war with us, we are going to have a quality war. Similarly, the structural indicators try to tell, yes, this is the quality of nursing care we are capable of giving. I move on to the other two, and I will jump into the outcome indicators because process indicators I want to discuss after a while. It's very close to my heart. So if you go into outcome indicators, which are used for quality of, to measure quality of nursing care, you will find basically they are trying to inform us whether nursing care is good enough to keep your patient safe and healthy, whether they will be alive and they will be safe and healthy after your nursing care or not. There are a lot of them which are present, you all know, like, patient fall, the number of patient fall, the pressure source which occurs, the mortality rate, readmission, deep vein thrombosis incidences, patient satisfaction, a battery of patient satisfaction, satisfaction with the nursing care in general, satisfaction with the nurses' management of their pain, the nurses' communication. There are so many. So these outcome indicators you will be finding, which are very much in existence and in use by different hospitals and organizations. They are also known as nurse sensitive indicators. This is a new term which has come, not very new. It has come the end of, around about 1996, this term has come, which are sensitive indicators, and these are part of the outcome indicators. There are many more. I have not mentioned them. Now, if you look into these outcome indicators, you will find advantages are there, definitely. They, they draw the attention of everybody towards the patient. It is the patient and whom we are giving nursing care. So that is one advantage. Second is, it is resistant to manipulation. Like, a patient fall has occurred. It has already happened. You cannot manipulate it, like sometimes structural indicators are manipulated. And third is, it is very meaningful to policymakers. It's in concrete terms. It is also very meaningful for patients also. So these are, certain advantages. Of course, there are disadvantages as well. These outcome indicators get easily influenced by other factors which are not in control of nurses. Like, for example, one outcome indicator is nosocomial infection. Now, nosocomial infection is influenced by nursing care. It can be influenced by many other variables. We all understand. So this is one thing which is a weakness. Second is, it takes a long time to measure outcome indicators, like, a certain period, maybe annually, maybe half yearly or quarterly. And third is, it requires a large number to show any statistical significance. You cannot use one or two incidents of patient fall and make some meaning out of it. It requires a large number. And most importantly, although outcome indicators are considered as very strong indicators of quality of nursing care, but they are retrospective. By retrospective, I mean they have occurred. We are seeing it. See the irony of it. You are trying to measure the quality of nursing care through outcome indicators, which have already occurred. You have no real time. It's already occurred and now you are seeing. So that's a weakness which is very much evident in outcome indicators. I am not going to tell you how to measure outcome indicators because all of you are aware of it. It can be either rate-based or it can be count-based. Rate-based, like, number of people who got pressure sores divided by the number of patients who were prone to get pressure sore. So you get a rate. Or it can be count-based, the number of patients who had a fall. Okay, so in that way. But what I want to highlight is that nursing administrators should be aware that these outcome indicators may be influenced by many factors outside the control of the nursing staff, and therefore should be very judicious and conservative in using them. I'm trying to mean that when the healthcare administrators, the hospital administrators as such is trying to hand over to the nursing leaders as, see, these are the outcome indicators which are nurse sensitive. You have to see the context, the setting, whether they are really applicable to your setup or not, and then can be used. So this is one point in outcome indicators. I hope I'm not very fast. I don't know. So I move on to process indicators of nursing care quality. And this is something, I should say that these are underrepresented in nursing. These process indicators, we don't have many. They generally are trying to measure the nurses' adherence to clinical guidelines or safety checklist. For example, in the critical care, we have a safety checklist for nurses to check when the patients are in ventilator, for example. So whether they're adhering to it or not. Now, this is something, which is difficult at times, because if you need to observe, and there are tools which can be used for observing the nursing care process, but they are not very cost effective. You require a senior nurse to observe the nursing care using a huge long checklist, and it counts on your time it takes. And moreover, you get biased when a nurse knows that she's being observed by somebody, they're watching your nursing care, you tend to have a change in behavior. So there's not many which are there. Of course, there are few, like monitor is one tool which is used as a process indicator. But I will take this opportunity today, which is given to me, to introduce a new process indicator of nursing care quality, and we call it unfinished nursing care. This is a new concept because it is new to India, but of course not new to the world. Since quite a few years, nurses all around the world are trying to establish this as a process indicator for measuring nursing care quality. I will just take this time to get your attention to this particular indicator. Let's define it first. It is any aspect of required patient care that is omitted or delayed by nurses. It's quite obvious, right? Now, in this time, I will just tell you a small little, why this unfinished nursing care came to my attention, my personal thing, I'll say. First of all, I was a critical care nurse for many years. Nearly 15 years I have spent in critical care. And we had a very good critical care team, and we got many awards. We got many times praised for our work. Looking at the outcome indicators, people saw that there are no pressure sores, fine. People saw that there's no DVT, the patients are not getting readmitted, ventilator-associated infections are less. So we were getting a lot of praises. But in the heart of my heart, I was not happy with our quality of nursing care. Why? Because, I think it happens to everybody. At the end of the day, when you are closing your eyes, you are going to sleep, you are thinking, it's all fine. But I could have done something I didn't do. I could have been more courteous to a particular patient, but I was so busy changing position of another. I could have washed my hands properly. Did I really wash my hands really properly when I went to start that central line? So there were, many times it came to my mind. And that what's happening? Somebody is telling from the outcome indicators, they are telling that it is good. But why I am not feeling? But it remained in my heart. What happened was in 2014, I was attending in Singapore, there was a Holistic World Nursing Conference. And, for the first time in that conference, I found a group of nurses from other countries. They were discussing this concept, which I felt that it has come out of my heart, and they're discussing that, yes, that it is a quality indicator. This is not only happening, I'm not imagining, it is actually happening to many people. They are thinking. It was a big reward. And that was the time when I started focusing on this unfinished nursing care, how it can be used as a process indicator. And it was my doctoral thesis topic as well. So I just shared this small little experience which I felt. Now, unfinished nursing care, to understand it better, you have to understand how it has evolved, the temporal evolution of the concept, how it has happened. Before 2001, nobody spoke of this. What happened was in 2000, there was a very large hospital-based study, which was a collaborative study between US, Europe, many European countries. They were trying to see the patient outcome. And in that study, when they published the first paper in 2001 by ICANN, they found that there is a phenomena among the nurses which is influencing the patient outcome. And they gave this term care left undone. And that was the first time people started hearing about it. In 2004, this terminology unfinished care started coming in nursing literature. But in 2006, this concept was studied in its entirety. And this concept can be used as a process indicator for measuring quality of nursing care was done by an American nurse. She studied the whole thing from different approach, from qualitative, from quantitative, and she coined the term missed nursing care. Around about the same time in Europe, there was another group of nurses who were working on the same concept. They didn't call it missed nursing care. They gave a name called rationing of nursing care. Like, you know, how we give ration, the government gives ration, na? Little. Like we are not able to give full all the rice they require. We are giving little portion, we are withholding some portion. So they called it rationing of nursing care. The same concept in 2009, it came in literature as a term called prioritized care. And this was given by the Scandinavian nurses, mainly from Sweden. They say that prioritization is always happening in nursing. And I'm sure all of you will agree that all of us have heard or hearing do prioritization, then only you can give proper nursing care. I do agree. Prioritization, that is giving precedence to certain activities over others, is a very good strategy for disaster situation, for emergency situation. But think, if you are doing prioritized nursing care day after day for each and every patient, what is going to happen? You are going to miss certain activities which are essential, but you are not able to do. So this was another term which was there. And then in 2014, there was a first systematic review which was published in this. I have done a systematic review on the same concept. It came out in 2020, and we have an international consortium who are working on researches on unfinished care concept and how this can be used as a process indicator for measuring quality of nursing care. So that was all about temporal evolution. Now, many of you must be thinking that, okay, you are telling, the speaker is telling about unfinished care and quality of care. Use it as a process indicator. But why should you accept what I am telling? So let's give some evidence to it. There are few evidence, but I'm bringing just two of it. One is research done quite a long time back in 2004. If you look at this table, you will find that in this, they are calling it as tasks undone. They are not calling it as unfinished care. They have used the word task undone. And that task undone is correlated with quality of care. See the correlation coefficient, it is 0.634 and it is significant. It shows a strong relationship with quality and the number of tasks which were unfinished by nurses. I have another evidence for you. It was a study done by these authors. Out of this, the first author, Ball J.E., he is one of the most prominent researcher in this field. This is 2014 publication. In this also, what they have done is they have made the patients to rate the quality of nursing care. And they have graded it into 4 grades: poor, fair, good, and excellent nursing care. And they have made the nurses to score their unfinished care. And if you look at this table, you will find that the more the mean missed nursing care score, the rating of the patients are poor. So, and this is, the correlation is significant. The relationship is significant. So these are the two evidence which I'm trying to give you and try to make you agree with me that unfinished care can be used as a process indicator to measure nursing care quality. Now, the question comes, how to use the indicator of unfinished care? I mean, it is a self-report indicator. You have to say it yourself. The nurses have to report it. Now, it can be done by different ways. We have 3 main types of tool or instrument. One is called the MISCARE self-report questionnaire, which has got 21 items, and the nurses are told to indicate in frequency how much they have missed the frequency of missing the activities like individual needs of patients, discharge planning, education, basic nursing care like mouth care, bathing, then regular how they're assessing the patients, and also the reasons for missing the activities. They are supposed to indicate in a 5-point Likert scale where they say give 1 score, meaning that they have never missed it, 2, that they have rarely missed it, 3 is for sometimes they have missed, 4 is they have frequently missed that activity, and 5 is they have always missed. Now, I think many of you are thinking, why should a nurse tell that they have missed this care, isn't it? I think that's a very genuine concern. We will address it afterwards. But before that, let us see 2 more scales or 2 more instruments which can be used as a quality indicator for unfinished care. Another is called BRNCA. BRNCA, I think, is a short form. It's a Switzerland, one nurse researcher from Switzerland has made this. They also have about 20 items, and it is a 3-point Likert scale. And there is another instrument called unfinished care. It has got different names and different versions. One version is having just 5 items, another having 7, another having 10, and another one having 13 items. And the response options are either yes or no. And this also has got good psychometric properties. And these are the main 3 models. Now, if you look at the characteristics of this indicator, this particular indicator, you will see that these are self-reported by nurses. This is not something you are observing or somebody else is telling. It is the nurses who are telling about themselves. It is easy to understand, very simple. The answers also are very simple, like you have to just tick, and it requires a very short duration to answer, and it is available for different clinical settings. We have these questionnaires for pediatrics, for maternity, for emergency, for critical care, for geriatric practice, for community, for everything, and also for different countries have got. We have an Indian version, like I have a Indian version which I've culturally adapted and done all the tests, psychometric tests with Indian data, and they have come to have high psychometric properties. So it is available. This unfinished care indicator is available for different settings in different countries as well. Coming to the decision for choosing quality indicators. Now, how do I decide which quality indicator should I choose? I think that that is dependent on with what purpose you are using it. Like if you use for external accountability and verification purpose, like you are having an accreditation inspection. So in those cases, it is obvious that you will be using either of the structural or outcome indicators or both. And if somebody is doing it for internal purpose, for quality improvement, a nurse leader wants to improve the quality of nursing care, a process indicator is very much important for that. It's a wise decision for nurses to use both these strategies. So all the types of quality indicators can be used when somebody is taking a decision regarding choosing the quality indicators for their own organization. I have not told or discussed about the sources of data for quality indicators. From where do we get this data? One is from administrative records of the hospitals. It's simple. You know, we have hospital admission discharge records, we have OPD records. So we can get a lot of these outcome indicators, structure indicators from these administrative records. We can also use clinical records of patients to understand certain process indicators. We can use survey. Like just now we were discussing the unfinished nursing care. These are survey questionnaire which can be given to the nurses periodically, maybe monthly, maybe 6 monthly. And the data, which is a real-time data, can be collected and used by the nurse managers. And finally, the direct observation. Direct observation is, of course, gold standard as for process indication, but it comes with its own problem of time and resource and bias problem. I'll also take this opportunity to propose a new concept which is coming in healthcare, that is aggregated quality indicators. It is new to the healthcare in India, and it is new for us nurses as well. But yes, we can give a consideration to this. Now, what happens? Why is this aggregated quality indicators are
Excuse me, ma'am.
off?
Sorry to interrupt. Ma'am, we
Yes.
have only 5 more minutes, ma'am.
Okay, I'll finish.
Thank you, ma'am.
Now, you know what happens? These aggregated quality indicators, because of the availability of numerous and different quality indicators, it may make it very difficult for patients and policymakers to make any decisions at times. Moreover, you know, some organizations might use only a few selected quality indicators, although these may not be the most important ones. It happens, you know, many organizations. I've seen an advertisement of a hospital in Kolkata who are trying to show one of their process indicator, that a heart surgery is done only with few inches of cut incision. Now they are using a process indicator, but nowhere they're reflecting in their advertisement about their outcome indicators, how many patients really survive, how many patients are readmitted after that surgery, that they're not doing. So it is like, you know, selectively choosing something. So with these two difficulty in mind, what has happened is aggregate quality indicators are developed for combining different indicators into composite indicators or composite scores. What they do is every indicator is taken into consideration and weightage is given to each one, and then an aggregate composite score is being calculated and presented. It's not within the scope of this presentation that we discuss this, but it is nursing leaders can take this into consideration. If you look at the advantages, there are many. First of all, this aggregate quality indicator, they condense complex indicators into a single indicator. It is easier to interpret. It enables us to understand the progress or the regress of quality over time, how it has improved or it has not improved. And then it reduces the number of indicators without dropping the underlying information, which is the base, and it facilitates communication with the general public. I would conclude with this, that decision to choose quality indicators for nursing should be deliberated upon by nursing leaders before it is being handed over by the hospital administrators. Most of the time it happens that the hospital administrators decide which quality indicators should be used for nursing care, but I think it is very important that the nursing leaders who are present in the hospital should deliberate on this, the context, the measurement, and the settings, and whatever is available, and then only choose it. Secondly, unfinished nursing care, I propose, should be seriously considered as a process indicator by nurses. And quality indicators should be used within an atmosphere of openness and a non-punitive approach. Now, this is the answer to the question which I myself raised, that why should unfinished nursing care be reported by nurses? We are giving the onus of responsibility to nurses. Why? This is because if the nurse leaders acknowledge that this phenomena is occurring and this is affecting nursing care quality, then an atmosphere of openness will come out. I think most of the nurses will be very happy to tell that what they are not able to do, and also give the reasons why they are not able to do. And quality indicators should not be treated as an end to themselves, but rather means to achieve the end. It should not be that, yes, accreditation agencies are asking for quality indicators and we give it to them, but it should be means to achieve the end. And all of us know the end for all of us is quality nursing care for our patients. I have a few references I have put in this out of, I think the reference list is longer than this. And thank you so much for this. And please reach out to me if you have any questions regarding unfinished nursing care as a quality indicator. This is my phone number and email address.
Thank you, ma'am.
Thank you so
Thank you,
much.
ma'am, for your very enlightening session.
I think I'm in time.
Yeah, ma'am, you're completed with the time.
5
Sharp
minutes.
time.
Thank you.
You're completed in time, ma'am. Thank you, ma'am. Any queries from the delegates? Any queries? Okay, ma'am. I think there is no queries. Thank you, ma'am.
Thank you, Leda.
Thank you, ma'am. I hope I made sense.
Yeah, definitely. You did it very well.
Thank you, ma'am.
Next, we move on to the next session on exploring the potential for excellence in healthcare. I request Dr. Asma BBTM to introduce to us Dr. Harish Pillai, one of the illustrious officers.
Good morning, Dr. Harish. Hello, am I audible? Hello, am I
Yes, ma'am.
audible?
Yes, ma'am.
I'm more than happy to introduce Dr. Harish Pillai, the CEO of Metro Specific Holdings, Hospital Holdings of Philippines. He is a doctor with exceptional leadership skills. Presently, he is working as CEO of Metro Pacific Hospital Holdings of Philippines, and he started this career, work in 1st of October 2021. And this is a very, very famous hospital, private hospitals in Philippines, which serves the community for quality healthcare. Dr. Harish Pillai was previously with Astra DM Healthcare India for 8 years. He was the CEO of Astra India since April 2018, a vertical under publicly listed Astra DM Healthcare. Astra India is spread over or across 5 states of India with a network of 14 hospitals with over 3,600 beds, 9 clinics, and a chain of 50 pharmacies, a standalone laboratory diagnostic chain, home care network, and virtual care platform. Dr. Harish was also part of the pre-IPO team of Astra DM Healthcare that led the company to list by the Bombay National Stock Exchange in the month of February 2018. He was earlier the cluster head of Astra DM Healthcare in Kerala and Hyderabad from 2015 that included 5 hospitals. Dr. Harish Pillai had joined Astra DM Healthcare as the CEO of Astra MedCity, an iconic 670-bed greenfield hospital project. And this hospital, he was involved with the green and brownfield hospital projects, hospital operations, quality and brand management, he has played a significant role in the development of healthcare industry in India, Middle East, and North America by setting new benchmarks in quality and patient care. Prior to joining Astra DM Healthcare, Dr. Harish was the CEO of Egypt's biggest private tertiary care hospital, As-Salam International Hospital, Cairo, for 7 years. He has also been instrumental in implementing several high-value healthcare initiatives in Cairo. He also held leadership position in both Belhaul Specialty Hospital, Dubai, UAE, and Apollo Hospitals in India. He is one of the most influential leaders in Indian healthcare industry, and he's a member of Joint Commission of International Standards Advisory Panel, and is closely associated with the Federation of Indian Chambers of Commerce and Industry, Confederation of Indian Industry, Association of Healthcare Providers of India, Nat Health, etc., and a visiting faculty, Tata Institute of Social Sciences, Mumbai, Administrative Staff College of India, Hyderabad, Indian Institute of Management, Bangalore and Calicut, and also he's a visiting faculty for Frankfurt School of Finance and Management, Frankfurt, where he has completed his master's in business administration. And he's basically a doctor from India. He did his MBBS from Bangalore University, and he had a master's degree in hospital management from Osmania University, Hyderabad. And I don't know what else is there. No, so much is there with Dr. Harish Pillai. We are closely associated with him because he was a part of us, and now only he has 2 2021 only he has gone to Philippines. Till that time, Dr. Harish Pillai was associated with Astra DM Healthcare, and he is the editor of our journal also. Not only he has proven his talents in administration in healthcare industry, even in teaching, he is a visiting faculty for many of the, as I have mentioned, many of the important institutions in India and abroad, that is Frankfurt in Germany, where he did his own studies. And I am presenting such a wonderful person, dynamic person. I don't know how many adjectives I have to add on to Dr. Harish, as he is like, I'm presenting to you a truly international Indian to you to talk on the topic.
Dr. Asuma, I think you've spoken enough about me. Thank you. Thank you so much.
I don't know how I have to tell about you, because that much is there with you. And
always know that you can take a person out of Kozhikode, but I'm always with you and your students. I had the great pleasure of coming to the institution, the College of Nursing, and interacting with your faculty and your students. So I always consider myself as part of the family. So I'm not a stranger to the system. Yeah. Thank you so much to the College of Nursing, to you specifically for inviting me for the session. If I may just request the organizers to allow me to permit sharing. Yeah, thank you. So I have been given a complex topic to speak about. Basically, it's to do with excellence. Now, excellence is such a broad topic in healthcare in itself, and whichever country in the world I go to, nursing continues to be in my heart, because I'm very fond of saying that my grandmother, I hail from Trivandrum. My mother's mother was actually a nurse. I think that obviously at that time we had the Maharaja of Travancore, and the British Raj was there. So yeah, that is, I guess, in a personal testament, it is there. And my mother always used, I was born and brought up in Kolkata. I was born in a government hospital in Calcutta. So Amma, my mother, always says that you were delivered safely with a government nurse. So, that's a kind of respect which I have for the nursing fraternity. And me, I did my house agency in Trivandrum Medical College, and some of the most valuable lessons in life, especially to be a doctor, I have actually learned from the senior matrons and the nurses of Trivandrum Medical College, and for which I'm eternally grateful. So I would just share some of these aspects with regards to overall healthcare, about why it is constantly important to be restless, that we should never be satisfied the way we are. And it's a matter of pride that nurses from India, and specifically from Kerala, are there all over the world. COVID has really opened up huge opportunities for nurses from Asia, mainly from India and from the Philippines. Right now I'm based in Philippines, and as you all know that Philippines is one of the world's largest exporters of healthcare workers, including nursing. So I have a ringside view of the curriculum, the student development programs, which is happening in the Philippines. My chain, I'm the CEO of the largest holding company in the Philippines, Metro Pacific Hospital Holdings. We have a network right now of 19 hospitals. And in our network, in addition to the hospitals, we also have 2 allied health colleges, of which, obviously, in the allied programs, nursing constitutes a large volume of students. And one interesting aspect what we have really focused on in the Philippines is mainly to do with COVID, is to invest massively in digital technology. That how can you really give experiential learning for students despite not having the opportunity for face-to-face interaction. So this is something I suppose for the future. So I'll go straight to my presentation now. I hope you can all see my screen. Yeah. So the topic given to me is to do with excellence. I call it, whether it's a dynamite or a spoof. where a patient is concerned. Obviously, excellence is the heart of anything we do in healthcare. So quickly, the agenda for my meeting, I'll just briefly touch on the cornerstone or the genesis of healthcare, the way I interpret it, give you a certain perspective, then a couple of tools, then some elements which are important, the people aspect, business aspect, service aspect, clinical and digital. The business aspect is something very important for all of us in healthcare to understand, because sometimes we make the mistake, especially when we come from public sector, that we don't really keep the cost efficiency model in care, because you think that it's free. There's nothing. There are no free lunches in this world. To give you an example, if you're in the state of Kerala and you are fortunate to work for a teaching hospital or the district hospital in the public sector, please understand that the cost of care is borne by the taxpayer, by the common citizen of the land. Therefore, you need to really have that kind of business acumen, basically to appreciate shortfalls in budgets and how you can become much more efficient. Then we'll touch a bit on service, clinical, and of course the new frontier, which is digital. So quickly on the genesis, you all need to remember the basic triangle, or I call this a pyramid model of healthcare, where the patient who's at the heart of the pyramid, the consumer, you will look at the triple A's. One is accessibility, ease of access to healthcare, and because of COVID in the past 2.5 years, we have also used digital medium to access healthcare, quality healthcare. So accessibility is very important. Affordability, especially in third world countries. In India, we have the Ayushman Bharat, which gives you a certain degree of lowering of the economic barriers to access healthcare, therefore affordability. But still, the paradox in a state like Kerala is that despite the large presence of public healthcare, we all know that it is the private healthcare which is actually providing 70% of the healthcare needs of the citizens in the state. So affordability is a key factor in terms of equity. Assurance. Assurance is the model where we talk about minimum expected quality of care. Like every patient, firstly, the famous Hippocratic oath that do no harm. When you go to a hospital, you expect that your primary complaint will be taken care of, and you should not be a victim of some defects in the system within the hospital. So that is the meaning of assurance. Of course, there are several, the two concentric circles are talking about hindrances which prevent these three vertices of the pyramid working in harmony: access, affordability, and assurance. And of course, there are enablers. So people like you and me, who are part of the stakeholders, we have to act proactively as enablers to make sure that there is a balance in the three. And in the College of Nursing, which MIMS is affiliated to, the MIMS College of Nursing, the enabling aspect, what you're doing is basically on two elements. One is that assurance part. If you train healthcare workers, especially let's say the medtechs or the nursing who are coming out, who are your alumni, if you give them qualitatively superior competence and skills, and if your faculty are really up to date in the whatever's happening around the world, then you can be sure that the assurance model of the healthcare workers can really be preserved. Now, let me share a few perspective. The definition is basically to paint a landscape. So one is, we have three elements. Like if you look from a doctor's point of view or from a nurse's point of view, the technical knowledge, your interpersonal skills, and of course your tools of care. All that is very important, whether you're a nurse or a doctor. If you're a patient, obviously you expect that to minimize the gaps between your expectations and what is reality. I mean, all of us have certain expectations from a nurse and also from a doctor, for example. And as a patient, I hope that my real experience would be closer to what I think the nurse and the doctor ought to be, rather than the gap should be much greater. And of course, from a community point of view, we look at the elements that accessibility is, affordability is important. The cost, the budgetary cost, whether you're in the private sector or in the public sector, that is also important. Now, cost is something which is very interesting. Like I remember in 2018 when the nursing strikes took place across Kerala, the big debate was that why are the nurses in Kerala being paid so little? If you talk about your monthly salary, and that's a very good debate to have in comparison to workers in other sectors, need not be even healthcare. And therefore, the Minimum Wages Act was brought into law, raising the actual salary base, the salary band for nurses in the state of Kerala, which is a very good thing, and it's a positive thing. But it had its collateral impact too. One is that if there was a paradigm in the debate that the brain drain from Kerala to outside the country or even outside the state would decrease, it really did not happen. The needle has not moved at all. But if you say that, did it make a material benefit to the nurses and their families? Of course it has done, because that is we are basically talking about bread and butter means. But when you look from a society point of view, the overall cost of care for the state is definitely increased vis-a-vis neighboring states, if you look at Tamil Nadu and Karnataka. So cost from a community point of view, especially in the healthcare context, is something which will always be visible. And I think we all should be transparent to discuss about the cost of care. Another perspective is that from an excellence, when you talk about excellence, you need to understand the 4 dimensions of management. Of course, we look at organizations and people. Like in the case of MIMS, you're very fortunate to have a visionary founder, chairman like Dr. Azad Mopin. If you look at Dr. Dr. Azad's own legacy, I mean, he is an alumni from the Calicut Medical College. He could have been, and he was a very popular teacher, lecturer in the medical college. He could have chosen an academic career, but thank God, many of us say that, thank God he didn't choose an academic career and he decided to become a healthcare entrepreneur. Hence, we have such wonderful institutions like MIMS, and even your own institution, the College of Nursing and others, mainly because of vision and the organization what he has set up. Of course, in today's world, I talked about that every institution need to really be future-proof, and therefore this leverage on information technology. We look at the various processes and systems we have, whether it's in a hospital, in an educational institutions, or otherwise. I think that's a critical factor. And of course, our external stakeholders, whether in terms of, like in the College of Nursing, your key factors, your faculty and the student. And on the other side, the student with your own family, with your moms and dads who have invested their hard-earned money for your education. So they're all stakeholders in your success. So that's what this 4-dimensional view would be. Another binocular view, like if you look at relationship within a hospital, like this is very simple, that when a patient comes to the hospital, obviously the patient interfaces, let's say, has taken an appointment online or has come physically to the hospital, to the main reception, done the registration, and then goes to the outpatient department, meets the front office staff there, and then meets the doctor. The doctor can either order a laboratory investigation or a radiology investigations or a prescription. There are so many actions which the doctor as a care provider will have to do to ensure the patient's primary reason for coming to the hospital, mainly to seek relief from his pain points, that is taken care of. So it's a very complex system. And when you talk about a binocular view, is that we are looking at an end-to-end point of view, from purely looking at the patient's perspective. And unless we understand all the key elements which constitutes this larger system, things can go wrong. For example, let's say the doctor prescribed a certain antibiotic, but there was a problem in terms of his in the old days, we used to make those paper prescriptions where handwriting of doctors are traditionally very poor. And in the pharmacy, the pharmacist who read the prescription misunderstood because the handwriting was not very clear and gave the wrong medication to the patient. It's a disaster. So, such things can also happen. So that's what the meaning of this binocular view is all about. So this segment on perspective talks about excellence in operations. So many of us think that it is so complicated, a hospital. Is it really mission impossible? That can we really get a perfect system that at every point of contact of the patient, anywhere in the system, it's like a wow feeling that you exceed the expectations of the patient, which is very difficult. Like sometimes you have this experiences that, like in your case, you are in Kozhikode. Imagine somebody going to MIMS Kozhikode. What a wonderful doctor you have there as a consultant. Let's say, I mean, any of your doctors at consultants at MIMS Kozhikode. Excellent doctor. The treatment which you went for was very successful, but unfortunately, the discharge process was terrible. Let's say there was a delay in discharge. The bill exceeded your initial expectation. So already as a patient and the patient's family, you're forgetting the good work done by the doctor and the nurses. You're really caught up in this non-clinical affairs of the hospital. That is why when we talk about operational excellence, it's a throughput of everyone in the system. And sometimes when you're in leadership, whether you're the CEO or whether you're the chief operating officer, it sometimes is helpful to sit down with your team members and understand what is really happening at the front line. Like Madam Asuma Bibi was giving my introduction. So when I came to Kochi in 2013 to build Astomed City, that was, I consider Astomed City as my baby. One of the first things we did in 2014 after we commissioned the hospital was I introduced this concept called breakfast with the CEO. So breakfast with the CEO is basically idli and sambar or whatever is upuma or whatever you have. But I used to have it without any managers, directly with my staff who were in the front office, who were in the reception. I used to call them to my office and, give them breakfast. And then I used to listen to them that please tell me that what are the things we can do to make the experience of the patients coming to Astomed City far superior than anyone else. There's a lot of learning and a lot of ideas which the team had suggested we had incorporated to change the system in the hospital. So that's basically what I'm trying to say here. This slide is basically referring to looking from a patient's point of view. What are those elements in a system, in a healthcare entity, which adds value to the patient without increasing your cost? So on the right side, you look at, you either reduce cost to the patient or you increase the value. And cost is always relative. Relative in the sense that we always talk about value proposition. Like to give you an example, if I give you the example of cardiothoracic surgery, I know that the cost of cardiothoracic surgery in MIMS Kozhikode or even Kozhikode Medical College is of a certain amount. But if I go to a hospital in Delhi, AIMS Delhi, or let's say Max or Apollo Hospitals Delhi or Fortis Gurgaon, the cost is maybe 2 times or 3 times more than the cost in Kozhikode. So that's what I meant. So it's relative to the market, relative to perceptions, and relative to competition. So that's where cost have to be. So the effort of the system is always try to eliminate as much as cost as possible, of course, reduce it, and proportionally raise the value and create new value for the patient or the customer. So this is something we need to remember. Now, examples of a few tools which we can use in the excellence paradigm. One is, this is a Japanese concept, is called 5S. So there are words in this. So the whole philosophy is that the eyes cannot see what the mind doesn't know. So if you do not know something about it, your eyes, you will always be blind. What I meant is not functional blindness, but metaphorically you will be blind. So the Japanese philosophy is, and there's an English translation of it. So let's look at clockwise manner. First is to sort. So this is an area that, let's say you go to a department first, you make sure that it should not be chaotic. You should sort out all the items, let's say on your table, in a proper manner. So it's a Japanese word called seri. Then you set in order, means, let's say you're sitting in front of a computer. So your keypad should be close to your arm, your elbow should be able to rest, your pen and your stationery should be, that's the meaning of setting in order. It's called Saiten. Next is called Shine or Seso. So basically to keep your workplace tidy and extremely clean. If you're a nurse, imagine that you're a medication nurse. Your medication preparation table, everything should be spick and span, also from an infection control point of view. Then comes standardize, or called Saiketsu. Standardize is the concept that if you look at the first three, sort, set in order, and shine, you try and create a pathway so that it becomes in a repetition manner. In the nursing or a medtech kind of a forum, especially if you're a fresh staff, you have these seniors in the team. When you work in a hospital, these are mentors. So the mentors will give you a certain work culture, which will give you a sense of discipline, so that over a period of time, mentally you'll become standardized. That's the meaning of Saiketsu. And finally, we're talking about sustain, that is called Shitsuke. So sustain is, if you look at the 5S principle, this becomes part of your DNA. So we know that, to give you an example from a hospital, we know that within, let's say, if you want to do a phlebotomy service, right? Some nurses have this magical ability to take a blood sample without, the patient does not even know. It's not even like a mosquito bite. It is so smooth, the access to the vein, you know, that the entire process. So for a patient, it's a massive relief, because the patient had expected a lot of pain. But because the nurse is so well trained in these principles of 5S, in the technique of phlebotomy, the customer experience is supreme. So that's what this talks about. The other example, again, from the quality world for excellence, is what we call as the DMAC roadship, where if you define any problem in your professional life or your personal life, or in the let's say as a student, for example, you define what exactly is the problem, then you measure what is the current performance and capability of that. Then you analyze the root causes of exactly why did the problem happen in the first place, and then you try to improve by implementing potential solutions. And then finally, you're controlling by standardizing the solutions and continuing to monitor performance. So it's actually a virtuous cycle when we look at in a clockwise manner: define, measure, analyze, improve, and see. That's what DMAIC, the tool, is all about. Now, I know that it's a very provocative headline, but there's no other way to talk about that. We can't tolerate bullshit in life. What it means is that always from a patient's point of view, because we're healthcare workers, we should really focus on those activities which enhance the care process for the patient. Anything which does not add care to the patient is actually bullshit. It's an utter waste of your time and effort. So we should try to minimize that, and as far as possible, eliminate it. To give you a concrete example is that electronic medical records. Many hospitals mandate that electronic medical records are essential. Now, I have because I've run hospitals. Obviously, if you look at from a nursing point of view, many nurses struggle to say that, oh my God, there is so much of data entry requirements into the computer. How much time do I have for core nursing? So therefore, it's also required for the IT developers, the programmers, the healthcare workers, the nurses, everyone to form cross disciplinary teams to ensure that at the user interface, when you enter a form, that form A, the number of forms should be minimum, and the data templates in a EMR should be as minimal as possible. And you only focus on those things which really make sense from a patient care point of view. Now, this is a fascinating slide. The Toyota production system in healthcare is something which is debated world over. Now that we have, more than a couple of I would say about roughly 1.5 to 2 decades of experience world over, I would say that this is a very fascinating system of improving quality of healthcare. A classical example is the emergency department of a hospital. In the emergency department of the hospital now, especially like in the example of Kozhikode, you have the recent experience of the Air India air disaster, or even earlier than that, you had this experience with Nipah virus outbreak in the Kozhikode Medical College. So these kind of public health emergencies or a disaster management system really puts the spotlight on principles of lean or a Toyota production system. So what it means is that basically, like the example which I gave before from Aster MedCity, you need to ensure that you put competent staff at the front line. Like in this case, could be emergency technicians, it could be nurses. You deploy these staff there, and the supervisors, their next level supervisors, will constantly train them and mentor them, but at the same time listen to the workers, the frontline workers, so that you have a virtuous cycle of improvement. And this could be anything like simple as inventory management to make sure that there is adequate stockage of drugs in the crash cart, the required consumables are present. You have all the codes are well grilled, whether it's code blue or let's say code red, everybody's well oiled into that. So in this kind of a system, even from a managerial point of view, if you're the nursing manager should spend minimal time in her or his offices and should be much more, time should be deployed being with the staff and the supervisors in the emergency department. At the same time, when we look at performance measures, whether it's quality or clinical outcome measures, this should be co-created with the help of your frontline staff. So this is the basic essence and principle of the Toyota management system. So basically, what it talks about, that's what TPS is all about. You focus on your people, frontline people, eliminate, that's the lean principle, eliminate non-value adding activity. Of course, you embrace technology, whether it's RFID or QR code systems. Then you talk about don't stock too much of inventory, keep your inventory lean, just as what your team needs. And of course, if things go wrong, which is bound to happen because we are all people, you always need to do root cause analysis and learn from that. Now, a bit about people. When we talk about karma, that's our ancient Indian philosophies, that even you all as students, you need to ask that, well, where do you see yourself? Like, what's the purpose of your life? Or if you're a profession, then you have to discuss that. Okay, now maybe some of you will think that maybe I don't know, 10 years, 15 years, you would like to be in Dr. Asuma Bibi's position. I mean, she's the principal. Why not? As a young student, you should have those kind of vision and role models in life. If that's your vision, then what all should you do to achieve that vision? How are you going to achieve that? That's the point number 3. Obviously, you need to go complete your bachelor's program, go for your postgraduate program, and then also maybe required to do a PhD. That's what you need to do. Then we talk about performance monitoring, which is constant for all these factors. And finally, if errors take place, you need to look at corrective actions. The other model is also focusing on the people aspect, is the wheel of Dharma. This is all focusing completely on elements of people wherever the system is, whether it's to do with relationship management, like for example, also in the context of nurses, right? We talk constantly about this issue of union, let's say nursing unions, or to do with IR issues, industrial relationship issues. I believe that it's all to do with the relationship management, where there is an element of trust deficit, where intersectoral dialogue has not taken place. And if you look at a very cooperative kind of a model, where the managerial class, the supervisors and the managerial class really invest time with the lay staff, then you really will not create that kind of a like an adversarial kind of a relationship. All these relationship in terms of people have to be based on certain ethical principles. People running it must have the competency. Obviously, you must have that sense of business acumen, so that in a private healthcare entity, manpower costs are pretty critical and sensitive. Therefore, how do you balance the manpower cost towards the quality of work, and also sustainability of your business enterprise? That's very important. Constant evaluation of your staff in terms of performance. Then we obviously look at global aspects, cultural effectiveness. See, I've read media stories in the context of Kerala, and for example, uniforms of students. Like I've recently heard stories about some issues happening in the west coast of India, in the state of Karnataka. Really, what is the purpose of education? Purpose of education is basically to expand the mind. Really, does it matter what the student comes, what kind of a uniform the student? I don't think that should be the priority. You need to unlock mind. So the cultural aspects also of education is education and training is also very important. Of course, leadership and how do you navigate this entire process, and consultation. Consultation is the basic principle of consultation is we all have our knowledge limits. We are not experts in everything. Some of us are generalists, and therefore we need to know when to seek help. That is the whole concept of consultation. And of course, finally, when you talk about communication. On the other side, on the people aspect, like I gave you the example of trade union issues and friction in the workplace. This is a classical example of a slippery slope. When there is frustration building up, that's point number 1, limited performance improvement opportunity. Let's imagine a ward nurse. A ward nurse posted in the general ward has absolutely no opportunity to improve her or his performance, and there is no career pathway there. There is a high risk of frustration. Number 2 is that imagine huge work pressure because of inadequate manning ratios. The staff can have burnout. That's a big problem. Third is there is no standard way of measuring performance. So you're constantly at the mercy of your supervisor, who might be very subjective in performance appraisal, which is unfortunately this is holds true in many parts of the world. So that's a big problem. Absence of measurable goals, which is also, I think it's a demotivating factor. If we all know what is expected of us, it is very clear and articulate. It's very easy for us to rise up to expectations. And of course, inconsistent performance reviews, like let's say sometimes the frequency of reviews itself is missed out, then it's a challenge. Then quickly into the business aspects. I've already mentioned that briefly, whether you're in public sector or private sector, cost is something very important to be sustainable. So the cost of your model has to be always kept optimum. We have to improve access, especially let's say you're a hospital, you have to see how can you get more volume of patients to your hospital. You have to focus on improving the quality of care. You have to decrease variations in performance. Like for example, let's say if you have 5 nurses in a ward, you need to ensure that all the 5 nurses up to a certain level is having consistency in their competence and their skill level. You cannot have too much of variations which will result in medical legal issues. That's a problem. Increase utilization of your capital assets. Let's say you have invested in expensive equipments, operating room, intensive care units, or MRI, CTs. You can't afford to leave it idle. If you have made a wrong decision in capital, let's say capital investment, then you have to really think out of the box. What can you do? Maybe you have to give it off to some other hospital which deserves it or needs it better than you. But you really need to focus on how efficiently your resources are being utilized, including manpower. Manpower is most often ignored. I talked about the cost element. We have to also focus on productivity of our manpower. That is the meaning of number 5. Of course, disparities in a system should be reduced as much as possible. Increase equity. We have to also focus on prevention, mainly prevention from making errors which can cause harm to a patient. Then, of course, the other elements are also. So all these things are like I've been a CEO for many years in my life. So I always visualize myself of being a gymnast. It's a tightrope act. When I was in Aster, so obviously my boss was Dr. Azad Mopin, so I have to meet his expectations. Then I have my colleagues, I have my subordinates. Now, how do you balance all these things consistently over a period of time and still you still manage to smile and stay healthy? So that's the meaning of business gymnastics. Now, service, please understand, in today's world where people have choices, even government hospitals, public sector hospitals are now taking customer feedback. Private sector, then this is the mantra to sustain and to grow. Extremely important that as healthcare workers, we are conscious that we need to really believe in the philosophy of patient-centered care. Therefore, your entire aspect, if you're in management or otherwise, you need to trust and empower your people. If you empower people, when you do employee surveys, right? Why do you work for one company, one organization for such a long period of time? You say that the sense of autonomy and empowerment, it's not the salary. People never say that I'm working in this company because they pay me high salary. That's not the factor. It's that enriching environment where intellectually and emotionally you feel attached to an organization, which actually helps you to provide better service to your customers. So, which also means that your processes are efficient, you have the best technology to serve your customers. So that's the meaning of this aspect. Now, on the same context, when you look at service environment, right, you have to make sure that your service environment, which is not only physical, inanimate infrastructure, but also animate, which is people, is really very important. Like, to give you an example, you all know that Air India has been bought over by the Tatas. And one of the controversies which came a few days back was Air India has asked for its cabin crew to have a body mass index score. And if there's a certain benchmark, if you don't fulfill that BMI index, you cannot be a cabin crew. You will be posted for ground duty. So a lot of people talk about human rights. Well, that's cruelty. But then this is the global standard for service excellence, right? There are some safety aspects and also customer expectations in terms of look and feel of the service element. So that's what I mean, that in a hospital, it's very important etiquette and grooming. A nurse has to look really smart, in the sense that the way you carry yourself, the sense of confidence, what you have, your empathetic factor, your communication factor, your knowledge factor is very important, and also for a doctor. I mean, why do we traditionally say the doctors need to wear the white aprons? You know, that's the minimum expectation of a doctor. It's also to do with historical legacy, but these are those visual cues in the service environment which is expected from healthcare. On the right side, when we talk about delivery, you need to constantly create wow. In the wow meaning, in a hospital environment, nobody comes out of choice. If you go to a hotel, you know, out of choice for pleasure, but you come to a hospital because of pain, either physical pain or a mental pain. And in such an environment, when you have a pain factor, how do you exceed expectations of the patient and the family member? It's a very big challenge. So how do you rise up to that is this entire service aspect. Then, of course, ease of doing business. Don't get complicated, cut through red tape, make it as simple as possible. And the center part, we should always imagine ourselves from the lens of the stakeholder. Imagine. So I used to say when during our induction program of new employees in Aster, when I used to be there as a CEO, I used to do the vision lecture for all my new employees. And one prayer I used to have at the end of it is, please promise me that you will treat every patient as my relative, as my brother, my sister, my daughter, my son, my father, my mother. If you promise me that, you cannot do anything wrong. That's the meaning of looking from the lens of the stakeholder. Now, quickly, clinical, it's very important that you have a sense of order and governance in a hospital, whether it's the nursing fraternity, whether it's medtechs or even doctors. Therefore, the entire governance of privileging doctors, I can give you, a couple of examples that I used to be, because every single doctor in Aster Med City, I personally have hired them. I used to be very clear about the privileging, the credentialing and privileging aspect. Like, just because you have an MS surgery or an MCH, you need not be a consultant in Aster Med City. I used to be very clear about it. I used to say that you need to have minimum years of experience and show me proof of experience through your surgical logbook in order to be privileged as a consultant. So we used to have those challenges because the same qualified doctor in other parts of Kerala are already classified as consultants. But then I said, well, this institution is different. If you want to work here, these are our conditions. So you raise the bar about the kind of people you expect to work in your organization. Other elements, I've given you examples of induction. Mentorship is very important. Like, for example, there are surgeons who, let's say, after 25, 30 years of service, they think that they're at the top of the game. But there are good surgeons who, in spite of their so many years of experience, still invite coaches. Coaches are other surgeons who will come and observe them in the operating room for the first time to point out errors where they can improve themselves. Why do you think Sachin Tendulkar or Virat Kohli, how they become such great professional cricketers, batsmen? It's not because they had some technical flaw in their batting, but to become better and better, you need to have a coach. All of us need coaches to become better in life. So that's the whole concept of mentorship. So I won't touch more about that. Now, the last element is the world is going towards digital. Consumers are demanding it. If you're not future-proof as a healthcare organization, as students of healthcare, whether you are a nurse or a medtech, you need to educate. See, for you, all of you, it's very easy. You're all used to smartphones. You're used to most of the apps, whether it's Insta, whether it's WhatsApp, and you are all used to all these things, Facebooks. So for you, it's relatively easy to make the transition from what you're really used to on social media on your mobile phone to an electronic medical record system, or even telehealth for that matter. But this graph is basically showing from a patient point of view that during COVID time, why did patients prefer virtual consultation compared to face-to-face consultation? So that's where the world is coming to. And these are some examples, right, ranging from teleconsultations to the operational aspects of admission and discharge process, to using AI platforms in tissue pathology or in imaging or even vaccine. The COVID-19 vaccine, my friends, is a classical example in human history where we have broken the world speed record for vaccine. Usually it takes 5 to 7 years. But because we've used machine learning, we've used artificial intelligence, we could really produce a COVID vaccine in 10 months time in 2020, which is one of those key highlights in human history, I would say. So that's my last slide. So thank you. Thank you, College of Nursing, Dr. Asma Bevi, for having me. Thank you so much.
Thank you, sir. Thank you, sir, for your outstanding session. And we have to sincerely appreciate you for taking out time from your busy schedule to provide us with your such valuable information. And delegates, do you have any doubts? Any queries? I think there is no queries from the delegates, sir. Thank you for the wonderful session. Thank you, sir.
God bless all of you. Thank you.
Now, I call upon Ms. Alfrin Jose to introduce our next resource person, Dr. Shijala CH, who will be dealing on digital health, artificial intelligence, and technology in healthcare.
I'm happy to introduce our Vice Principal, Dr. Shijala CH. She has completed her BSc Nursing from Mahatma Gandhi University, Kottayam, Kerala in 2000. MSc Nursing in Medical Surgical Nursing from Rajiv Gandhi University of Health Sciences, Bengaluru in 2006. Dr. Shejila has completed her full-time PhD in nursing from Manipal Academy of Higher Education in 2018. She has secured research grants from national and international agencies like Sigma Theta Tau International Nursing Society, Omicron Delta Research Grant in 2014, and Department of Health Research Grant in 2020. She is the recipient of many international travel grants from Union for International Cancer Control and Science and Engineering Research Board for attending international conferences. She has got publications in national and international COAHS and Web of Science indexed journals and serves as a reviewer for many indexed and peer-reviewed journals. She has also received the Best Teacher Award from Kerala University of Health Sciences in 2020. And presently, she's doing the fellowship, FAMER Fellowship Program from Mahe FAMER Institute. We welcome you, ma'am, and over to you.
Thank you, Alflin. Hello.
Hello, ma'am.
Hello, Alflin.
Yes, ma'am.
Can you see the slides?
Yes, ma'am. Can you make it to slideshow?
It's stuck, I think.
Okay. Ma'am, you can continue. It's visible.
Stop your time. Hello, can you hear me?
Yes, ma'am.
Okay,
Audio is
thank you,
clear, ma'am.
Alfilin. Thank you, Alfilin. And good afternoon to all. The topic I will be dealing with is digital health, artificial intelligence, and technology in healthcare. So before starting, I just want to say something about the history of artificial intelligence. In 1955, Herbert Simon and Alan Newell has developed the first artificial intelligence program. And today we have most advanced human-like robots, which is created by Hanson Robots, and this known as Sophia, which has the first robot citizen who has got a citizenship in Saudi Arabia, and she can even smile, laugh, and frown like a human being. So digital technologies are transforming the health sector all over the world. Now, the exponential growth in digital technology coupled with global COVID-19 pandemic is driving a profound change in the delivery of medical care and research conduct. So digital health technologies are using some computing platforms, connectivity, software, and sensors for healthcare and related users. The broad scope of digital health include categories such as mobile health or mHealth, health information technology, wearable devices, telehealth, telemedicine, and personalized medicine. Then next is, what are the benefits of digital health technology? Digital health offers opportunities to improve medical outcomes and enhance the efficiency of treatment. It empowers the customers to make better informed decisions about their own health. Then providers and other stakeholders are using the digital health technology to reduce inefficiencies in treatment, improve the access to care, reduce the cost of treatment, and increase the quality of care and make medicine more personalized for the patients. Then what is artificial intelligence in healthcare? It is an overarching term used to describe the use of machine learning algorithms and software or artificial intelligence to mimic human cognition in analysis, presentation, and comprehension of complex medical and healthcare data. And what distinguishes AI technology from traditional technology is that it is having the ability to gather data, process it, and give well-defined output to the end users. Then the next is the application of AI in healthcare. AI can be used from keeping the people healthy. That is, use of AI and Internet of Medical Things in consumer health application is helping people to keep them healthy. And technology applications and apps encourage healthier behavior in individuals and help them to proactive management of a healthy lifestyles. It put consumers in control of health and well-being and give better feedback, guidance, and support for staying healthy. So many of us are using smartphones and smartwatches, which are used to detect even pulse rate, oxygen saturation, activity, BMI, then nutritional intake like calorie intake and all. Then in early detection, it is also being used to detect diseases such as cancer, more accurately and in their early stages. The use of AI enable review and translation of even mammograms 30 times faster with 99% of accuracy, which reduce the need for unnecessary biopsies. The proliferation of human wearables, consumer wearables, and other medical devices combined with AI is applied to oversee early stage heart disease, enabling doctors and other caregivers to better monitor and detect life-threatening episodes at earlier and more treatable stages. This is a few examples where it can be used, AI can be used in detecting cardiac diseases. Even it can be used for endoscopic imaging, detection of especially breast cancer, and it is used for diagnosing diseases through CT, MRI, etc. Then, especially in diagnosis, which provide fast and precise diagnosis, increase diagnostic accuracy, reduce the cost, enhance staff satisfaction, and improve patient outcomes, which include enhanced treatment efficiency, more personalized therapies, reduction in amount of unnecessary interventions or surgeries, and enhance the quality of service as patients may receive a diagnosis more faster. Then it is used in detecting diabetic retinopathy, CT brain bleed, intracranial hemorrhage, or for the diagnosis of ICH, coronary calcium scoring, which is a strong predictor of cardiovascular events, include heart attack and strokes. Then it is used along with echocardiogram to determine the EF or ejection fraction. Then in stroke diagnosis of patients who suffer from some blood flow disorders. Then it is also used in the detection of cancer from lesion images, identifying prostate cancer, osteoporosis related fractures, detect liver lesions, then used in cervical cancer screening and eye disease detection by using optimal coherence tomography. Then artificial intelligence can be used in clinical decision making, where AI can support the clinical decision making and actions as well as prioritize the administrative tasks. Then using pattern recognition to identify the patients at risk for developing a condition and or seeing it deteriorate due to lifestyle, environmental, genomic, or other factors. So that this will enable us to save valuable time and money and take strain off from the healthcare professionals and increase the comfort to the patients. Then the assistance of natural language processing, which makes it more convenient for doctors to narrow down the relevant information from patient reports. And it holds the ability to store and process large set of data, which can provide knowledge database and facilitate examination and recommendation of individually for each patient, thus helping to enhance the clinical decision support. This is known as precision medicine. Each patient will be giving individualized care based on the patient's profile. Then in treatment, AI can help the clinicians to take more comprehensive approach for disease management, better coordinate their care plans, help the patient to better manage and comply with long-term treatment programs. It can be used in the treatment of rare diseases like Wilson's disease. Then it is also used for targeted treatment, especially in cancer therapy. And BERG is an AI-based clinical stage biotech platform which work on mapping of disease to speed up the finding and creation of advanced breakthrough to medicine and vaccine development. And it is also used for the treatment of Parkinson's disease. Then again, AI is used in the form of robotics in medicine and surgery, and they range from simple laboratory robots to highly complex surgical robots that can either aid in human surgeon or execute operations. We have seen minimally invasive surgeries, knee replacement surgeries, etc. So these are using robotic aid. Then in addition to surgery, they have used in hospitals and labs for repetitive tasks, in rehabilitation, physical therapy, and support of those with long-term conditions. And this can be used even in patients with psychiatry. The virtual reality and augmented reality can be used to treat patients with anxiety and depression. Then patients with many neurological conditions like patients, there are certain cognitive assistants that can help patients with dementia. Then even it can be used for pain management. That is, it's an emerging focus area in healthcare. By leveraging virtual reality, which is combined with artificial intelligence, and simulated realities can be created so that it helps to distract the patients from the current source of pain and help them with opioid crisis. Then telehealth and telemedicine and another areas which covers medical education, remote patient monitoring, patient consultation via video conferencing, then wireless health applications and transformation of imaging and medical reports. Then it is also used in end-of-life care. Robots have potential to revolutionize the end-of-life care, helping the people to remain independent for longer and reducing the need for hospitalization and care homes. AI combined with advancement in humanoid design are enabling robots to even go further and have conversation and social interaction with people to keep aging minds sharp. It is mostly used for people, those who are old and having some chronic conditions, those who are homebound. So there are many virtual or cognitive assistants which help the patient to do the activities of daily living or the household work itself. Then in research, drug research and discovery is one of the most recent applications of AI in healthcare. And by directing the latest advancements in AI to streamline drug discovery, drug repurposing process, that is potential to significantly cut both the time to market for new drugs. As Dr. Harish has already said, that the vaccine trials, which is used during COVID-19, mainly uses artificial intelligence, so that within 10 months, most of the vaccines were developed, where normally it will take around 5 to 10 years. So that is also, vaccine development is also another area which uses artificial intelligence. Then even the AI can be used for clinical trial participation. So usually in clinical trials, large amount of data need to be collected and organized to get right theory for a particular disease and its treatment. With the help of AI, hospitals become capable of facilitating the result-driven approach to the respective clinical trials and allows neural networks to predict the bioactivity and characteristics of each patient. So this can analyze the patient data and can determine which patient will be more suitable for a particular clinical trials. Then AI platform have assisted researchers to find out the right candidates to test some of the developmental drugs for various diseases and disorders. Then development of new medicines. The unique benefit of artificial intelligence technology allow the healthcare professional to scan pre-existing medicines and use them to redesign medication in a way that allows them to fight against specific disorders. So there is a development of new drugs for the treatment of Parkinsonism. Then drug molecules are developed for OCD, obsessive compulsive disorders, etc. Then next is training of healthcare personnel. So it can be most used in nursing and medical profession. This allows those in training to go through naturalistic simulations in a way that simple computer-driven algorithms cannot. And training can be done anywhere with the power of AI embedded smartphone, quick catch-up sections, and after a tricky case or in a clinic or even while traveling, this is possible. You might have heard about a virtual reality clinical simulation techniques and all. Even there are cyborgs and humanoid robots which can be used for showing our clinic, doing simulations in labs and or simulation labs. So some of the AI technology even that allow the face tracking of students during the clinical simulation, we can track the facial expressions of students and we can analyze how the students are reacting to a clinical procedure, etc. Then enhance primary healthcare and triage to chatbots. And many of us are familiar with chatbots. You know that sometimes when you are opening a hospital site, there may be a screen coming, a pop-up screen coming like, may I help you, like that. So it is also using the triage, and primary healthcare also use chatbots. So it assists in enabling smooth flow and automation of primary healthcare, which allowing the doctors to stress over more crucial and dire cases, so that the patient or those who are sitting at remote areas, or the patients in remote areas, need not to come directly to the hospital to see the physician. So they can directly chat with the doctors or the hospital care assistants. So that save money on unavoidable trip to the doctor, and patient can benefit from medical chatbots. So usually the chatbots are available 24/7 services and have capacity to deal with multiple patients at the same time. Then the next is virtual nursing assistants. AI system may facilitate virtual nursing assistants that can perform a range of tasks, from conversing with patients to direct them to the best and effective care unit. AI-powered applications of virtual nursing assistants enable more regular interactions between patient and care providers, and between office visits, to avoid unnecessary hospital visits. So the first virtual nursing assistant which was developed is Care Angel. The Care Angel was developed to interact with patients, and so that they can give some assistance for the patients. Next is robotics, use of robotics in nursing. So you can see that the robotic nurses are used for giving injection, then transferring a patient, for delivering medications. Even patients in ICU, those who are admitted in ICU, can be cared by using a robot, and a robot can be used for physical therapy or rehabilitation. Then it is also used for minimizing the burden of electronic health record use. Then voice recognition and dictation are helping in enhancing the clinical documentation process. And AI can also aid in processing routine requests from the inbox, such as medication refill, result in notifications. It can also use aid in prioritizing the tasks that request the clinician's attention, and make it simplified for users to operate with their to-do list. Then next is it is used for reduction of dosage errors. Even single dose of medication or a drug can have some dire consequences on patient's body. So it is important that the patient takes right amount of medicine which is prescribed, and with the help of artificial intelligence, the industry will be able to reduce the margin of errors in medication. Then next is automation of redundant healthcare tasks, which lead administrators to have some spare time and go on working with important and necessary tasks. So Olive is an AI-based platform which automates several processes such as checking the eligibility of non-adjudicated medication claims, then transferring necessary medical data to the respective medical professionals, and so on. So this is an AI platform reduce the administrative or healthcare task. Then next is improve the healthcare access. Artificial intelligence has led to the development of several medical software that offers interactive and customized health services like anytime appointments with doctors, and patients have a better and improved access to the hospitals when required, and use of chatbots will help them further. This is one of the app which is used by our Aster MIMS hospital, that is One Aster. This is a virtual health assistant who can help you in booking appointment with physician and all. Then what is the benefit of artificial intelligence in healthcare and other domains? It helps to improve and provide benefit to the healthcare sector, such as delivering better and faster services and reducing unnecessary workload from the healthcare professionals, ensuring healthcare accessibility to at most every section of the society, because use of telehealth and telemedicine, which enable even patient in remote areas to get access to the maximum care. Then identify early risk of disease and also potential to assess the outbreak of disease. Then in case of pandemic-like situations, which help in communication, we know that most of us have downloaded Arogya Setu app. Arogya Setu app is based on artificial intelligence and which is used for communication like chatbots, then contact tracing. When you are usually when you are opening the Arogya Setu app, you can see how many of them are at risk or how many of their people were affected with COVID-19 within the 15 days or 30 days, like then it is used for preliminary screening and diagnosis. You might have seen that whether you have traveled anywhere, whether you have sore throats, any other signs and symptoms like that, Arogya Setu app that is all based on artificial intelligence. Then again, it is used for vaccine development, especially for developing corona vaccines for COVID-19 and Ebola virus also. Then use of administrative assistance for hospital booking or for that and all will be used in especially in pandemic situations. This AI can be used. Then there are, like any other health technology, the AI also has got some pros and cons. So the pros include improved diagnosis, serves rural communities better, then better clinical decisions and streamliness in several processes, especially the hospital administrative tasks can be reduced. Then the cons include complications in learning AI. Most of the people are not tech savvy, so it is very difficult to handle. Then difficult to change to adapt to. Most of us are not even now during the time of this COVID pandemic, even as a faculty, I know that we are having difficulty to adapt to the new technologies. Then require human assistance and require the implementation of AI in a correct platform. So these are some of the pros and cons of AI. Then challenges in implementation of AI in healthcare system. One is privacy and security of data. Then inaccurate or missing data or implementation of artificial intelligence in emergency setting, where sometimes human touch or human efforts are needed in emergency settings. Then other issues are data protection, quality of service, and potential hazards like clinical safety. Then clinician and patient relations can be affected. Then these are the threat of artificial intelligence in healthcare, which include data availability, bias and inequality, privacy concerns, errors and injuries, and it can lead to shift in the profession. So the first one is errors and injuries. AI system may sometimes go wrong, while the errors can obviously take place in human medical profession, as well as it is very crucial, and an error in the AI system could lead to injury for thousands of people. So there may be medication, a wrong instruction is given for a patient to take a wrong medication, or sometimes it can give wrong diagnosis. So AI can lead to injuries of thousands of patients because it is mostly used by many people at a time. So it can lead to errors and injuries. Then data availability. So AI systems require massive amount of data from multiple sources such as pharmacy records, electronic health records, insurance claim records, etc. Since the data is fragmented and patients often see different providers or switch insurance companies, the data get complicated and less comprehensible, as a result of which the risk of error and cost of data collection may escalate. So especially if there is a fragmentation of data, which can happen when the patient, especially in the if the patient is going from one healthcare provider or one hospital to another, or switch the insurance companies and that companies and all, this may become more complicated. Then another one is privacy concern. The collection of huge database and exchange of data between health system and AI developers, it can violate the patient privacy, leading to filing of lawsuits. So another area where the employment of AI system rises this issue is that the capability of predicting private information about patients, even if the patient has never given the information. With the latest AI system, if any patients with, for example, any patients with a Parkinson's disease who is having a tremor, if he is touching the mouse, that also can be detected by the AI system. So even though the patient is not able to provide, or if the patient is not even provided the information, the AI can detect even the minute movements of patients. So this is another privacy concern. Then next is bias and inequality. The AI system absorb and learn through data which they are trained. They can absorb the bias in the available data. So it is based on data collection and analysis. So any available data is having bias that can be fastly absorbed by the AI system. For example, data incorporated in AI may be collected in academic medical centers. Developing AI system will have less awareness about and result in less efficiency of treatments. If the patient, as I told, that the patient may sometimes move from one health provider to another, there may be the data incorporated in that particular hospital system. Sometimes it may not be transferable to the other hospital, so that there may be missing of data, so that patient may get less the treatment less effectively. Then it can lead to shift in the profession. In long-term run, the employment of AI system could lead to shift in the medical profession, because we have seen that already, especially in field of radiology, even in nursing also. If we are using robotics in use of robots in nursing may reduce the number of employees later. So this raises the concern that high degree of employment in AI might lead to fall in human knowledge and capacity over years, making the providers fail in detecting AI errors as well as future development of medicine or medical knowledge. Then in future, AI can be more used in the healthcare education field. So now itself, we have seen that during the time of COVID pandemic, we have seen some virtual simulation where most of the students were not able to go to the clinical setting and all, and we were using OSCE and virtual simulation for teaching the students. So in future also, the healthcare professional education, in healthcare professional education, the artificial intelligence can be used. Then it may augment the doctor's abilities to diagnose disease and find treatment plan which are optimized for a particular individual. I already told each patient's data can be collected, analyzed, and more precise treatment can be given to the patient. Then the current structure of health insurance might be replaced by AI-powered subscription services. We know that mostly we are paying now. The payment is through different apps. You may be using like Paytm or even Google Pay and all like that. The health insurance structure can be replaced by using AI-powered subscription services. Then robotic replacement for certain jobs in medicine. Already I told in the field of radiology, especially more precise diagnosis can be made by AIs even than human beings. So it may be replacing certain jobs, like in future, like people, those who are working in radiology department, in even in nursing, we may there may be replacement of human beings with robots. Then it is widely used in care of aging population. Usually we know that with our aging population are increasing nowadays. There are so many people, those who are homebound with chronic conditions and all. So in order to take care of the aging population, even smart homes can be developed in future. The smart home means it is use of some sensors and monitoring devices and tools for the easy living of the old age people. That is known as smart homes. Smart homes, cognitive assistants, those who are left alone at home. Even you can see that the people with dementia, cognitive assistants can be used. Then assistive robots can be used for housekeeping, mobility, then medication management, eating, grooming, bathing, and various social communications. There are certain robots known as pet robots can be used for social communication and all. So some of the these robots are like known as Areno robots and Paro robots. That are some of the pet robots which are used to socialize the aged population. Then in future, drug and vaccine development can be it can be more made easily and cost effective by using AI. And later on, hospitals themselves are out on their way, because most of the people are using smart health, e-health and all. There is no need of going to the hospital. So hospitals themselves are on their way out in the future. Then to conclude, despite some setbacks and limitations, artificial intelligence in healthcare are virtually announced every day. So that artificial intelligence tools can aid in medicine industry in enabling faster services, giving more accurate diagnosis and data analytics for detecting trends and genetic information that would expose someone to a particular disease. Then with access in the era where saving even a couple of minutes can save the lives in times, artificial intelligence and machine learning can be transformative, not only for healthcare, but also for every single patient. So I have used these references for preparing these slides, and there are more things to be said about artificial intelligence. I have just covered the important areas. So do you have any doubts on this? Anybody?
Thank you, Shujala ma'am. I think there is no doubts from the participants. Thank you, ma'am, for a very informative session. Now let's break. Okay, ma'am. Thank you. Now let's break for the lunch. I remind you all to stay online and join us back at sharp 1:30 p.m. Thank you all. Once again, welcome you all to the further sessions. To update us more about nursing excellence and how to derive it, we have with us Dr. Jyoti Clara Michael. I request Dr. Shijala CH to introduce the dignified nurse leader, Dr. Jyoti Clara, to take over the session.
Thank you. Am I audible?
Yes, ma'am.
Meenu,
Yes, ma'am.
I don't know why my video is not coming.
Yes, ma'am. Shijala, ma'am.
can I introduce madam?
Yes, ma'am.
Yeah, please. My video is not shown. I am not sure what is the problem. Can you host?
It is still loading, I think, ma'am.
Okay, fine.
Okay, ma'am. Good afternoon, ma'am. And I am happy to introduce Dr. Jyoti Clara, who is the Director of Nursing IHH Healthcare India in Gleneagles Global Hospital. And she is the Vice President of Association of Nurse Executives in India and Tamil Nadu State official member. Dr. Jyoti is an alumni of CMC Vellore with a professional journey over past 32 years and reaching pinnacle positions in academic and clinical areas in nursing. She has served in various capacities such as Assistant Dean for Clinical Affairs, Sultan Qaboos University, Oman, National Advisory Board for Research, Oman, Director, Nursing and Quality, Gleneagles Hospital Group, Chief Clinical Governance Officer, Coventry Corporate Office. And Dr. Jyoti has got many awards and honors to her credit, like Most Innovative Healthcare Leadership Award, then International Travel Award from Midwest Nursing Research Society, USA, Deanship Training from University of Wisconsin, USA, then ETAPI Research Award, USA Rotary Vocational Excellence Award, Best Nurse Award by Tamil Nadu MGR Medical University, etc. She is an assessor for NABH, NAC, and JCI. She is certified in ISQA Fellow, and she is an INC inspector and developed critical care nurse practitioner standards for INC. She is a PG guide, co-guide, and advisory member, and she has many publications in national and international journals. Especially her publication is in Nature, BME, then board member for British Journal of Nursing, UK and India, and she is a member of many professional bodies in India and abroad. Her research areas of research interest include women health, pain management, then alternative and complementary therapies, quality of care, online course development, EBP and training, and accreditation, and nursing profession and ethics. With this short introduction, I would like to welcome Dr. Jyoti Clara. Over to you, ma'am.
Thank you very much. Am I audible? Is my screen visible?
Yes, ma'am, you're audible and the screen is visible, ma'am. Clear, ma'am.
Thank you very much. First of all, I would like to thank Dr. Asma for having given me this opportunity to be with all of you next 45 minutes. I'm proud I'm a nurse and I'm speaking on this topic on nursing excellence, how to drive it. When we talk about excellence, excellence is always competing with self, not with others. When it comes to excellence of me, I have to check whether how and what I was in the last few years and what I'm today and what is that I'm going to be tomorrow. So that will help me to move forward. The moment you compete with others, either we will get a FOMO, like fear of left out, or probably we will feel we are the best. So always it is important as a nursing department, we should always measure us with the yardstick of us only, how we were performing earlier and what is that we are performing now and what will be our performance in the future. When it comes to nursing excellence, you must be understanding that nursing excellence is an assessment that comes for certification. First thing I would like to request each and every one of the participants today seated here, never ever prepare your nursing directorate or your nursing service just for nursing excellence preparation or certification. Keep doing quality. Let it be the USB and let it be a day-to-day activity. And if excellence or certification or accreditation comes in, that's fine. They can come anytime to assess this because our processes are in place, our practices are in place, and we are very clear what is our goal and the direction. So with this, I would like to take next 30 minutes to explain to you about what is the reason why we have taken this topic, how to drive it, and how do we exactly drive it. Let me give up a background as to where we are up to in nursing. Nursing was always considered to be a caring profession, but now we are moving into curing, and we are part of curing. We are clinicians in the clinical front. When we say clinicians, who all belong to clinician group? The doctors and the nurses, those who are practicing. I call myself as a clinician. I also claim myself as a business leader because I am in the administration. So as nurses, we are part of curing community. We have seen science has moved from palliative to curative. Earlier days, when a patient is chronically ill or when they are having a end stage disease processes, it is very difficult to say that they will live little longer. But now the curative component has come. Lot of regenerative studies have come, lot of regenerative and salvaging processes have happened. So in this way, like we are having lot of facilities and lot of innovations for curative component in healthcare. So we see that we are also having longevity of life and people are having quality of living because of this change in the healthcare. Isolated versus participatory management in cardiovascular intervention and treatment. This is one example I want to give you. We have been always working in isolation, medical and nursing and paramedical team. But now it is all collaborative. We would say we have a cardiac nurse who is able to assess the cardiac failure, and she is called as cardiac failure nurse. We have a cardiac transplant nurse. We have nurses of different titles, those who are contributing towards cardiovascular intervention and treatment. So also in other specialties, we could see there is always no isolation, but we become more participatory. And why did I mention cardiovascular here is when a surgeon closes the final surgery in the cardiothoracic theater, the last question he asks the nurse is like, so shall we go ahead? So the nurse says yes, and that is participatory. Many times when you're standing next to a doctor who's going into the central line insertion, jugular and all, like they insert the catheter, they give a look and an eye contact to the nurse who is assisting, and she says, you are right, you are in the right place. This is how we participate. When a doctor says shift the patient to ICU to ward, then immediately the nurse steps in to say, sir or doctor, I think the patient should stay back for 4 to 6 hours further so that the patient will be able to recover and meet the criteria for shifting to the ward. So we participate. I've just given an example of cardiovascular intervention here, but in all specialization. And that is how we have better results. And we are also able to see nurses are upskilling themselves. They are becoming more specialized and they are the most wanted professionals across globe. And this is not decreasing, it is increasing, and it is in an incremental progress every month and every year. And after Corona, we have seen a great need for nurses globally. And we could see people just fly to other countries and other places where they could be taken care well and they are being positioned better. Having said that, it is not something called as like dependent or independent. We never do a dependent work at all in care. We never depend on medical profession. We never depend on management. We never depend, but we interdependently work. We interdependently work. We never dependently work. Dependent working is somebody saying, do this and you do it. We cannot do that in nursing. In nursing, if there is an order from a doctor, the doctor may be a star doctor, doesn't matter. But if he writes a prescription, it is a responsibility of the nurse to check whether the prescription is right and whether the prescription is an appropriate prescription for the patient, the weight of the patient, the age of the patient, the disease condition of the patient. If it's not appropriate, she can always go back and then say, would you please change the order? Could you please reconfirm? Would you want to look into the order and say whether it is the right one? Patient is on Ryle's tube, you are prescribed an entry-coated drug. Would you like to change? So these are some of the dialogues that we see which says that interdependent. There is no dependent nursing at all. We either independently work or we interdependently work. Independently nurses work, and NABH Nursing Excellence is one of the key tool for you to work independently in many areas. And that is how we promote a cure culture. Leading and advancing healthcare. Nurses lead and advance healthcare. There are a lot of examples. We have like Gracie Mathai ma'am was with you. Now she is leading healthcare in some other organization. She was doing it here. There are leaders like many leaders who are leading the healthcare. Your principal, your nursing head, your senior leaders in MIMS are the people who are leading healthcare, and they are contributing towards, and that is how the healthcare is advancing. And beginning of nursing excellence, I just wanted to give you a history about the beginning of nursing excellence in India. I would recollect, like when I returned back after the position that I was holding with Dr. Asma Bibi there in Sultan Qaboos University, I found that there is something that is lacking for nursing. So our hospital, Global, when they went for nurse NABH accreditation, we got certified in 6-8 months. And once we got certified, when we had the senior, because it was in the beginning, so we get to see our COs, everybody coming down from NABH and offering us the certificate in person. It will be a great program that way. So when it came, Dr. Giridhar Gyani, I just asked, like, why not for nursing? Why only for medical professional you are giving importance? Nurses should also come forward. We should have something for nurses similar to magnet status. And you will not believe there are many leaders like Madam Abati Kupan, and we had Daisy, and we had Elizabeth, so many leaders, and Gracie ma'am, all of them joined hands. Actually, Dr. Karanjekar was there that time as a CEO for us, and then we invited 11 top nursing leaders, and we formed the first core committee, and we applied the magnet status together, and then we formulated which is the standards for nursing excellence. But it was lying low until 2014. And then 2014, the life was given to it. I think that time it was Gracie Mathai ma'am who was in the technical committee. And then they brought in, and then the entire document that was prepared and forwarded to them was reviewed. And then we all met once, and then we again formalized it, and then it was launched. In 2021-22, currently, I am in the technical committee of NABH. Apart from that, we are all again working as a team for revising the second edition. So this is how like the journey began, and we never thought that it would happen unless the first step of one question comes from some of us. So please ask a question, why not nursing and why not for nursing? So NABH, when I would like to quote some information from NABH, this is if you want to know about nursing excellence, just go back to this website. It talks about like why we need to go for nursing excellence, what is the reason, and it very clearly says NABH is a quality body. It says very clearly nursing profession is a cornerstone of any quality related programs in healthcare. When you see nursing excellence or any accreditation program, maybe JCI or NABH, when they come in, the best contribution comes from the nursing department, the leaders and the nurses. It is unanimous across all institutions. They gave their heart and soul and they contribute a lot. Nursing is a larger population in any institution, and that is an advantage for us to claim that we own majority of the success and we owe to it. And something interesting there in my slide, can you see, like 1920 April 2015? I would say that I was proud to come to Malabar Institute of Medical Sciences to be an assessor. And that was my first assessment for nursing excellence. It was 2 days exciting assessment with Beenama. Beenama was my co-assessor, and we both came down and we stayed. It was really a great experience. I could say the principles that you follow related to quality was amazing. I was able to appreciate many good things apart from identifying areas of improvement. Now, why do you have to have nursing excellence? The benefits: stimulates continuous quality improvement, safe, effective, competent, and ethical nursing care. It regulates and guides and promotes professional nursing practice, raises community confidence, because community believes, okay, when they go for nursing excellence, the nurses are safer in this hospital. Guidelines to nursing administrators and supervisors for supporting and facilitating nursing care, and opportunity to healthcare unit to benchmark. See, once you keep collecting data, at one point of time, you can benchmark yourself. And you can say, for example, in our institution, when we see what is the success of the transplant, we found that the transplant success rate of ours is even higher to the benchmark internationally given, which is very surprising, but it is a truth and it is a fact. Now, how did we reach there? It is all because of the quality effort that is put in. So likewise, you can actually benchmark it. So once you collect data, you go through it for a few cycles, then you can benchmark it. Now, what are some of the pillars of nursing excellence? What you should consider? Now, how do you go about? You have to think of transformational leadership, meaning we will discuss about it. Like when you say transformational leadership, where is your CNO position? Where is your nursing head position? Is she having power to in the boardroom? Are they able to hear her voice? Her voice is voice of the nurses in the hospital. So she has to be positioned rightly in the organization. The organogram should be very clear. She should be on second on line from top. So she cannot be pushed to third or fourth. And she cannot be a department of another department. No. Nursing is a department of itself. We always work parallel with medical department. Nursing, when you say a train that runs on the rail track, if there are two tracks, right? It's one track is medicine, the other track is nursing. With these two tracks, the train of healthcare moves forward. That is how, like, you have to, and transformation leadership does not exist with, oh, we have done this in the past, so let us continue. No, it keeps revising. That's why nursing excellence says you have to revise your policy annually. You have to revise your protocol, your manual, everything should be revised annually. Your training PPTs, your training material, everything should be revised periodically. Structured nursing empowerment is very, very important. What is the structured nursing empowerment? We have to empower nurses, those who are working and reporting to us. Everything nursing head cannot do. You have to decentralize certain responsibilities to your next online, and if at all there is a in charge in the cardiothoracic unit, or if there is an in charge in the medical ICU, give them the empowerment. Let them become stronger in that. So let our structure not be strong on top only. It should be strong as you go down. So structural empowerment is very, very, very important, for which you need position, you need salary, you need information. People should know. So what do we do is, like, we also have an organogram position in all our nurses station. So they know very clearly who's a leader in nursing and who's a person they have to contact. So nurses should be having access to escalate. Nurses should be having access to contribute and to give suggestions. So if that is not openly happening, then the structural empowerment is not going to be transparently seen or felt. Clinical nursing excellence, this is all about doing and to see the outcome. For example, you want to see how best the antibiotic administered. Do we have escalation, de-escalation properly? oxygen waste without happening. Clinically, the patient is turned properly right time, no pressure injuries. All the nursing sensitive indicators, quality indicators are met. So these all comes under nursing clinical excellence. And evidence-based nursing practice. Best practices: never clamp or release the catheter before removing the indwelling urinary bladder catheter. Why do you do so? When you clamp, you say it is 2 hours, but sometimes you leave it back for 4 hours. So what will happen? The bladder intima will expand and there will be minute tears, which will not be seen. It is microscopic. Patient will return back to hospital after discharge with cystitis. Many times, this is not noticed. This is not understood. So what happens is patients are treated and again, they go back. But what evidence says that do not clamp and release. Also, the reason is no two bladder is same. It all depends on the amount of fluid you consume. If at all a patient is well hydrated, within 2 hours, how much of urine it could hold differs. So in this reason, we say that do not clamp or release unless it is a neurological bladder. So evidence-based practice talks about that. Hope I am audible and clear to all of you. Am I too fast?
No, ma'am. You're clear, ma'am.
Fine. And if you want to have a chat, please put it in the chat box. All the participants, if you find something to be clarified, please put it in the chat box, which we can clarify later. Now, when you for nursing excellence, you have to have a list of evidences in your hospital. Like we have 15 evidences that are practiced. Do not use povidone on your wounds, then do not clamp and release. Okay, so you have information adequately given prior to surgery. Okay, so psychosocial. So there are several evidence-based practices that are happening. Use ice when you have the contrast administered, and if you have a doubt, so that reduces the vascularity and prevent extravasation. So there are many such evidences that you in day-to-day practice, but put them in order and then say these are the evidences. What is a type of evidence? Whether it is a strong evidence or a weak evidence that you have taken, from which literature you have taken, keep the list ready so that it is also incorporated in the manual. Nursing quality indicator. Sure, the nursing excellence does not specify the number of quality indicator. It is depending on the scope. For example, if you have obstetrics in your hospital, then you certainly have to have whether the mother voided 6 hours within 6 hours and then she got shifted from the labor room. And how many of the mothers did not void within 6 hours and what was the intervention done? Whether the baby was fed immediately after delivery for normal delivery, whether abdominal crawling happened for the newborn. So these are some of the evidence quality indicators that you'll put for obstetric. So likewise, you have quality indicator depending on the scope that you have for the hospital. In addition to that, you have fall, then you have pressure injury, iatrogenic injuries, 2 identifiers. So many other things that you also capture as a quality indicator. Now coming to nursing excellence. When you say NABH nursing excellence, why do we do it? It is a systematic, independent, documented process for obtaining evidence, evaluating it objectively and determining the extent to which policies, protocols, and the requirements, including stated, implied, and statutory and regulatory needs. When you say here, stated is very clear, statutory is clear, regulatory is clear. What is implied? Implied is it may not be explicitly stated, but it is important. It is subtle. It is important. For example, explanation before giving injection. Somebody who is sleeping, you cannot just go and give injection, right? So there are certain explicit expectation that is not very clearly written, but it is implied. So those are also important in nursing excellence. What is standard? The standards you see like a level of quality you want to attain, what you want to attain, and what is the level you want to attain. Now, NABH gives the minimum standard. sky is the limit for your excellence. You can go beyond, but the minimum is stipulated by the NABH. So never see that in whatever standard given in NABH is the ultimate. No, it is the beginning. So once you reach that, then you keep spiraling up as a quality. Standard may be defined as a scale of achievement, which is based on the desired level of excellence. And it's a degree of excellence in nursing care and describes competent level of nursing care, how competent the nurses are and the carers. Now we have chapters and indent. When we have chapters and indent, these standards are put clustered under chapters and indent. So what is indent? Indent is like it gives you in the book, no, it gives you a write-up. What this chapter talks about. What is this chapter expecting us to perform? What is this chapter that will be considered for evaluation? So it gives meaningful interpretation, rationale, significance of the standard that are included in a particular chapter. So the clustering of the standard and giving them interpretation is the responsibility of the chapter and the intent. Now, once the chapter is defined, clustered, standards are clustered, then you have the objective element. What is objective element? We measure it. When we measure it according to the different element that is given there. Under NRM, you will have something called as a CNO should have a qualified, should be qualified. They should have a proper years of experience, number of years of experience. Then she should be positioned in the organogram, right? So these are the measuring components under the standards, which is called as an element. So it is acceptable compliance with objective elements determine overall compliance with the standard. So if suppose in one standard you have 5 objective elements, okay, maybe in first chapter you have this, you take standard 2. Under standard 2 you have few objective elements. So what will you do is you have to see that these elements are complied to. So then if all the elements are met, then you will come to say that you are meeting the standard. We have 7 standards, 7 chapters, 48 standards and 216 objective elements. This will differ in the, this is in the first NABH NE excellence. Now, this is what is the first edition shows. So we have, this is how like it is distributed. We have the resource management, then we have care of patient, management of medication, education, communication, and guidance, infection control practices, empowerment and governance, and then comes your nursing quality indicator. Now, can you see here, these are standards. Now, under these standards, you will have so many objective elements. So if we meet all the objective elements, then if you are meeting all the objective elements, then we are meeting all 9 standards. Then if you are meeting all 9 standards, the entire chapter is being met and complied to. This is how for NCP, it will be this. This is how for MOM, and this is how for education, communication and guidance, infection control practices, empowerment and governance, nursing quality indicator. Now, coming to the main aspect, how do we prepare? What is important? It is important that we understand this is the structure. So this I developed with my own interest when I was working for the hospital for nursing excellence. Actually, I had started working for nursing excellence from 2011 onwards, 10 onwards. And then in the year 2012, I underwent the NABH accreditation course, and then I was certified assessor. But this model was prepared before that. And first thing is learning, and then is application, and then I got certified. So that was a clear process for me to excel and understand the process of accreditation and certification. In this model, I have put input, throughput, and output. What is input? The structural empowerment, transformational leadership, vision, mission, values, and objectives of not only organization, nursing must have vision, mission, and objectives, nursing department, because with the vision and mission and objectives only we move forward. This should be aligned with the organization's mission, vision, and objectives. Core values can be taken from the organization, but it can be translated to nursing related. For example, if you say empathy as a core value of the organization, we should define what empathy means to nursing. And then we will split it up into simple component called as what empathy means to a OPD nurse, what empathy means to a end of life care nurse, what empathy means to an ICU nurse. So that's how you incorporate values into practice. Then comes your philosophy and service excellence goals. So when I say philosophy, philosophy is what we believe, right? So what I believe, what my nurses believe. And we cannot prepare a philosophy just by ourselves. We have to involve everyone. So in our organization also, you could see, the first slide. When I put the first slide, you could see something put there down. There, here, professionalism, expertise, and advocacy. This is our philosophy. So these three are the tenets of our philosophy. So we have to see what is our philosophy for nursing in our organization. So when we think the philosophy for your organization is very clear, it has to be rolled out. Rolling out should be from top down. Like I had rolled out the philosophy development is involving everybody from down up. But once it is developed, rolling out, interpreting it is from top down. So the nursing director will be giving it to the next leadership team. The next leadership team will be giving to the senior leaders, and then it comes to the nurses at the bedside. So once you do it, you should have a measure. You have to see how you convert philosophy. Philosophy is very abstract, but you have to convert it into concrete statements, and then you have to measure it. And when you measure, you will know these are the values that our nurses own it, and they are demonstrating it. So some of the philosophical statements can be attitudinal mostly, but it can be measured by behaviors. Like for example, non-negotiable behavior. A nurse cannot be rude. A nurse cannot be showing a frowning face to a patient. So these are all philosophical demonstration. And greeting patient, meeting patient. So these are all philosophical tenets that you see in reality. And if you don't allow a nurse to learn in an organization, if you don't conduct a CNE, then again it is reflecting philosophy, because philosophical tenet says that expertise is important, and for expertise, training is important, exposure is important, and you have to provide time. It should be a learning environment. So all these are reflected in the philosophy. Now, what is the benefit of the entire framework as an outcome? We'll come to the outcome, then we'll come to the throughput. What is the outcome? Finally, what do you do when you are able to apply this framework? Care quality will improve, safety and lean cost. In fact, why lean cost? Because whenever the attitudinal component is involved, there is a leaning cost. Wherever there is a learning and scientific application, there is leaning a cost. You lean waste. And nursing care standardization will happen. If you take across hospital, you must be having 1,000-bedded hospital or 500-bedded hospital, and you may be having maybe 30, 40 nurses station. When you go across, you will find everybody doing temperature checking same way, blood pressure checking same way, medication administration, they will not be different. Suppose the patient is transferred to different units, they find everybody doing the same way. Methodology is same. Like we talk about Domino's, no? When we say talk about Domino's, the way they pack, way they wrap, way they put things, and way they offer is same. Whether it is done in UK, US, India, or any place. So there is standard. So the same standard, we are able to do it because of such application of framework and nursing excellence. Patient satisfaction and RN job health. Always we measure patient satisfaction, but it's important to correlate with the nurses' satisfaction. If you find a 20-bedded ward, the nurses, there are closer to 20, 22 nurses in that ward. So then what do? You measure the satisfaction of the nurses and you measure the satisfaction of the patient there. Correlated. If the nurse's satisfaction is higher to patient satisfaction, it is not good. If the patient satisfaction is higher to nurse's satisfaction, it's not good. It should correlate to something closer. It should be. Then that is the right kind. Why do I say this? Is because when you have a very happy patient and the nurses are not happy, it means that nurses are pressured to provide care. With pressure, they are providing good quality care. But this will not long last. Nurses will go into burnout. When they go into burnout, what will happen is their performance will go slow and it will not yield the results. And it will not no more fun working in that particular unit. If the nurses are happy and the patients are not happy, maybe there is a rain-free administration. Nobody is bothering. Leadership is not rightly monitoring. Maybe nurses are neglecting. Maybe nurses are not up to they're not demonstrating philosophy or objective vision of the organization at the down level. So probably our training is not happening. So many errors are happening. So we have to see, or sometimes it will be like nursing ratio. It will not be problem with the nurses. It's problem with the ratio. Sometimes you give less number of nurses to that unit, and however nurses do, patient satisfaction will not improve because the nurse-patient ratio is very thin and it is not adequate. Error reporting and reducing. Here, the nurses, once you apply this framework, nurses will become transparent. During nursing excellence, as you take the nursing excellence forward, they become more transparent. How do they become more transparent? You will encourage people to report. So, reporting error, you need courage, or hiding, you need courage. If I ask you to put the answer in the chat box, you will always put reporting error is requiring courage. Yes. So to be bold is to report. If you're brave, you will report errors because you are interested in patient life. Anybody can do error, but the second error cannot happen. What is the second error? Hiding the first error. So hiding the first error cannot happen. So I always tell my freshman nurses, I would not say you cannot do mistakes, but don't do mistakes knowingly. Keep yourself conscious so that your mistakes are lesser. And once you come to know that there is a mistake that has happened, please escalate immediately so that the patient can be saved. I'll give you an example. A patient was transferred from ward theater room to recovery room, post anesthesia care unit. The nurse receives. The anesthesiologist sends a syringe with a technician saying that if the patient has pain, please administer this, so many mics. So the nurse receives that syringe and then she starts giving it. But then as she starts few drops, she found that the patient response was different. She stopped. She called the technician. She asked, what is the ratio? Then he said this. Then the anesthesiologist came. Then we explored that it was not the dilution that is required in the post-anesthesia care unit. It was the dilution that was used in the theater, which cannot be used in the post-anesthesia care unit. So, because she started, okay, there is an error, but she identified it rightly. She escalated, ensured that the patient is reverted and patient was normal and gone to the ward and then sent home. If the nurse is not strong enough to understand this, what will happen is we would have lost the patient. So be transparent, no punitive action. If at all anybody comes and says they have done a mistake, give a bravo card. Tell them thanks. Thanks for coming to tell us about your mistakes. And what is self-reporting? Self-reporting in NABH Nursing Excellence, always you consider self-reporting as a department. Like for example, you're working in a ward, you're working in an ICU. Each one is a nurse's station. Anybody in that unit can report. That is self-reporting. For example, a young nurse, freshman nurse missed a particular vital signs, BP checking before administration of medicine. So then the senior nurse in that unit escalates saying that one of my nurse committed an error and she marks the occurrences. It is still called as self-reporting. Because self-reporting is not only I report, but the team reporting is also self-reporting. Why do we do this is because we need to encourage people to come forward and there should be positivity. There should not be any fear because it is important for us. None of the nurses think that today I'll commit 2 error, I will kill 1 patient. Nobody prays and comes, right? We always say that we want it to be safe. After duty also, we don't want any calls. People should not call us and tell us that, okay, you have not documented this, you have not done this. So all these are being taken care when you are closer to error reporting and error prevention culture building. Now, coming to the throughput. So when you want to reach here, when your inputs are this, you know the input, you know the output. Now, what happens in the middle? That is what is a cyclic pattern. Like lot of PDCS, multiple PDCS happen, Plan, Do, Check, Act. Lot of improvements happen. Okay, so here you have lot of quality audits happening. So what do? First of all, we have to identify standards. So first step is you have to be thorough with the nursing excellence standards, objective elements, interpretation of it. Then what you have to do is you have to compare it with what we have. So that is a first gap exploring. So then after that, you categorize the gaps, identify relevant gaps, put them as a measures and metric. And then when you see that, you will understand something is missing in SOP. So then what you go back to the SOP, and then you see, you will not believe there was such things happening in our institution. One example I would like to give you. Patient coming, there were 7 patients who had extravasation when they were given contrast in the CT room. So what happened was, we found that there was something missing in the SOP. What was missing? It was not prescribed. What should a nurse do, or what should the team do? The nurse, the technician, and the other team should do when a patient has the, when the nurse or the staff has got a doubt that the patient has got extravasation. It need not be extravasation, but the doubt. So when you have a doubt, what do? When you see visibly there are few drops that is coming out on the skin, what do? So the SOP was not, it was generally written. Okay, you take care of the patient, you apply. But then we redefined it saying that no, and we saw somebody applying thrombophobe, which is not good. We then gave, presented to the pharmacy and therapeutic committee. And then we decided, and we said that no thrombophobe or any such medicine. Just use ice, use a pillow sling to elevate the limbs. That's it. Okay, so you reduce the blood supply and then you calm down the cells there, and then it will be all right. And ice also promotes aggressive progression of the extravasation. So this is how the gap is filled. This is just one example out of thousands of changes that you're going to see. And monitor quality indicator, conduct quality indicator. So you keep monitoring it, and never ever we think we are alone. So nursing excellence means it's part of nursing, operational and medical. So when you have a core committee formed for nursing excellence preparation, invite your pharmacy manager, invite your operation head, invite the facility related person. So you have to have one meeting with them. Very important. And you should tell very clearly, for laundry, what is that beyond nursing you require? For biomedical equipment, what is that you require? Biomedical waste, what is that you require? And they have to take process ownership to support nursing excellence exhibition. So this has to be clearly put. If you say only nursing and the nursing team works, you will not get help from them. You will become exhausted, burnt out, and you will not enjoy the nursing excellence journey. So always we call it as a trio team concept. So bring in people into the system, into the plan, so that you will be able to have medical, bring in DMO, one DMO, involve all the HODs of various specialty areas. What is under nursing, but when it is coming to ICU and other area, you have nursing head, you also have somebody as a medical head, right? Senior professional. So bring them all. If it is ER physician is important to be involved. Otherwise, we will not be able to progress forward in excellence. And phlebotomy related work nurses too. So you have to involve lab. It is important, biochemistry lab. We need to have some of the validation done there. So that is one committee, core committee. Then you should have internal to nursing one core committee, which is called as a championing committee. So this championing committee will work towards championing each of the chapter and ensuring everybody is competent on the compliance of these chapters. When you say internal to nursing, you have three categories of internal nursing team. One is nursing administrators, all the senior supervisors and assistant CNOs, assistant superintendent, or maybe assistant director, deputy director, and the nursing director, all of them come as a nursing admin. It's a small group of team. And then comes your nursing mid-level managers, all your supervisors, the next level supervisors of individual unit or department or in charges. All of them come under this. Then comes your nurses at the bedside. Now, we have to have more focus on the middle-level people so that they are able to translate it to the nurses. Now, you must be seeing, because you are an educational institution, you will understand the verbs that are mentioned here. Transform, motivate, facilitate, evaluate, support, decide, directly. So all these are significant for nursing administrators more when compared to nurses. But whereas update, comply, sustain, perform, innovate. So these are some of the things that is very much required for the nurses, those who are working in the those who are working in the bedside. They innovate, they participate, they self-assess. So these are all important. Now the mid-level nursing manager balances between the top and the bottom, and they translate. So the entire pressure and the delight is staying at the mid-level nurse manager. They have to role model, they have to participate, they have to engage. So once you do that, what will happen is you will be having a quality improvement happening. So then what will happen? You will be able to balance cost, quality, safety. Patient will be happy, nurses will be happy, there will be clear benchmarking improvement. So you will raise the bar of quality indicator to reach higher level of excellence when it goes spiral, cycling one around after the other. And then comes after few cycles, you will benchmark. You will say that patient fall is 0.2, but we never had fall. So reduce the benchmark. You can even improve it and then keep it. So this is how you do the nursing excellence journey, and that will give you the result. Now, when you see here, these are the three things that you will focus. And what is for your institution? Suppose MIMS is preparing, you should know what is the structural empowerment means to you, what is a transformation. So everything should be very clearly described. And when you do this, what will happen is nursing excellence continuum starts. So initial to higher level. Probably this time you will be at one level, next time. It's not the gap or the NCs that you get. Oh, I got only 5 NCs. Doesn't matter. Self-assessment is more important than the assessor's feedback, because assessor's feedback is a sampling exercise. But when you do self-assessment, it is a 360-degree deep dive. So we have to understand that. Now, when you say quality improvement, I have explained to you all the steps here. So this is a simple methodological steps that you will follow to go. This has to be done for every single activity, every single component, every single individual, those who are involved in quality areas. Now, scaffolding nursing excellence framework, how do you scaffold it is, like you will have clinical excellence program, continuous quality improvement program, and then you will identify some projects, then you will have list of evidence-based practices, and you will also see what are the empowerment that you have given. The list of empowerments that you have given to the nurses should be written clearly. And how do you promote ethical culture should be very transparently written as a policy. Philosophy, service excellence, I have explained enough. Quantum and quantic transformational leadership. What is the role and how the leadership is? Is the leadership given training on new things as days goes by? How do you go from a comfort zone to a growth zone? Everybody wants to do same thing again and again, right? But every year they should be different. There should be growth. So from a very composed mindset, we have to move into a growth mindset. So what is growth mindset? Organization should grow. If organization grows, I will grow. And if I grow, the nursing will grow. So that is how we keep growing it. And it is important. Never say that, oh, we so many patients, I have no bed, I cannot receive patients. There is no no's in when you go for a transfer. You will find, okay, how do I add nursing manpower? How do I add nursing resources so that I can accommodate more patients and take care of the patient? And even complexity of the patient, we have to be much focused on that. Now, coming to a very important diagram, this is again my conceptual framework, very close to my heart. And I always say that this is central to patient safety. When you empower nurses, patients are safer. Nurses are happy. That is what. So two outcomes, patients are safer, nurses are happy. So it is important. Why not to make patients safer? And why not to make nurses happy? We have to do that. So how do we do it? When you do so, what will happen? So when you do so, professional development, and there is mirroring of something nice happening outside, embarking organization brand in market and marketing. We nurses as a marketer, right? We market. People come to choose an hospital for nursing. Days are gone. For this doctor, I'll come for treatment. After that doctor has done something. See, a good handicraft of a doctor goes into a bad nurse's hands. It is no use because outcome is not there. However good the surgery is, if it goes to a bad nurse, it will not happen. So it is important that only because I always say, no, the doctors go for press release, they go for celebrating success. I always tell them, if not for nursing care, you will not be able to celebrate success. You will not be able to go have a press release. So we ensure that during press release, nurses are invited, they are thanked, they are taken care. So will we reach there? There are certain things that we have to address to, which you have seen already, like leadership, teamwork, partnership with healthcare professionals, medical fraternity, initiatives, opportunity. All these I have actually touched upon in my talk. Okay, all these are serving as a foundation on which you have few pillars. These pillars are very essential for action plan. The first pillar is empowerment is top down, power dissemination. If my nurse does not see me in the organogram or see me as a strong leader, for example, I'm working in medical ICU. I have an in charge in medical ICU. The in charge doctor in medical ICU does not bother to even call the in charge of medical ICU to discuss or plan the care of patient. Then the nurse will know that this is what is empowerment, right? But if the nursing in charge in the ward is involved for admission of patient, discharge of patient, they are collaboratively deciding with the doctor, then the empowerment is there. This is what is called as top-down empowerment. Then empowerment dissemination is a down-pull approach. You have to pull people. I pull people. When I go on rounds, when I see nurses standing behind doctor's group, I slowly bring her inside and keep her next to patient. She has to be in the middle. So for doctor's rounds, the nurse and the patient are in the middle. Rest of the people are around. And your doctor cannot discharge a patient without asking a question. Grace, can I discharge this patient? Shall we discharge this patient? Will it be possible? So when do you think the patient can be sent out? Okay, so this discussion is very, very important. You have to pull people up, bring them into committees. When in the committee, they have to talk, PNT committee, critical care committee, blood transfusion committee, nurses have to be pulled up, call them to present audits, call them to present some of the successes, call them to present data. So it is important for them to present information there in the committee, contribute. They have to contribute. So when they do so, there will be a strong alignment between the committee, the nurses discussing in the ward, in the committee. Then it will happen in boardroom also. In the boardroom, the nursing head should be strong. She should be able to pull up people to make them visible. Just nursing alone, like only one person attending all meeting is not possible. We have to deputation is very important. Leadership deputation is very important in this. When you do a leadership deputation, you're pulling up people, you're providing them opportunity. It is important. Talk to them, counsel them, coach them. Then empowerment as a constituent component of organization philosophy. So if organization does not want nurses to be empowered, see, why do you have this program as a MIMS institution? Early days, you will see they went for nursing excellence. And even now you see that such programs are happening. Why do you think organization is going for it? Because there is a philosophy. So unless there is a belief that nursing makes a difference, you will not be able to have a nurses empowered. Empowerment at thought level precedes action level. A nurse need not be empowered by action, start of her career or at the beginning of joining your institution. Initially, she can be at the thought level. So as nurse educators, what you should do, you should assess whether at the thought level. So anything happens, you have to go back and ask the nurse, what do you think should have happened to prevent this incident? Then she'll say, I think I should have stepped up and communicated immediately. Oh, good. Thought level, she is empowered. But then why is she not doing it? Then we have to explore cleaning up areas, whether she's scared of the doctor, whether she is not having adequate knowledge on the escalation policy, or what is that fear, or what is that stopping her to translate the empowerment in action. So then slowly when you address and unveil, the action becomes stronger. Then and the entire institution becomes stronger. Empowerment once you promote empowerment, it is difficult to say stop. Once what happened, a senior orthopedic surgeon came to my office. He sat in my office. As soon as he came, I asked him, would he like to have coffee or tea? And then we ordered a cup of coffee for each of us. And then I asked him, what is your concern? How can I help you? So he said, I transferred a patient from the ICU, surgical ICU. And 6 hours post that only the patient was transferred. The nurse did not transfer. She's showing me a paper saying that criteria is not fit. I have got so many years of experience. My age is 50. And when I say, why can't they transfer? So I was listening to him carefully. And then I explained to him very clearly, this is a protocol and policy. Once the protocol is rolled out, as a nursing director, I cannot stop it. Nurses follow protocol policies strictly. So, and then I explained to him, do you want your patient to go to ward and come back to ICU with much difficult situation? Or do you want the patient to go to ward and then go home from there? So he said, yeah, go home. So then we have to follow this. It is not just a surgeon as a surgeon. Patients, interventional related queries are there for patients. So patient has to stay back. We have to monitor other things. So then he was happy. He said, okay, now I understand. So it is important for us to have such dialogues with our colleagues, our people, those who are working with us, our team. So then you will see that it gets accelerated and then moves on. Empowerment is not successful with aggression. What happens in nursing community? Mostly we fail because we are too aggressive. We cannot be patient. Sometimes you have to be silent. Sometimes you have to be observant. Sometimes you have to stay and say that, okay, this has happened, but I'll come back to it in a different side, different angle, but I'll solve it. So that should be your determination. Never be aggressive. Passivity is dangerous. Aggressiveness is dangerous. You have to be assertive. Assertive blended with competency and people skill. None of my nurse supervisor, you cannot be a nurse supervisor if you're not competent in that area. For example, if you're a liver ICU nurse, you have to be competent in that particular area. So along with leadership competency checklist, we also put the supervisors under the competency checklist of the area. So this is how we do. Now, success story. So once it has happened, you will celebrate success. Many times what happened, even during the assessment, we have to plan. See, what do you do? If at all, next 6 months, you're going to have the nursing exam, 3 months. So 3 months before, you should know who's going to do morning shift, afternoon shift, evening shift. Train everybody. But then you should know who's going to do, who's going to be there. So this is to increase accountability. And then you keep following the people. Put champions, chapter-wise. Chapter-wise, you give training. Internal audit, interdepartmental audit, like one ICU can go to ward can go to ICU, ER can come to endoscopy. So have an interdepartmental audit done by nurses. Identify internal auditors, certify them. So for a hospital of 10 bed, at least 25 internal assessors are important for nursing excellence. So what will happen? They'll go up and down and they'll keep doing all the audits and try to improve. The staff describing a feeling of empowerment is one of the success. The nurses should see it. The success of NABH nursing excellence is not the number of NCs that you get. It is when your staff say, we feel very empowered. Cohesive team are formed. The team becomes more closer, glued. On the day, I've seen when I gone for assessment, the last day when we say by all of them will come and then they'll take a pic together, they'll celebrate, they'll cut cake, all that. When they get the certificate, they display, CEOs call them. All these are like saying that if we are together, if you're not together, then we will not be. There are some elements, maybe 1 or 2 people who are not with the team. So what do? They go and tell their problems to assessors. Assessors cannot solve problem of your institution. So never do that. If you feel you're discussed, you're not comfortable, go back to your leader and talk to them. That is the best way. And you have to provide as a leader opportunity for them to come back. That will form a cohesive team. Improve staff morale. It will improve staff morale because they are most wanted. When we go for nursing excellence, everybody knows the nurses are the most wanted, and they see all that is happening and importance that is given to nursing. The morale will improve. Increase patient and physician satisfaction. We'll attend to a lot of improvement plan, lot of audits, we'll do the correction. So what will happen? The physicians are also satisfied seeing the improvement. Even the resistive clinician will come closer to nursing and they will understand. They will say, okay, come on, tell us. There are incidences when nurses tell doctor, I think your prescription has to be changed. They'll come back and change immediately, because for nurses, it is a 5 or 1 or 2 or 5 patients that is assigned to us. But for them, it is multiple. And in the multiple setting, for us, it is the same setting. You come for 6 hours, 8 hours duty in one ward or ICU. But for them, they go to ICU, they go to ward, they go to OPD, they go to other areas. And it is a mix of things. So they tend to have some labs in their order or prescription. So that is why we have to say, do not blindly follow, but evaluate, rationalize it, go back, recommend. That's why ISBAR. In ISBAR, that is called as recommendation. Recommend. And then they will understand. Patients and families are included in unit committees and team meetings. It is important to include as many as possible into these committees and too. They should be representative. See, if you have a 5-member department, there will be 1 person representing the committee. If you have 1,000 nurses, then you should have enough member representing different committees, including mortality morbidity committee. In some units, see, because of nursing excellence, some of the hospitals have taken opportunity to enter into mortality. Otherwise, some of the nurses are not, even nursing leaders are not allowed into mortality morbidity committees. Patient satisfaction and then preparation of institution has to happen for the subsequent. See, when you go for, why do I write this point here is, when you go for nursing excellence, you are proving that last 2 years we were growing, next 2 years we will be growing. So we have to say that we are doing this periodically to improve. Then center of excellence. Then we can build the center of excellence. Now, if you see in Mumbai, for us, no, we are hand transplant excellent. We are center of excellence for hand transplant, because we know every single hand transplant coming to us is a success. And patients are groomed, rehabilitated, and taken well. So there is center of excellence for oncology, center of excellence for oncology nursing. So we have to build center of excellence for nursing. So in our institution also, we have got 6 centers of excellence in nursing across group. So we have to build center of nursing excellence, not just the clinical excellence. Clinical excellence is different, but it matters. The number matters, the clinical involvement matters, the clinical program matters. But nursing excellence is something that will purely depend upon the nursing. The workplace can be a positive, curable, not a mind blending and spirit sharing one. So you have to see that the crucible possibility that we have to have a positive mind to involve. And many times what happened during assessment, only the CNO and the few people get exposed to the meetings and other things. Try to involve as many possible. If you have 2 days, put few people in the front, bring some youngsters, team leaders. Some of the senior nurses also can join. So that is how you promote them. You give them opportunity and then to allow them to see. So they'll be very happy what is happening. In the CNE, the success have to be shared in CNE, small groups. Everybody should be involved in the success. It's just not the cream of 2-3 people in the nursing. They are called and they are celebrating the success. And future ahead of nursing expected from each one of us is, it is for us to explore, no? So you have to get involved, participate and act. Everybody should participate. Don't wait for invitation. It is your organization. Just go back to your CNO and ask, what can I do? This is my talent. How can I help? Can I bring in, can I arrange dressing trolley this way? It looks better. I have read in one of the literature this way. Can I implement this with my team? So we have to get involved. Keep the generation strong. Very, very important. What will happen is senior nurses, sometimes even scrub nurses don't allow the younger nurses to scrub. But we have broken that chain in our institution. I'm sure it's happening in your institution also. So allow younger nurses to come in the front. Allow them to work with you. Never say you're too young to learn this. No nurse is too young to learn this. Every nurse joining institution is a nursing officer. She is finishing, unlike medicine. And medicine, at least you practice after you get your credentials. But we practice while we are in nursing. So it is important for us to recognize them right from the start. Never restrict. Never restrict. If you restrict, you cannot have a stronger generation in your organization. If you don't have a stronger generation, you have to bring in leaders from outside. Stop bringing leaders from outside. You should generate leaders from inside. It's important. Sit back, relish the past, cherish the present, and nourish the future. Age is no bar. Never go by age if you want to go for nursing excellence. Some of the young minds will be smarter than some of the older minds. Some of the older people will be smarter than they are. So go by the competency, go by the interest and involvement, go by the zeal and the charisma that the people have. Experience no bar. Again, I am telling you, you will not believe when we had a few assessments done across group, we found that just 6 months old nurse in the profession, she was able to perform better than seniors. How come? How come it is possible? The way she was doing the procedure, way she was expressing the competency. So never put a bar. Hierarchy should never play as well. All it needs is our commitment and passion for profession, blending with daring and risk-taking approaches to break the resistance and take the profession forward. Never ever say that I have removed a nurse from the unit because the doctor didn't like that nurse. It is our responsibility to ensure that the doctor sees that nurse right way. We have to see that the nurse presents herself in a right way to the doctor. It's between the doctor and the nurse. They have to solve the problem. We cannot be shifting them to different departments to solve their problem. So teamwork is important. We have to make them accountable for that. So with this, I would like to say that quality is everyone's responsibility. Quality is a pride of workmanship and best wishes to walk the path others have not taken. Never use same QIP for every nursing excellence audits. You have to have QIP. How do you develop QIP problems? You will take quality indicator for the, now we are come to 2022. Happy New Year to everyone. God has preserved us in 2021 and we are here in 2022 and 2022 is going to be a great year ahead. That is what is a belief and the faith we have with us. Now, if you see you want to have something for 2022, what you have to see, you have to go back to 20 and 21. What is a pattern? What is a quality indicator? What are the negative reports the patient has given us? What are the improvement area that we have identified? What are the feedback from doctors? What are the feedback from senior nurses? All that you have to take and put it in one paper. Then you identify what is the path that you have to take, which you have not walked earlier. Which is the path you have to clean it and then make it beautiful. Which is the responsibility that you have to add to few people. Should you shuffle teams? Should you do things? So all this had to happen 6 months before or every year beginning, the first quarter, your manual should be reviewed. Your plan should be reviewed. Your calendar should be ready. You should know what is your 2022 year going to be like? And then you have to have it, everything written black and white, so that every quarter you will know whether you have reached it. Time bound is very, very important. So with this, I think I have given my views as to how to prepare the unit. I hope you enjoyed the session. I'm very sorry, my slide, I'm not able to see my face. I'm able to see you, but I'm not able to show my face. There is some problem with the connectivity. I hope I have done justice and made it clear. If you have any queries or any doubts, please come back to me through your organization. Thank you so much for giving me the opportunity, and thank you, MC, for introducing me to the team. Thank you.
Thank you, ma'am. Thank you, ma'am, for sharing your expertise in this session. And delegates, please use the chat box for sharing your doubts if you have any. Any doubts from the audience? Okay, so it was truly an informative session, ma'am. So once again, we thank you for taking time out of your busy schedule. Thank you so much, ma'am.
Thank you much. I'm signing off.
Okay, ma'am.
Have a wonderful day, all of you. Happy New Year. God bless you.
Same to
Stay
you, ma'am.
strong, stay safe.
Thank you, ma'am. Thus, we have come to the end of the scientific sessions. We request all the delegates to please fill the posters forms and mark your valuable feedback on the sessions dealt in this conference. Let us now move on to the last segment of our 2 days national conference, the scientific paper presentation. Presenters, please note, you have just 8 minutes for the presentation and 2 minutes for discussion. Kindly stick on to the time. Firstly, I call upon Ms. Krishna V. Gandhi to present the paper.
Good afternoon, ma'am. Good afternoon, everyone. Am I audible?
Yes.
Ma'am, should I share the slides?
Yeah, sure.
My slides are visible?
Yes, Krishna.
Thank you, ma'am. So hereby, myself Krishna Gandhi from Gitanjali College of Nursing, Udaipur, Rajasthan. I will be presenting the scientific paper presentation on the statement of the problem, a study to assess the level of knowledge and preoperative anxiety among patients. I'm sorry, wait a minute. I'm sorry. Now the slides are visible.
Yes, Krishna.
Really sorry. So for the scientific paper presentation, my topic for the day is a study to evaluate the effectiveness of nurse-led interventions on the level of knowledge and preoperative anxiety among patients undergoing cataract surgery at Sri Vinoba Bhave College, Sri Vinoba Bhave Civil Hospital, Silvassa. The background information is, as we all know, that eye is the important sensory organ that is helpful in receiving and gathering the information from the surrounding. It is always that above 50 and above, it is more estimated that 82% of the blindness is because of the cataract. During the cataract procedure, it is very imperative that patient remains still. So the need of the study arises, like when I was in my clinical posting, I found that many patients were fit and fine, their health was normal, but because of the anxiety and due to lack of knowledge, during the surgery or before few minutes of the surgery, they had to postpone the surgery because of the elevation of the blood pressure. With that view, I thought of doing the study on the nurse-led intervention. Here, the survey also says that the untreated cataract is mainly because of fear, anxiety, and the surgery cost. The objectives of the study were to assess the level of knowledge and preoperative anxiety among the patients undergoing cataract surgery in the experimental and control group, to determine the effectiveness of nurse-led interventions on the level of knowledge and preoperative anxiety, to correlate the level of knowledge score and preoperative anxiety score among the experimental and control group, and to associate the pretest knowledge score and preoperative anxiety score with the demographic variables of the patient undergoing cataract surgery. The research hypothesis here as stated that there will be the significant difference in the pretest post-test level of the knowledge score and the preoperative score among the patients undergoing cataract surgery in the experimental and control group at 0.05 level of significance. The nurse-led interventions will bring about change in the post-test and the level of knowledge score and preoperative anxiety score among the patients undergoing cataract surgery in the experimental group. There will be significant correlation between the level of knowledge score and preoperative anxiety score among the patients undergoing cataract surgery in the both experimental and control group. There will be significant association between the pretest level of knowledge score and preoperative anxiety score of patient undergoing cataract surgery and the demographic variable in experimental and the control group. The review of literature I took here and were divided into the three categories. First was the study related to knowledge assessment. Second was studies related to anxiety. And the third was studies related to the effectiveness of nurse-led interventions. The methodology which I used in the research approach was a quantitative research approach with the research design, quasi-experimental, non-randomized control group design, in which in the experimental group, first, the pretest was conducted a day prior to the surgery. In that, the assessment of level of knowledge and preoperative anxiety was done. Then, the intervention given to the experimental group was two. First, routine nursing care was as usually given, and the second was nurse-led interventions, in which I made it into two phases. In the phase one, first, a video-assisted teaching of 15 minutes was shown to the patient, and second was binaural music therapy for 15 minutes. The phase one was also given day prior to the surgery. In the phase two, the same binaural music was repeated for 15 minutes just before the 1 hour of surgery. In the post-test, there was 3 sections, in which in the first section, the socio-demographic data was collected. The second section was the structured knowledge questionnaire that I conducted on the 5th post-operative day, that is the 7th day of pre-test in the OPD, and the assessment of pre-operative anxiety, which I did 30 minutes before the patient undergoing cataract surgery in the inpatient department. The next group, that was control group, in which the same pre-test was conducted, but the intervention was only the routine nursing care, and the same post-test were conducted as scheduled. The research setting I used was the OPD and IPT department at the ophthalmology. The samples were the patients who are undergoing the cataract surgery of Department of Ophthalmology. The sample size I used was 60, 30 in each control and experimental group. The sampling technique was non-probability consecutive sampling technique. The variables, the demographic variables, the independent variable was the nurse-led interventions, which included 2 video-assisted teaching and the binaural music therapy. And the dependent variable was level of knowledge and level of preoperative anxiety. The inclusion criteria were the patient aged 40 and above, those who are willing to participate, those who are visiting the ophthalmic department of the SVPCH, and those who are diagnosed with the cataract and are going for the surgery for the first time, those who can understand Hindi and or Gujarati. In the exclusion criteria, the patient who are not ready were excluded, who had already undergone the surgeries were excluded, patient on hypertensive, antihypertensive or antidepressive drugs were excluded, with patient having hearing impairment or the gross visual impairment was excluded. The tools which I used was first socio-demographic performer, second was self-structured knowledge questionnaire. With the help of Spearman-Brown's proficiency formula, I got the reliability 0.9 and the assessment of preoperative anxiety I did with the modified state trait anxiety inventory adult and with the help of Cronberg alpha method, the reliability was found to be 0.82. As already I said, the interventional package included two, the video assisted teaching and the music therapy. The teaching included anatomy physiology of the eye, cataract management, and mainly it was emphasized for the post-op care. And the music therapy, I got the permission from the Dr. Loy Philip. She is a healthcare professional, and with her permission, I have used the music. The binaural music is a music that is having two different frequency in the both ears, and with that, it is a anti-anxiety that will decrease the anxiety of the patient. It is already proven that this binaural music will reduce the anxiety of the patient. The data collection procedure hereby, I maintained the rapport with the patient, then the consent was obtained from the sample, the control group, pre-test was taken with the described tool, second, the routine nursing care provided, and the post-test was done. Next, in the experimental group, the pre-test was also taken in the prior surgery with the help of the tool as already mentioned. Then the intervention was given, that is nurse-led interventions. And again, the post-test was conducted as per the schedule explained. The analysis of the data was done by the descriptive and inferential statistic. The first section was the description of socio-demographic variables. Hereby, in the age category, the maximum patient belonged to 61 to 70 years. The females were more undergoing for the cataract surgery. Then the samples were more residing in the rural community. The education of the patient in the control group was found that more of them were illiterate, and in the experimental group, most of the samples were primary school education. Then on the basis of the occupation, all the samples, majority of them were unemployed. With viewing to the income category, the income of the control group, the majority were within the 10,000 to 29,970. Whereas in the experimental group, majority of them were less than 10,000. Now, gaining about the previous knowledge of the samples, it came that majority of them were having no enough previous knowledge. Now, the assessment of pre-test and post-test level of the anxiety and the knowledge as divided. In the pre-test level of knowledge, it was found that it was moderate in both control as well as experimental group. Moving to the post-test level of knowledge, in the control group, it was same, it is the majority in the moderate group. But in the experimental group, they gained the adequate knowledge. In the pre-test level of pre-operative anxiety, found that the majority of the samples were having severe anxiety. Then the post-test level of pre-operative anxiety revealed that 90% of them in the control group had the severe anxiety, whereas 83.33% majority of them were under the mild pre-operative anxiety. The section 3, that is effectiveness of the nurse-led interventions. Here we'll see the knowledge. In the knowledge, the pre-test mean was 11.5 with ST of 2.02. In the experimental group, mean was 21 with the standard deviation of 2.16 with the mean difference 9.5 and the t-value 15.23 with the p-value less than 0.01. Hence, the hypothesis was accepted. In the control group knowledge, the mean in the preoperative anxiety in the control group post-test, the mean was 11.6 and in the experimental group post-test was 21. The mean difference was 9.4 and the p-value was 0.01. That was also highly significant. That suggested that in the control group and the experimental group post-test, there was major difference, and in the experimental group, there was increase in the level of knowledge. Here, with the preoperative anxiety pre-test in the experimental group, the mean was 84.76 And in the post-test, it was 40.26 with the mean difference of 44.5 with the t-value 28.2 and the p-value was less than 0.01. That suggests it was highly significant. In the preoperative anxiety, comparing between the control group and experimental group post-test, the mean difference was 44.23 and also the p-value was less than 0.01, which was significant, and that is highly significant. Fourth section, we go for the correlation between the knowledge and preoperative anxiety. It was found that in the pre-test control group, there was a positive weak correlation relationship, and in the post-test control group, there was also a positive weak correlationship. But in the experimental group post-test, there was a moderate correlation of 0.4699. Hence, the hypothesis 3 was also accepted. The association between the pre-test level of knowledge and preoperative anxiety with the selected demographic variable. In the association, all the variables were non-significantly associated with the level of knowledge. Same way, it was non-significant with preoperative anxiety too. Now the discussion part here in the section 2, the assessment of pre-test level of knowledge and preoperative anxiety discussed with the supportive study given by Fockett PS on the 108 cataract surgery. The research found that showed that the pre-assessment stage was more anxious provoking than the post-operative stage. So in the same I did for the pre-operative anxiety. And the section 3 was effectiveness of nurse-led intervention. With the supportive study by Gail M, he performed the study on the preoperative teaching on anxiety levels of patients scheduled for cataract surgery. The findings of the study revealed that the preoperative instructions could help to reduce the anxiety level in the patients. The recommendation of these studies were that the policy could be built up to implement the nurse-led interventions to the higher departments. Also, it can be applied to all the various categories of patients undergoing cataract surgeries. Then the comparative study could also be performed between the two interventions which I have chosen. The quasi-experimental study which I performed could be done to a true experimental study. Even on the larger samples, the study could be replicated. The study I did was only for the cataract, for the ophthalmic department, specific to cataract, but it can be also done for various surgical departments. And as it is a non-pharmacological measure, we can implement in various studies. The conclusion hereby, on the basis of the present study, it was concluded that the nurse-led intervention helped in improving the level of knowledge and it reduced the preoperative anxiety of the patient. The age group that maximum was 61 to 70 years, residing in rural community, and majority of them were females. In the pre-test, it was found that majority of patients were with moderate knowledge, whereas in the post-test, the experimental group, they had mild knowledge, but mild anxiety, but in the control group, they were having moderate to severe anxiety. And thus it was concluded that the non-pharmacological intervention, that is not nurse-led intervention, was helped in improving the level of knowledge and helps in reducing the preoperative anxiety. Hereby the references which I have used, and thank you for allowing me to present in the presentation. And thank you to all and the Department of MIMS College of Nursing.
Thank you, Ms. Krishna.
Yes, thank you.
Okay. The participant one has took 5 minutes extra for the presentation.
I'm sorry, ma'am.
It's okay. So the evaluators can have a discussion for 2 minutes.
Krishna,
Yes, ma'am.
why you have used consecutive sampling?
Ma'am, because it was during the COVID time, and also during that time we were having less patient flow. So if I would have gone under random sampling also, ma'am, then the samples which I need to achieve within 1 month would not be possible for me, ma'am. That is the reason I used the sampling technique, non-purposive type of sampling technique.
Okay, then can you state the hypothesis 2? How you have tested the hypothesis 2?
Yes, ma'am. Hypothesis 2, I tested with paired t-test and unpaired t-test. I have divided into 2, experimental and control group. So I first found out the pre-test level of knowledge in experimental and control, then post-test level of knowledge and in experimental and control group, which I compared with the t-test. But the unpaired t-test I used for the 2 different groups. Means for the pre-test, post-test in the experimental group, I use t-test, paired t-test, and for the pre-test and post-test in opposite groups, I use the unpaired t-test because it was having 2 different groups, ma'am.
Okay.
Okay, Ms. Krishna.
Yes,
Next, I invite Ms. Shilpa S. for presenting the study.
Hello, ma'am.
Yes, Shilpa.
Is the slide visible, ma'am?
Yeah.
Okay. Good afternoon, everyone. Myself, Shilpa, Assistant Professor, Al Shifa College of Nursing, Perindalmanna. So coming to the title, assess the knowledge and practice regarding infection control and standard precaution among nurses in critical care unit of a selected hospital. So according to John Oxford, we have come from a world of infection. We live in a world of infection, and in the future, unless we take control of the infection now, we will continue to live in a world of infection. Just go to the background of the study. Infection is a major problem encountered in healthcare delivery service worldwide. It constitutes one of the most important causes of morbidity and mortality associated with clinical, diagnostic, and therapeutic procedures. The most important source of spread of infection is through contaminated hands of the healthcare givers like doctors, nurses, and other staffs. Most hospital-acquired infections are caused by transmission of pathogen from one patient to another, especially by healthcare workers who fail to wash their hands after evaluating a patient or who did not properly comply with simple hospital hygiene measures. Healthcare-associated infections have long been recognized as crucial factors between the quality and outcomes of the healthcare delivery. Renewed effort geared towards education in terms of training and retraining about standard infection control, as well as strict adherence by healthcare staff and students to aseptic practice can reduce the extent of the risk. Knowledge and compliance with standard precaution is essential to prevent hospital-associated infection and protect patients as well as medical workers from exposure to infectious agents. Nurses play important role in prevention of infection. This mainly focus on assessing the knowledge related to nosocomial infection. Need and significance of the study. Many factors stimulate infection among hospitalized patients. Decreased resistance among hospitalized patients, increasing variation of medical procedures and invasive techniques, crafting potential route of infection and transmission of drug-resistant bacteria are packed up among hospital populations. Propensity for developing hospital-acquired infection is higher in critically ill patients admitted in critical care unit. The reason for a non-adherence to hand hygiene guidelines retreated that compliance with high protocol by healthcare workers is poor due to several constraints, including heavy workload, high number of clinical procedures, and conditions of healthcare workers. So this is a problem statement. A study to assess knowledge and practice regarding infection control and standard precaution among nurses in critical care unit of a selected hospital in Cortical. These are the objectives. To assess the knowledge of staff nurses regarding infection control and standard precaution in a critical care unit, to evaluate infection control practices in critical care unit, to associate knowledge scores obtained regarding infection control and standard precaution with selected socio-demographic variable, to associate practice scores regarding infection control and standard precaution with selected socio-demographic variables. Coming to the true hypothesis, there is a significant association between knowledge regarding infection control and standard precaution among nurses in critical care unit with selected socio-demographic variables. We are adopting Rosenstock health belief model for, Coming to the review of literature, we are categorized the reviews under 3 headings. First one, studies related to isolation precaution and infection control in critical care unit. Studies related to knowledge of infection control practice among nursing professionals. Third one is studies related to incidence of healthcare associated infection in critical care unit. So this is the methodology, quantitative approach we are using for the study. Non-experimental, descriptive, exploratory research design is used for the study. Population is critical care nurses. Setting is Almas Hospital Cortical. 30 staff nurses are selected on the basis of non-probability purposive sampling. Data collection is done by using 3 tools. First tool is structured socio-demographic performa for getting baseline data. And the knowledge is assessed by structured questionnaire, and the practice is assessed by applying observational checklist. Data collection and interpretation are done by descriptive and inferential statistics, and the association are assessed by chi-square value. Sampling criteria, inclusion criteria is ICU staff nurses who were working in ICU for 1 week, who were study diploma, graduation, post-graduation in nursing, who were willing to participate in the study, who were available at the time of data collection. Exclusion criteria, ICU staff nurses who were working in area other than ICU, who were not willing to participate in the study, who were not present at the time of data collection. Dependent variable, infection control and standard precaution achieved by staff nurses. Independent variable, knowledge and practices among staff nurses. So the results are categorized under different sections. First one is distribution of demographic characteristics of nurses in critical care unit. 80% of the staff nurses belongs to the age group in between 20 to 30 years. 93% of the nurses are female, and above 60% they are married. Half of the participants belongs to Hindu religion, and closely half of them belongs to Christian religion, and remaining 10% belongs to Islam religion. 66% are residing in Panchayat, and 66.6% of the participants having the experience in between 1 to 3 years. And more than half of the staff nurses are BSc nursing graduates, and 50% of them have the history of attending workshop related to critical care unit, and 66.6% of the staff nurses having knowledge regarding biomedical waste management, and surprisingly 96% having ICU protocol regarding infection control practices they are aware about. Section 2, assessment of knowledge of staff nurses regarding infection control and standard precaution in critical care unit using structured questionnaire. The result is 60% having good knowledge and 40% having average knowledge. Coming to section 3, assessment of practice of staff nurses regarding infection control and standard precaution using observational checklist. The results were 70% having average practices, 20% in poor practice, and 10% is in good practice. Coming to the association section, there is a significant association between knowledge regarding infection control and standard precaution with selected socio-demographic variables such as age, marital status, number of children, religion, long-term residence, professional qualification, year of experience, workshop attended, related critical care unit, and previous training regarding biomedical waste management. And coming to the practice, the relationship only localized into religion and professional qualification. Coming to discussion, the finding of the present study were in line with another study was about assessing the knowledge deficit concerning nosocomial pneumonia prevention among critical care nurses. A self-administered questionnaire was used among 134 critical care nurses. The result of the study reveals that several important deficits in nosocomial pneumonia knowledge were identified, indicating a need for critical care nurses to have greater exposure to nosocomial pneumonia prevention education, guidelines, and research. Coming to the conclusion, The study results that majority of the staff nurse having good knowledge regarding infection control and standard precaution in critical care unit. The majority of the staff nurse having average practice regarding infection control and standard precaution in critical care unit. You can cite this article in International Journal of Nursing Critical Care, Volume 5 and Issue 2. Thank you. Thank you for the patient listening. Thank you,
Thank
ma'am.
you, Ms. Shilpa, for completing the PPT presentation within the time. And now here you have 2 minutes for discussion.
Okay, ma'am.
Evaluated, please note.
Shilpa, since many of the people have conducted the study, why you have done or repeated the study?
Ma'am, actually, it was an institutional-based study. There are so many complaints of infection department, that is nosocomial infections are some of the incidents were higher in the hospital. So as a part of that, we will take as it's a small project, then conducted the study for a smaller duration.
How many 30 staff nurses you were samples no in different
Yes,
ICUs?
Yes, ma'am. Yes, ma'am. Hello, ma'am. Hello.
30, no?
30, ma'am.
Which sampling technique was used?
Non-probability purposes sampling, ma'am.
Okay, okay.
Because the major problem we have faced is there is cooperativeness is very less, ma'am, in between the staff nurses, because the staff shortage was very severe there. So this was a challenge for us to complete the study, because we are dividing in 3 shifts and we are checking the staff nurses. We are collecting in 3 shifts, ma'am. We are approaching the staff nurses who are working in the different shift. The number was very low.
Checked it with observational checklist was used for
practice,
some
ma'am.
practices, no?
Yes, ma'am. Hand washing.
Then only one person, and how you have done it?
Actually, it was a group project, ma'am.
Group project.
Yes, ma'am. Me and my students are there. 4 members are there in the group.
4 members. Then how you have done this observation?
We have a checklist.
Only one person have observed, or different person has observed?
Actually, we are assessing the patient for 1 week, ma'am, same person, and there are different criteria in the checklist, that is hand washing and disposal of waste in the proper that color code system, disposal of the waste product, and they are touching one patient after caring, they are properly hand washing and doing that hand washing procedures, that hand hygiene procedure before touching to next patient. So many steps are there in the checklist, ma'am. So we are assessing each, that every steps they are satisfying or not. The students are dividing into 3 ICUs, then they are collecting the samples, ma'am.
From the participants.
Sorry, ma'am?
How you have taken consent from the participants?
Actually, the first thing was we have to convince them. It's very difficult, ma'am, because of the heavy work schedule and lack of enough staffs in the ICU. It's very difficult. So we have to convince it with infection control team that it's a better result, better prognosis for the patient. That's why we are convincing them as a positive approach. Finally, they will agree with the study, ma'am.
Okay, then how you have established the reliability of that tool, whether that tool was a standardized tool for you have used for observation, or you people have made, or it is an
for a checklist, we have standardized a tool, ma'am. As from the infection control department, we got a standardized tool for checklist. For assessing the questionnaire, we are prepared the tool and we are assessing it by Cronbach's alpha. 0.87 is the value, Cronbach's alpha reliability.
Reliability, especially if we are using observational checklist standard, how will you do the reliability assessment?
Ma'am, actually it was a standardized tool, ma'am, checklist.
Even though it is prepared by somebody else from outside also, you will see whether how will you calculate the reliability in an observational.
Sorry, ma'am. I
Have
have
you
no idea.
rate the reliability?
Hello, ma'am. Hello.
Inter-rater reliability, have you heard?
Sorry, ma'am. No idea, ma'am.
No, just to go and read.
Okay, okay.
Thank you, Ms. Shilpa.
Thank you, ma'am.
Next, I invite Mr. Ajmal Rahman KK for presenting the study.
Thank you, ma'am. Ma'am, am I audible?
Yes, you're audible.
Okay. I am not able to share the screen, ma'am. There's only one host. Okay, now it's fine. Okay.
Ms. Shilpa can stop sharing the screen.
Ma'am, is it visible?
Not right now, Ajmal. It is not visible right now. The slide is not seen.
1 second, ma'am. Okay, what about now, ma'am?
Now, okay, now it is seen. You can just play the screen, no? So this.
Yes.
Okay, now it is visible. Now clear out.
Okay, ma'am. So, good afternoon, respected ma'am. So, my study title is A Study of Social Capital and Self-Rated Health Among College-Going Students in Puducherry. And the background of the introduction of the study is like the concept of health would be incomplete without emphasizing social aspects of an individual. So what is actually social capital? Social capital is the sum of total resources embedded and relations surrounded by a person that makes the resources through gathering of networks, which mean like a network of social relations by norms of trust and reciprocity. It includes social network structures, resources streamlined, and social capital had gathered importance as it is influences the development of youth. So the resources, what all resources are encircled by the people, that is termed as social capital. Not only the economic or financial support, but also the good friends, good relations, good neighborhood, good what about good colleagues. So such a way, all resources we usually say the social capital. So the aims and objectives of the study is among the college going students of selected colleges of Puducherry, the first aim is to determine the social capital perceived by the students. Second thing is to identify the factors associated with social capital. Third thing is to determine the association between social capital and self-rated health. And fourthly, the qualitative component of the study to explore the perception of the participants on the social capital experienced by them means by the students. And we can see what is social capital and self-related health, the two important terms in my study. So social capital means the resources that are assessed by the individuals as a result of their membership of a network or group. And what is self-rated health means? Self-rated health is a single item indicator of health status across social science research where participants can rate their own health. They can click their own health status by assessing themselves. What is my today how is my health status? They can themselves value their health. So these are my two operational definitions of my study, and the reviews of literature were selected from the different categories of studies, like studies which emphasizes on social capital worldwidely, and studies from Indian context, and studies focuses on social network and cohesion related to social capital. And the importance of the research work is like mainly on adolescents, because our India is one of the country where the adolescent is having mostly like almost 243 million of adolescent or adult age group, like 10 to 19 year of age group are residing in the in our country. like while comparing rest of the world, and it is given, the statistics is given by the UNICEF on 2019 October 2. And the related to methodology of my study, my research approach is the study is designated to have both quantitative as well as the qualitative approach. So it's a sequential explanatory mixed method is used, in which a cross-sectional analytical method by a validated questionnaire is used for quantitative part, and for qualitative part I have used focus group discussions are used for the qualitative part. And regarding the research design, is used, the study was a sequential explanatory mixed method. Firstly the quantitative part is done, then the qualitative part is done. So the variables were the independent variables like social demographic variables such as age, gender, number of family members, education, income were the independent variables, and the outcome variables were the self-rated health status. And the setting of the study was the arts and government arts and science colleges at Puducherry. And the population, the target population of the study was the refers to the college-going students of the Puducherry, and the sample of the present study comprises the student from Bharatidasan Government College for Women, Tagore Government Arts and Science College, and Indira Gandhi College of Arts and Science from Puducherry. And related to the sample size calculation, assuming the percentage of low family social capital as 5.4 percentage and 2.5 odds ratio for good health, quality in high family social capital college students from the previous study from Croatia, which was done in the year 2015, with 95% confidence interval and 80% power, with design effect of 1.5, calculated the sample size as 422 was my sample size using the software OpenAP. The qualitative part of the study, the sample size selection was like considering the feasibility, the two focus groups discussion consisting of 8 members was being conducted till the saturation of response attained. And the sampling method was multi-stage cluster sampling method. And after the multi-stage cluster sampling method, I have used simple random method from the colleges to select the participants. Then the development of data collection instrument, the tool was a data collection instrument was a pre-tested self-structured questionnaire validated by social science senior resident and junior resident of Department of Preventive and Social Medicine, JIPMER. And related to the procedure of data collection, selection of colleges in Puducherry, that was the ideal focus of clusters in cluster sampling. That was the step 1, and step 2 was the informed consent. And then the eligible students were in a cluster were selected. Then the quantitative part of the study was done by administering a semi-structured questionnaire. After that, the qualitative part of the study is done by conducting 2 focus group discussions. One was among the male students, male participants, and second was among the female participants, consisting of 8 members in each different groups. And audio recording was done and transcript were made with the help of an audio recording. And my area was in Puducherry, and I have got one help from a Tamil speaking student who had helped me in translating this Tamil content to English language while using the analysis part of qualitative data. And the result and findings, the data was collected from 422 participants between the age group of 18 to 25 years old, and the response rate was 100%, and around 29.4%, 46.9%, and 18.2%, and 4.5% belong to the age group of 18, 19, 20, 21 respectively. And the mean age was 19.03 years was found to the participant with a standard deviation of 0.98. And out of the sample, about 21.1% of the participants were male and 78.8% were female. One college was entirely women's college. And about the association of social demographic variables with the social capital, that was my association was done by using the chi-square value, and it reveals the variable income had significant association with social capital, and that is p-value shows 0.04, and rest of the variables had no significant association with social capital. And the analysis part of the qualitative part is some of the themes and codes were formulated. Themes were identified and codes were formulated. Then the theme was, global theme was social capital expressed by the college going students. The theme 1 is role of family social capital in maintaining health. So social capital is divided into 3 components. One is family social capital, Second thing is neighborhood social capital, and the third thing is college social capital. Then related to the family social capital, role of family social capital in maintaining health. How does it happen? So the identified code were there were poor communication within the family. And code 1B is non-supportive family for academic progression. So most of the participants who are doing their graduation, so mostly they are, for some of the families were not encouraging the students to go for higher studies that were identified in the qualitative part. And there was some of the fluctuating financial support, and some of the students were even for going for the part-time job in order to complete their education. That also was identified in the from the qualitative part. Then theme 2 is the role of neighborhood social capital in maintaining health, and codes were identified as there were lack of trust among the neighborhood social capital, and they were motivated by the feeling of belongingness, like they were sharing their emotions, and they are getting a feeling of belongingness from their neighborhood positively. That also was formulated. Then related to the college social capital, theme 3, role of college social capital in maintaining health, and codes were identified as need for good friends. Mostly some of the friends were actually abusing, or like they were using like drug abuses, and the normal students were actually like they were attracted to such habits because of the bad friendship. So the codes were identified as need for good friends from their qualitative part of discussions. Then third B, 3B, there were strengthened during social activities. The students' behavior are like their potentialities will be like it was strengthening by using various social activities like visiting old age homes, or while doing like by celebrating their birthday parties from their old age homes or nearby such poor associations. Like they were doing some of the charity works that was giving them some strength as a good behavior. That is also one of the identified code from like this college social capital. That was the results. And conclusion of my study is the study found that among the study participants, of 2/3 of the college going students were having high social capital, which splits to 3 domains. And out of it 2/3 of the participants had high social capital from family, college, and half of them had high social capital from neighborhood. And 2/3 of the participants were with moderate health status. And the health was classified as excellent, very good, good, then poor and very poor. That was the rating scale of health, so that they can rate themselves. And 2/3 of the participants were having moderate health status, which were like good health status. And the study reveals that the current trend of youth towards the health perspectives, which can be beneficial to further actions and reference that can be a reference in implementing some of the youth related activities in future. That was the conclusion, and these were my references.
Okay. The
Thank
third
you, ma'am.
participant took 3 minutes extra for the presentation.
Sorry, ma'am.
Now we have 2 minutes for discussion.
What are the strengths and limitations in your study, Ajmal?
Strength was actually speaking one mostly focused. And if you ask a question like where is adolescent boys, that was one of my strength of my study, which I feel like mostly the through the qualitative part of my study, the problems of some of the adolescent boys are they are able to reveal their personal issues. So we are not that much caring the adolescent boys. That was one of the field which I have felt after my studies. We need some of the more focused interventions towards adolescent boys also, than considering always adolescent girls, which I feel. And weakness, I felt like since it was a COVID situation, the colleges, the data collection was a little bit difficult. And weakness, which I feel mostly the behavioral pattern, or the qualitative part was less. I was conducting only 2 focus group discussion, and if we are conducting any large interviews or open air questions, such things if this study was a longitudinal study, that may be giving a much good result, which I feel. My study was just a cross-sectional study. That was I felt, ma'am.
Then any future recommendations? One is you have already mentioned few of the recommendations like longitudinal.
Yes.
Any
Yes.
other?
Mental health component of the study also can be included, ma'am. Especially health status. I have just mentioned only health status. That health status can be splitted into mental health, physical health. Such components can be again it can be split in future, ma'am, which I felt. So that new scales for this mental status also can be prepared.
Then which method was used for analyzing the data in qualitative part?
Qualitative part was like a focus group discussion. I was recording the audio by using mobile phones only. Then I was like writing that there mostly they have spoke which sentence. I have classifying which sentence they have mostly spoke, and I have made into themes and codes.
There may be some techniques or specific method. You just find out which
Okay,
method,
okay.
different qualitative analysis methods are there.
Okay, ma'am. Thank you, ma'am.
Right. Okay.
Okay, ma'am.
Thank you, Mr. Ajmal.
Thank you,
Next, I
ma'am.
invite Ms. Anaka P. for presenting the study. Anaka, are you ready?
Yes, ma'am, I'm ready.
Okay, Anaka. You can share your screen.
Okay, fine. Ma'am, is it visible? Hello?
It is not visible. Just the screen is a white color. That's it.
Okay, okay. Just wait. Okay. Is it visible?
No, Anaka.
Now is it visible?
No, Anaka. Ms. Binsi, can you share the presentation of Ms. Anaka? Can you share the screen, Binsi?
Yes, ma'am. Yes, ma'am. Just wait.
Yes, Anaka, you can start presenting now.
Okay. So, good afternoon, everyone. Is it audible, ma'am?
Yes, Anaka.
Okay. First, I'm sharing thanks to Principal Dr. Asma BVTM and Vice Principal Dr. Shijila CH and the overall conference organizers for giving a chance to me present my topic here. So we can move on to directly the presentation. Title of my study is The Effect of Structured Teaching Program on Knowledge Regarding Reproductive Tract Infections Among Kudumbashree Members. And coming to the introduction, we all know that a woman's health is her capital, and the health and well-being is a matter of concern which affects all aspects of human being, and it has a wider implication for social, economic, and political life of an individual. Then, especially the health of the woman has a great association for growth and welfare of a country. Then good sexual and reproductive health is one of the important for women's general health and well-being. Women's experiences a unique healthcare challenges and are more likely to develop certain diseases than men. Such conditions which may affect the sexual and reproductive health of women. So in that, the reproductive tract infection is very common, which is affecting in women. So generally seen, this is an silent epidemic in is one major public health problems that causing significant proportion of gynecological morbidity and mortality, maternal mortality in developing countries. So studies on women in developing countries has found that the reproductive tract infections prevalence rate that is ranging from 52 to 92%. Coming to the statement of the problem, they evaluate the effect of structured teaching program on knowledge regarding reproductive tract infections among Kudumbasri members at Andur Municipality, Kannur. Then objectives. First objectives, assess the existing knowledge regarding reproductive tract infections among Kudumbasri members. Then second one, evaluate the effect of structured teaching program on knowledge regarding RTIs among Kudumbasri members. Third one, find the association between knowledge score regarding RTIs among Kudumbasri members with socio-personal variables. Coming to the operational definition, effect refers to the extent to which the STP on RTIs has achieved the desired outcome as evidenced from the gaining knowledge score measured by knowledge questionnaire. Then coming to structured teaching program, it refers that the systemically developed teaching learning activity for 1 hour duration, which consists of instructional resources like slides designed for Kudumbasri members to impart the knowledge regarding definition, types, causes, signs and symptoms, complication management and prevention of reproductive tract infections. Coming the knowledge, it refers to the awareness regarding RTIs among Kudumbasri members as measured by structured knowledge questionnaire. Coming the reproductive tract infection, which refers to the infections of the reproductive tract, which include syphilis, gonorrhea, trichomoniasis, bacterial vaginosis, vaginal candidiasis, and HIV, that salpingitis. Kudumbasri members, which refers to the woman who is the member of Kudumbasri unit of Andur municipality. Then socio-personal variables refers to the sample characteristics which include age, religion, type of family, education status, occupation, and monthly income. Coming to the assumptions, the Kudumbasri members will have some knowledge regarding reproductive tract infections, and the structured teaching program will improve the knowledge of Kudumbasri members. Then also this structured teaching program will promote the health-seeking behaviors among the Kudumbasri members. Coming to the hypothesis, H1, there is significant difference between mean pre-test and post-test knowledge score regarding reproductive tract infections among Kudumbasri members as measured by structured knowledge questionnaire. Then coming second one, there is significant association between pre-test knowledge score among Kudumbasri members with the selected socio-personal variables. Then conceptual framework, I here quote Daniel and Stufflebing CIPP model, that is context evaluation input, then process and product evaluation. So then coming to review of literature. Research methodology. Here review of literature, I had divide the category, classified my studies support and 3 headings. First one is prevalence of reproductive tract infections, that include 11 studies, and knowledge regarding RTIs include 11 studies, and effectiveness on structured teaching program, knowledge regarding RTIs include 9 studies. So total 31 study I had included in my study. Then coming to the methodology, research approach is quantitative experimental approach, and research design is pre-experimental, one group, pre-test, post-test design. Then variables, independent variable include the structured teaching program on knowledge regarding RTIs among Kudumbasri members, and the dependent variables include knowledge which is gained by the Kudumbasri members regarding reproductive tract infections. Then settings, Kanagayana Varanashala at Andur Municipality, Kannur district. Then population, Kudumbasri members of Andur Municipality, Kannur. Then sampling technique, convenient sampling technique. Then sample size is estimated at about 60. Then tools and techniques for the data collection, structured teaching, structured knowledge questionnaire, and technique was self-report. Then coming to the tool description, part 1, I divided this tool into two, part 1 and part 2. Part 1 contained 9 questions and also including the socio-personal variables, include 6 questions, and the members who are having any previous experience for attending this class, which include 3 questions. So the socio-personal data include age, religion, type of family, then occupation, education, and monthly income. Then coming to the part 2 questions regarding RTIs, I divide the section into 3, section A, B, C. Section A contains the general information about the RTA, which includes 6 questions, each one carries 6 marks. And section B, which include the knowledge regarding causes, signs, and symptoms of RTA, includes 6 questions, score is 6. Then section 3 or C contain knowledge regarding complication and management and prevention of RTA, 13 questions each. The score is 13, total is 25 questions. The next, this is the interpretation of the knowledge score. Here, I divided the categorized the knowledge into poor, average, and good. The good carried mark in between 18 to 25, that is 72 to 100%, and in average 9 to 17 mark, that is about 36 to 68%, and poor 0 to 8, that is about, the percentage is about 0 to 32%. Then this is the development of structured teaching program. That is, I reviewed the literature and reviewed the textbook, and discussion and consultation with the expert of the Department of Obstetrics and Gynecology and the Community Medicine department. Also get suggestion from the guide. Then content validity. Content validity I had done with the consultation of 8 experts in the field of obstetrics and gynecology and community medicine. Then coming to the reliability of tool, I had selected calculated that reliability by Cronbach alpha method. Then pilot study, I had done the pilot study among 6 samples on 3rd of January 2020 at Pilatara Kudumbasri unit in Chirdaram Panchayat, which is coming under Kannur district. Then coming to the data collection process, after getting the institutional ethical committee clearance and permission, also I get from the municipality chairperson and Kudumbasri chairperson at Andur municipality. Then I had collected the data after obtaining informed consent from the subject. Then the pre-test questionnaire was given to assess the knowledge regarding RTAs among 60 samples. Then after that, I had given the structured teaching program. Then on 28th February 2020, the duration of the entire program was 1 hour. Then after 14 days, that is about 14th March 2020, I had given, I had done that post test.
Sorry to interrupt. You're exceeding the time limit. Now it's already been 10 minutes.
Okay, fine.
Can you just speed up?
Analysis. Okay. So analysis of my data was done by descriptive and inferential statistics. Then socio-personal variables, which is analyzed in terms of frequency and percentage. So, okay, then the pretest and knowledge score was computed by mean, median, mean and mean percentage and standard deviation. Then next one. Next. Okay, next one. Next. Okay. This is the description of socio-personal variables. In that, that is the 45% of the samples, which is belongs to 31 to 40 age group. Then 93.3% samples, which is belongs to Hindu religion. Then 68.3 samples belongs to nuclear family. Next. In education, 35% of the samples belongs, they are completed degree. Then next is occupation. 81.7% of the samples, which is they are home workers. Then in income, 31.7% they are have income in between 5,000 to 15,000. Coming next, section 2. This is the distribution of samples, which is based on the pretest knowledge score regarding RTIs. Here, 78.3% have average knowledge regarding RTIs during pretest. Next slide. This is the next. The next, this is I refer the area wise. Then next slide. Okay, next. Okay, this is fine. This is the area wise mean percentage of pretest and the post-test knowledge score regarding RTA. Here, this diagram is showing that there is a high variation, or there is a difference between in the pretest and the post-test knowledge score. Here in post-test, we can find that 90% of the sample having general information about RTA, and also 88% having knowledge regarding causes and signs and symptoms of RTA, and 78% complication and knowledge in complication and management prevention of RTA during the post-test analysis. Next slide. Okay, next. Okay, this is the significant difference between the mean pretest and post-test values that I already mentioned. Next slide. Association. Next, this is the association between pretest knowledge score with the socio-personal variables. Here we can see the calculated value is greater than the table value. Here that means the education status, occupation, and in monthly income. So we can conclude that there is a significant association between the pretest knowledge score with the socio-personal variables. Coming next. Okay, discussion. The present study reveals that most of the samples have a 78.3% have regarding RTA. That in related study, a non-experimental research approach with a descriptive survey research conducted to assess the knowledge of women regarding RTA. That result shows that 61% had average knowledge regarding RTA. Next one. The next. Then this is the effect. The mean post-test knowledge score regarding RTA among Kudumbashree members will significantly higher than the mean pre-test knowledge score. So one of related studies, true experimental study, which is conducted by to assess the effectiveness of behavior change communication package on RTA in reproductive age. That the result shows that knowledge regarding RTA was found to be inadequate among women after BCCP intervention. That means behavior change communication package. Okay, the next one. The next third objective, significant association between knowledge regarding RTAs with the education, occupation, and monthly income. Here, descriptive observational study to conduct the knowledge of nursing person regarding RTA, association between knowledge and variables. The next slide. Okay, next. Nursing implication in nursing practice. Okay, coming education, research, and administration. Coming to the limitation. Here I face one problem that during my post-test time, there is a social pandemic disease, COVID was there. So I can't collect the pre-test of 4 samples at a time. Then I'm doing one thing that I went to their home and collect their data. Then the rest of them I had selected, done the data collection from a common place. Coming to the recommendation, a similar study was maybe conducted, including the dimensions of people's attitude, health-seeking behaviors, and actual practices towards the prevention and control of reproductive tract infections. Then comparative study can be carried out to ascertain the knowledge regarding RTAs between urban and rural community. And a similar study may be replicated on a large sample at the state, national, international level. Thereby, findings can be generalized globally for a large population. Okay, that's all, ma'am. Thank you.
Thank you, Anaga. Now there is 2 minutes time for discussion.
Yes, ma'am, I go.
Okay.
Hello, Anaga.
Hello.
Hi.
Why you have selected these Kudumbasri members?
Because they are social workers, ma'am. So they can share more knowledge regarding this reproductive tract infection and other information to community women know. That's why I select this Kudumbasri members, ma'am.
For that purpose, you are selected. Okay.
No, ma'am.
Without there
They
is
can-
any significance that there are among Kudumbasri members, this RTA is more common. So that is why you are selected like that. Okay, okay.
No, ma'am.
And then the tool that you have prepared or any ready-made tool?
No, ma'am. That is I prepared that questionnaire.
Then validity, reliability, and also how you have checked the validity and reliability.
Validity done by consulting with the 8 expert in the Department of Obstetrics and Gynecology and also non-community medicine. And
That
reliability,
reliability.
alpha method, ma'am.
Okay. Oh, okay.
Thank you, Anagha.
Okay, thank you, ma'am.
Next, I welcome Ms. Minigina P. For presenting a study. And you have 8 minutes for presentation. Kindly stick on to the time.
Okay, madam. Thank you. Is it visible?
Yes.
Yes, Nigina.
Good afternoon, all. Good afternoon.
Nigina, can I interrupt? Can you put it in slideshow mode?
Yeah. A warm good afternoon to all of you. Scientific paper presentation. The statement of the problem. A study to assess psychological distress and ways of coping among family caregivers of patients with traumatic brain injuries admitted in Government Medical College Hospital, Kozhikode. Introduction. Accidents are an unexpected event, typically sudden in nature and associated with injury, loss, or harm. Accidents are a common feature of the human experience and may result in injury or permanent disability. Accidents occur as a result of a combination of reasons. While the cause of accidents can vary, consequences are often same, resulting in damage and serious injuries. Accidents may cause injuries like brain injuries, fractured bones, burn injury, catastrophic injury, drowning, electrocution, and spinal cord or back injury. Moderate and severe traumatic injury can lead to a lifetime of physical, cognitive, emotional, and behavioral changes. These changes may affect a person's ability to function in their everyday life. Objectives. Assess the psychological distress experienced by the family caregivers of patients with traumatic brain injuries. Second, identify the ways of coping adopted by the family caregivers of patients with TBA. Assess the association between psychological distress and selected variables among family caregivers of patients with TBA. Assess the association between ways of coping and selected variables among family caregivers of patients with TBA. Determine the association between psychological distress and ways of coping adopted by family caregivers of patients with TBA. Hypothesis. There is significant association between psychological distress among family caregivers of patients with TBA and selected variables. There is significant association between ways of coping among family caregivers of patients with TBA and selected variables. And third one, there is significant association between psychological distress and ways of coping. The conceptual framework used was based on Sister Callister Roy's adaptation model. Review of literature. It was organized under the following headings. Epidemiology of the traumatic brain injuries includes 11 studies. Impact of the traumatic brain injuries in patients and family caregivers, 12 studies. Psychological distress and ways of coping among family caregivers of patients with TBA, 10 studies. Total 33 studies were included. Research methodology. Research approach, quantitative research, design, non-experimental descriptive research design, setting, neurosurgical and surgical wards of Government Medical College, Kozhikode. Sample, family caregivers of patients with TBA admitted in neurosurgical and surgical wards of Government Medical College Hospital, Kozhikode. Sampling technique, consecutive sampling. Inclusion criteria, family caregivers of patients with TBA admitted in the hospital for 7 days or more, who are in the age group 15 to 65 years, willing to participate in the study, able to read and write Malayalam, involved in the patient care. Exclusion criteria, the family caregivers who have mental illness, hearing impairment. Tools and technique. First one, questionnaire to assess the socio-personal data of the patients with TBA and family caregivers. Record review. Technique, self-reporting and record review. Tool, second, brief symptom inventory BSI 18 checklist to assess the psychological distress. And third one, COAHS brief COPE inventory scale to identify the ways of coping adopted by the family caregivers of patients with TBA. Reliability. Reliability was calculated by using Cronbach's alpha, and the value of the reliability tool 2 was 0.751 and tool 3 was 0.689. Data collection process. After getting administrative sanction, the data were collected from 107 family caregivers during the period 22nd March 2021 to the 1st of the May 21. Samples were collected using consecutive sampling technique. It took approximately 30 minutes. Analysis and interpretation. Data were collected from 107 family caregivers using the questionnaire, then BSA 18 checklist and COAHS brief COPE inventory scale. The data were organized, tabulated, and subjected to descriptive and inferential statistical analysis with the help of 18 version of the SPSS software. Section 1. A. The socio-personal data of the patients with TBA. It includes age, gender, marital status, number of children, type of family, occupation, and support system available. B. It includes the type of TBA, surgical management for TBA present GCS scope, the difficulty in performing activities of daily living, presence of bed sore. Results. The 43.9% of the patients with TBA were in the age group 20 to 39 years. Majority were males. 61.7% were married and 62.6% belonged to the nuclear family. 36.4% of the patients were coolie and 36.4% were having spouse as the supporting system. One with the clinical data, 29.9% of the patients have STH, 37.7% have undergone craniotomy, and 33.7% had present GCS score less than 13.2% have patients have bed sore. Second section, socio-personal data of the participants. It includes age, gender, religion, educational status, occupation, marital status, type of family, relationship with the patient, income, and the source of income. Section 2B, perceived health status. It includes diagnosed illness and perceived health problems of the participants after undertaking the caregiver role. Results. 34.6% of the participants were in the age group 26 to 35 years, 51.4% were females, and 61.7% Hindu religion. 62.6% of the participants had high school, higher secondary education, 74.8% were married, and 60.7% belonged to nuclear family, and 29% were cared by the mothers. Majority were belongs to BPL, and 46.7% were themselves as the source of family income. And the perceived health status of the participants. 43.9% of the participants had very good health status, 63.6% had no diagnosed illness, and 91.6% had no perceived health problems after being the caregiver. Section 2, the psychological distress among the participants. It includes mainly 18 items under 3 subscales: somatization, depression, and anxiety. The results, 86.9% of the participants had moderate psychological distress. Then section 3, ways of coping adopted by the participants. The subscales, it includes maladaptive coping and the adaptive coping. The maladaptive coping includes self-distraction, denial, substance abuse, behavioral disengagement, venting, and self-blame. Adaptive coping includes active coping, use of emotional support, instrumental support, positive reframing, planning and seeking social support, use of humor, acceptance, and participating in the religious activities. 48.6% had used self-distraction, and none was using substance abuse as a maladaptive ways of coping. 97.2% of participants had highly used instrumental support, and none of them used humor as an adaptive way of coping. The result, 92.5% the moderately used maladaptive ways of coping, and 53.5% had highly used adaptive ways of coping. Section 4, association between the psychological distress and the selected socio-personal variables of the participants. Section 5, association with the ways of coping adopted among the participants and the selected socio-personal variables. And the section C, correlation between the psychological distress and the ways of coping among the participants. There was a positive correlation between the psychological distress and the maladaptive ways of coping among the participants. And there is a negligible correlation was found between the psychological distress and the adaptive ways of coping among the participants. Section 4 results, there is a significant association between psychological distress and the type of family of the patient, then the relationship with the patient and the perceived health problems of after being the caregiver. There was a significant association between the maladaptive ways of coping and the perceived health problems after being the caregiver. There was no significant correlation between the psychological distress and adaptive ways of coping among the participants, and there is a significant correlation between the psychological distress and the maladaptive ways of coping. Discussion. In the present study, 43.9% belonged to 20 to 39 years, and similar, the study was conducted, a retrospective epidemiologic study was conducted for the head injury patients at Port Harcourt Hospital, where 32% belongs to 21 to 30 years. And the gender, 72.7% were males. And in a study, prospective population-based study, epidemiology of the severe brain injury, 71.4% were males. And in my study, the craniotomy, 37.4% were undergone craniotomy, and a similar study is conducted in 2019 Government Medical College Trivandrum. A longitudinal cross-sectional study, the 48% had undergone craniotomy. Then 29.9% had STH and 39.97% had STH. Psychological distress in the present study, 76.6% had moderate depression and 82.2% had mild anxiety. Similar study was a literature review in 2019. It showed that significant levels of stress, anxiety, depression, and burden. Depression among the TBI caregivers are often high, 22 to 77%. The ways of coping, 85% of the participants had highly used acceptance as a way of coping. In March 2015, a study was conducted on the effect of the TBA on the caregivers dealing with grief, coping with changes, and looking forward to the future. 80% of the participants had highly used acceptance as a way of coping, along with the disbelief and grief. Limitations of the study. Scope of generalization is limited due to small sample size. Study was done in single setting. Recommendation. It can be replicated in different settings. A similar study can be conducted to assess the family roles, challenges, and needs of the family caregivers in caring for TBA family. A similar study can be conducted to assess quality of life of family caregivers after undertaking caregiver role. A comparative study can be conducted to assess the psychological distress of caregivers of patients with TBA who are admitted in hospital and within 2 weeks after discharge from the hospital. The same study can be conducted with a large sample size. These are my references. Thank you.
Thank you, Ms. Nigina. You took overall 9 minutes for the presentation. And judges, you have 2 minutes for discussion.
Hello, Nikina.
Yes, ma'am.
What was your sampling technique?
Consecutive sampling was used, ma'am.
Why you have used consecutive sampling?
Because it was COVID-19 and the traumatic brain injury patients was very low because lockdown time and the accidents were also very low, less during that time.
Where was your setting?
Government Medical College Hospital, Kozhikode.
How many hypotheses you have explained?
Sorry, ma'am.
How many hypotheses was
There
there?
are mainly three hypotheses.
But the last one correlation you have explained.
Yeah, the association was found to be correlation, ma'am.
Association. Correlation.
No, there was association between the selected socio-economic variables and the distress and also coping, and the psychological distress and ways of coping, there was found to be correlation.
Okay. Okay.
Okay, thank you, ma'am.
Okay.
Thank you. Thank you for listening.
Thank you, Ms. Nigina. Next, I invite Ms. Sona to present a study.
Association പറഞ്ഞിട്ട് അവസാനം നോക്കുമ്പോൾ ഒരു correlation ചെയ്തു വെച്ചിരിക്കും.
Good afternoon to one and all.
Yes, Sona, you can start.
Okay. I'm Sona from MIMS College of Nursing. I'm doing a study on effect of interventional
Sona, can
program
you
on
put that
knowledge and practice
slideshow?
regarding self-care.
You can continue, Sona.
Okay, so I'm doing a study on effect of interventional program knowledge and practice regarding self-care among pregnant women with the hypothyroidism. My guide is Mrs. Shobha, Assistant Professor in Government College of Nursing, Thrissur. Introduction. Thyroid disorders constitute one of the most common endocrine disorders in pregnancy. Literature shows the prevalence of hypothyroidism in pregnancy of 2.5% and prevalence of hypothyroidism in Indian pregnant women 4.8% to 11%. Need and significance. Untreated hypothyroidism in pregnancy is associated with both maternal and fetal adverse effects. It is known to result miscarriages, anemia, preeclampsia, gestational diabetic mellitus, abruptio placenta, PPH, and increased cesarean section. Fetal complications include low birth weight babies, preterm delivery, both neonatal hypothyroidism and hyperthyroidism, intrauterine growth retardation and stillbirth, and intrauterine fetal death, and increased prenatal mortality. Next statement of the problem, a study to evaluate the effect of interventional program on knowledge and practice regarding self-care among pregnant women with a hypothyroidism in selected government hospitals in Thrissur. Objectives of the study, there were 7 objectives. First objective, evaluate the effect of interventional program on knowledge and self-care among pregnant women with a hypothyroidism. Second objective, evaluate the effect of interventional program on practice regarding self-care among pregnant women with hypothyroidism. Then identify the relation between the knowledge and practice regarding self-care among pregnant women with hypothyroidism. Then fourth objective, find the association between the knowledge regarding self-care among pregnant women with hypothyroidism and selected variables. Then fifth one, find the association between practice regarding self-care among pregnant women with hypothyroidism and selected variables. Next is the hypothesis. H1, there is a significant difference in the mean knowledge score regarding self-care among pregnant women with hypothyroidism before and after interventional program. Second hypothesis, there is a significant difference in the mean practice score regarding self-care among pregnant women with hypothyroidism before and after interventional program. Then third hypothesis, there is a significant correlation between knowledge and practice regarding self-care among pregnant women with hypothyroidism. And fourth one, there is a significant association between knowledge regarding self-care among pregnant women with hypothyroidism and selected variables. Then fifth, there is a significant association between practice regarding self-care among pregnant women with hypothyroidism and selected variables. Next, we are going to the methodology. Research approach was quantitative approach and research design, pre-experiment, one group, pre-test, post-test design, and setting of the study, Government Medical College Hospital and General Hospital, Thrissur, Kerala. Then population women with hypothyroidism and sampling technique, purposive sampling, and sampling size 36 pregnant women with hypothyroidism who fulfill the inclusion criteria. Next is the sampling criteria. Inclusion criteria, the pregnant woman with a gestational age between 4 to 34 weeks and willing to participate in the study and able to read and write Malayalam. Then the exclusion criteria, pregnant women with cardiac, renal, and liver disorders and eclampsia and severe pregnancy-induced hypertension. Next, we can describe about the tool. Tool 1, semi-structured questionnaire to assess the socio-personal and clinical characteristics of the pregnant woman with hypothyroidism. The first tool consists of 2 sections. Section A, questions were related to socio-personal characteristics, and section B, questions were related to clinical characteristics. Total number of questions 11. Then tool 2, questionnaire to assess the knowledge among pregnant women with hypothyroidism. Number of questions 18. Then tool 3, reported self-care practice inventory for pregnant women with hypothyroidism. Number of questions 18. Next is the content validity. The content validity of the tool was established by the 8 subject experts from Department of Obstetrics and Gynecology, and reliability of the tool. Reliability of the tool was established by max alpha, and the reliability coefficient of the tool 2 was 0.82, and for the tool 3 it was 0.86. Next, ethical consideration. Ethical clearance was obtained on 29/5/2019. Next, we can move on to the results. First is section 1A, socio-personal characteristics of hypothyroidism. 55.5% belong to 20 to 29 years, and 38.9% were educated up to secondary level, and 94.4% were housewives, and 61.1% belong to nuclear family, and 55.6% had no previous information regarding hypothyroidism. Next is section 1B, clinical characteristics of the pregnant woman with hypothyroidism. 63.9% belongs to third trimester, and 41.7% belong to Gravida 2, and 36.2% had past history of abortion, and 44.5% had past history of hypothyroidism, and the associated comorbidities with this hypothyroid pregnant women were 25% had gestational diabetic mellitus, and 5.6% had both the gestational diabetic mellitus and the gestational hypertension. Next is section 2. That is effect of an interventional program on knowledge regarding self-care among pregnant women with hypothyroidism. The results were, after interventional program, knowledge score was improved significantly from 5 to 15, and the computed p-value was 23.6 with a p-value of 0.0001. As the obtained p-value was less than 0.001, the null hypothesis was not accepted. Next is section 3. That is the effect of interventional program on practice regarding self-care among pregnant women with hypothyroidism. So the result, after interventional program, the practice was significantly improved from 13.42 to 44.67. The computed p-value was 21.9 with a p-value of 0.001. As the obtained p-value was less than 0.001, the null hypothesis was not accepted. Then section 4, relationship between knowledge and practice regarding self-care among pregnant women with hypothyroidism. The result, the computed Karl-Pearson correlation coefficient R value was 0.20 with a p-value of 0.23. So it was concluded that there was a weak positive correlation between the knowledge and practice regarding self-care among pregnant women with hypothyroidism. Next, section 5A, association between knowledge regarding self-care among pregnant women with hypothyroidism and selected variables. There was significant association between the knowledge regarding self-care and occupation of the pregnant woman with hypothyroidism. Next is section 5B, association between practice regarding self-care among pregnant women with hypothyroidism and selected variables. The result, there was no significant association between practice regarding self-care among pregnant women with hypothyroidism and selected variables. Next, we can move on to the discussion section. Study findings. The pregnant woman with hypothyroidism had associated complications such as abortions and intrauterine fetal death. The author and year, Sisodia, J. 2017, similar study findings, rate of maternal complications, abortion 10.6% and intrauterine fetal death 9.2% were found to be higher in pregnant with hypothyroidism. Then next study finding, effect of associated comorbidities among pregnant women with hypothyroidism. That author and year, Klein RZ 2013. Then the similar study findings, adverse maternal effects in the hypothyroid group when they have comorbidities such as gestational and gestational hypertension. Then third study findings, there was improvement in the knowledge and practice score after interventional program among pregnant women with hypothyroidism. Then author and year, Thomas M.A. 2017, similar study findings, after interventional program knowledge score improved from 24.67 to 53.15 and practice score improved from 25.72 to 55.05. So next we can move on to the nursing implication section. In that, nursing education, bring positive attitude towards the self-care and initiate discussion and improve the ability of communication. Next, nursing practice to conduct the healthcare programs and reduce the mortality and morbidity rate and improve the quality of life. And next, nursing administration, mobilize the available resource personnel and organize in-service education. Then last, nursing research, that is serve as a scientific basis and increase the wealth of the knowledge. Then last, next is about the limitation and recommendation. Okay, ma'am. Limitations, there was attrition of 3 samples during the course of study and recommendations, similar study can be conducted in the large sample and regular awareness programs on the self-care with the hypothyroid pregnant women can be initiated in the hospital and community settings, and the future researcher can assess the level of satisfaction of pregnant women with hypothyroidism regarding nursing care provided to them. In conclusion, study findings revealed that after interventional program, knowledge and practice scores significantly improved, and it is inferred that interventional program was effective in improving knowledge and practice regarding self-care among pregnant women with hypothyroidism. And these are the references that I referred.
Okay, Sona. Now the 2 minutes time have been started for the discussion. Evaluators, you can ask any queries.
Okay.
How much was your sample size, Sona?
Actually, ma'am, the calculated sample size was 35. During this period, I got 39 samples, and during the pretest, I got 39 samples. And after post-test, there were 3 attritions. 1 sample got pre-labor and 2 got discharged. So I didn't get them for post-test.
Okay.
What interventional program you have done?
That was an education program, ma'am. A structured educational program I given. Total 45 minutes. In that 35 minutes, I given education about regarding the general things about hypothyroidism during pregnancy, and the diet that they have to follow, and the food patterns that they should be avoided and I given education regarding the medication, and I also given an exercise that they have to do during this pregnancy period.
Okay, then how you have checked the practice?
I given a checklist. After pre-test, I given a checklist to them. The process was conducted after 4 weeks. So during that period, they have to do these things properly. So I given a checklist for these dates for 4 weeks. And during the process, I used to collect that checklist.
Okay.
Okay. Next, I invite Ms. Wahida K for proceeding a study. You have 8 minutes time for proceeding. Ms. Wahida, are you there?
Hello, ma'am.
Yes, Wahida.
Am I audible?
It is little bit feeble. Can you just raise your voice?
Okay, ma'am. What about now?
Yeah, it is clear now.
Can you see my screen?
Yeah, you can put it in slideshow mode.
Okay.
Yeah, it is clear now.
Myself, Wahida. First of all, I would like to thank our respected principal, Dr. Asma Bibi TM, and Vice Principal for giving me a chance for presenting in this conference. First of all, I would like to tell my title, that is the evaluative the effectiveness of structured teaching program on knowledge regarding danger signs in newborn among NICU nurses. In the life of a human being, birth of a baby is a very sweet moment. The birth of infant is one of the most awe-inspiring and emotional events that occur in one's lifetime. A healthy newborn is born at term between 38 to 42 weeks gestation, then cries immediately after birth, establish independent respiration, quickly adapt with the extrauterine environment. Then the neonatal period is the first 4 weeks of life and represent very vulnerable to the in a newborn baby life. And the detection of this neonatal illness through identifying danger signs is an important step toward the newborn survival. You know what's danger signs, which provide warning when a hazard or a hazardous condition is like to be threatening. So in danger signs in newborn refers to the signs leading to either recognition of illness or healthcare seeking in the sick newborns. The WHO recognized the danger signs were categorized as follows: not feeding since birth, convulsion, respiratory rate of 60 or more, fast breathing, severe chest syndrome, temperature above 37.5 degrees centigrade, temperature below 35.5 degrees centigrade, then only moves when stimulated or not even when stimulated, that is weakness or lethargy, yellow soles, umbilical redness, draining pus, skin boils or eye draining pus, signs of local infection. Then, according to National Neonatal Forum in India, the danger signs in newborn, they categorized as follows: as poor feeding, convulsion, hypothermia, poor capillary refill, jaundice, failure to pass meconium and urine, vomiting, diarrhea, abdominal distension, cyanosis, apnea, retraction, tachypnea, tracheoesophageal fistula, and umbilical infection. Then WHO report 2018 said about 46% of the deaths were among newborn infants, and about 70,000 newborn deaths every day, with about 1 million dying on the first day and close to 1 million dying within the next 6 days. UNICEF reported that total neonatal mortality in 2018 is 25.41 per 1,000 live birth. In 2021, it is 28.7 per 1,000 live birth. Then, according to this report in 2018, they ranked 12th in the neonatal mortality rate in the lower income country with 25.4 per 1,000 live birth. In Kerala, it is 3 per 1,000 live birth. Then my statement of the problem: a study to evaluate the effectiveness of structured teaching program on knowledge regarding danger signs in newborn among NICU nurses in selected hospitals of Malappuram. The objectives are evaluate the effectiveness of structured teaching program on knowledge regarding danger signs in newborn, determine the association between pre-test knowledge scores of NICU nurses with their selected socio-demographic variables. Then operational definition, effectiveness refers to the positive changes in the knowledge among nurses. Then the structured teaching that is developed by the researcher to escalate the knowledge of the NICU. It is a lecture based discussion adopted. Then to impart the knowledge on the danger signs with the help of PPT and pamphlet. Then the knowledge that is a positive response from the nurses. Danger signs means the signs which can complicate the life of a newborn. in the study NICU nurses in those who are working in the NICU in selected hospitals. Malappuram conceptual framework is general system theory. Chapter 2, review of literature. It was arranged according to the sessions: review related to danger signs newborn, review related to knowledge regarding danger signs in newborn, effectiveness of sexual teaching program on knowledge regarding dangers in science in newborn. Total 39 reviews were collected. And chapter 3, methodology. The research approach was quantitative approach, research design, pre-experimental design, then independent variable structure teaching program regarding danger signs in newborn, dependent variable knowledge regarding danger signs in newborn, socio-demographic variable, age, gender, educational qualification, years of total experience in NICU, any training session attended in danger signs in newborn. Then schematic representation of the study. Research problem approach, quantitative design, research design, pre-experimental, one group, pre-test, post-test design, population, NICU nurses from selected hospitals of Malappuram. Then the sampling technique, non-probability purposes sampling, 96 NICU nurses was selected, data collection was done, pre-test assessment was done, a structured teaching program was given with the help of LCD and pamphlet. Post-test assessment was done from the NICU staff nurses regarding danger signs in newborn with the then sample and sampling technique. About 96 staff nurses from selected hospitals were selected with the non-probability purposes sampling. Then the sampling formula, about 96 was the sample size. Then the inclusion criteria knows those nurses who are working in NICU nurses who are willing to participate in the study. Exclusion criteria, NM's qualification nurses were excluded. Those who have staff at the time of leave were excluded. And the tool and technique it is administered and semi-such is created by the researcher herself. It was 2 sections. First section is socio-demographic variables of NICU nurses. Second question from the knowledge regarding danger signs in newborn among NICU nurses. It consists 35 questions from various danger signs in newborn. Then grading of score: poor, less than 24%, adequate 25 to 49, 50 to 75%, good, excellent, more than 75%. STP, it was done by the researcher by adopting the knowledge from poor feeding, convulsion, hypothermia, etc. And it was given to the staff nurses. Then content validity, 11 expert in the field of neonatology, child health nursing, and statistics. Neonatologists, pediatricians also helped me for doing the tool. Then reliability, it is by split half method. It is 15.75. It is going to be highly reliable. Pilot study was done by in Al Madina Institute of Medical Science, Kottakkal. I have selected 10 participants for the pilot study. Data collection process, it was done in the period of January 2019 in Maulana Hospital, Aster Mills, Kottakkal, Al Shifa Hospital, EMS Cooperative and Memorial Hospital, Perindalmanna, Malabar Hospital, Manjeri, Korambel Hospital, Manjeri. This was the 6th hospital I had selected for my main study. The investigator selected 96 participants that fulfilled the inclusion criteria by using the non-probability purposes sampling. After that purpose of the study explained, consent was taken and the participants were informed before the study. The participants were selected, questionnaire was given, about 50 to 20 minutes were taken for attending the questionnaire and 45 minutes for attending the STB. After 14 days, process was conducted. Then descriptive and inferential statistics was used, that is the frequencies, percentage, paired t-test for comparing the pre-test and post-test. And for the frequency and for the analyzing the socio-demographic variable, chi-square was used to determine the association between the variable with the pre-test score. Then the areas I have used. Chapter 4 analysis, it is based on the 4 section, that is distribution of demographic category of them and their knowledge and their effectiveness of the MySTP, and also the determine the association between pre-test score and the NICU nurses with their selected socio-demographic variable. According to the majority are included in the 20 to 25 age group. According to their educational qualification, about 72% of them having BSc nursing qualification, only 25% have diploma in nursing, that I mean GNM. Any other qualification that include MSc nurses, and also years of total experience, about 68% of them have 1 to 3 years of experience. In NICU, they have majority have 1 to 3 years of experience in NICU. And about the training sessions attended by them was, it was only 7, only few attended training sessions on danger signs in newborn. And about their level of knowledge before I giving the test, that before the pre-test, that is only 48% of the people have adequate knowledge, 14 people have excellent knowledge. But after the STP, structured teaching program, it became escalated to 29, and also the most of the people have good knowledge. Then the analysis of effectiveness of structured teaching knowledge regarding danger signs in newborn, their mean score was 20, and it was 24.9 with standard deviation 4.4.
Mahida, you have exceeded the time.
Okay, ma'am. About the result, most of them have 20 to 25 age, and the majority have 73% have BSc nursing, years of 1 to 3 experience. Majority have. Then training session, nobody attended, many of them not attended. Then hypothesis, my first hypothesis was accepted, but second was partially accepted because I have got one association, only one association, that is for the training session attended by them. Other are not associated with the pre-test score. Then a similar study also conducted in the newborn danger signs among staff nurses working in Tummaneswar Hospital and Medical Research Center. Then about that, it was found that majority of the studies had median knowledge, 40% are adequate knowledge regarding newborn danger signs. Then summary, the present study was conducted to evaluate the effect of STP on knowledge regarding danger signs in newborn. The investigator found that there was significant difference in knowledge in pre-test comparing to the post-test. And also there is association for the training session attended in danger signs in newborn. So in nursing education, it can be utilized by the student to develop skill in creating knowledge in danger signs newborn, and also do in-service education. Nursing service, nurses can assess danger signs in newborn and also educate the mothers to identify them. Administration, the administrator should organize in-service education program to give health care personnel a refreshing course, encourage them to participate in this activity. Researches can be done to conduct the same study with a different variable on a larger scale. Limitation, time limit is there. So due to lack of time, is the generalization is not limited. Recommendation, this can be done with a larger samples, and also this can be replicated with the probability sampling technique, and also other healthcare professional can be included inside, such as paramedicals, etc. A similar study can be replicated also. Reference, this is my reference. Thank you.
Thank you. Thank you, Ms. Wahida.
Thank you,
Now we have 2 minutes time for discussion.
Hello, Wahida.
Hello, ma'am.
How many settings you have used for collecting the
I have for main data collection, I have collected 6 hospitals as the setting from Malappuram district. 6 hospital, NICU of 6 hospital I have collected.
Then what was your sample size?
96. We go.
Okay.
Okay, ma'am. Thank you, ma'am.
With this, we have come to the end of 2 days national conference. And now I invite Ms. Alflin Jose to read out the report of this national conference.
Report of National Conference 2022. The planning for the conference started in the month of October 2021. Quality in healthcare management was selected as the main theme for the conference. On the first day of the conference, the inaugural session started at 8:45 a.m. Dr. Shejila CH, Vice Principal, MIMS College of Nursing, welcomed the gathering, and Dr. Asuma BVTM, Principal, MIMS College of Nursing, delivered the opening remarks. The conference was formally inaugurated by Dr. Abraham Maman, Senior Consultant and HOD of Pediatric Surgery. The occasion was graced with the presence of Engineer Abdurrahman KP, Managing Director, Aster MIMS Academy. The first session was on Total Quality Management Strategic Dynamics by Dr. P. Naveen Kumar, Professor and Head Department of Hospital Administration, Kasturba Medical College, Manipal. The second session was on benchmarking, adopting best practices to improve quality by Ms. Wahida Rahman, an excellence consultant with Abu Dhabi Chamber of Commerce and Industry. Following this, a panel discussion on strategies for quality assurance in healthcare management moderated by Dr. Asuma BV TM, was held. The panelists were Dr. Sachin N. Suresh, Group Manager, Customer Care and Patient Excellence, Badr Al Sama Hospital, Muscat, Oman; Mr. Vivin George, Assistant General Manager, Operations, Aster MIMS, Kannur; Mr. Samir PT, Chief Executive Officer, Badr Al Sama Hospital, Muscat, Oman; and Dr. Sharbaz Bichu, Chief Operations Officer, Aster Hospitals, Mankul, Dubai. The forenoon sessions came to an end with a scientific deliberation on documentation and quality healthcare by Dr. Asuma BV TM. The first session in the afternoon was on disaster preparedness in quality healthcare, set up by Dr. Venugopalan PP, Director and Lead Consultant in Emergency Medicine, Aster DM Healthcare. It was followed by a session by Dr. Savia Fernandez, Nursing Superintendent MGM New Bombay Hospital, Vashi, on the topic KPI for Performance Appraisal for Nurses. The first day of the conference came to an end with a panel discussion on assertiveness and leadership for nurse executives, which was moderated by Dr. Anis George, former Dean, Manipal College of Nursing. The panelists were Dr. Sudha A. Reddy, Dean, Faculty of Nursing, KLE Academy of Higher Education and Research; Dr. Larissa Martha Sams, Principal, Lakshmi Memorial College of Nursing, Mangaluru; and Dr. Prabha K. Dasila, Director and Principal, MGM New Bombay College of Nursing, Maharashtra. The first session on the second day of the conference was on emotional intelligence and Johari window for leaders in healthcare management by Dr. Rajani Bagga, former professor and head Department of Social Sciences, National Institute of Health and Family Welfare, New Delhi. The second session on techniques of quality assurance in healthcare management was done by Dr. Somu G, professor, Department of Hospital Administration, Kasturba Medical College, Manipal. Following this, Dr. Lata Mandal, Joint Secretary, Nursing Research Society of India, gave a scientific deliberation on quality indicators for best practices in nursing. The fourth session was on exploring the potential for excellence in healthcare by Dr. Harish Pillai, Chief Executive Officer, Metro Pacific Hospital Holdings, Philippines. The pre-lunch session was concluded by Dr. Shejila CH, Vice Principal, MIMS College of Nursing, on digital health, artificial intelligence, and technology in healthcare. The post-lunch session on nursing excellence, how to derive, was done by Dr. Jyoti Clara Michael, Director of Nursing, IHH Healthcare, India. This was followed by scientific paper presentations. The pretest and the post-test were conducted. The mean pretest score was 11.2 and the post-test was 17. Regarding the feedback of the conference, regarding the overall feedback, 55.2% of the delegates rated the conference as very good and 31% rated as excellent. So that's all regarding the report of the conference. Thank you.
Thank you, Ms. Alfil, ma'am. And now I kindly invite Shijala ma'am to announce the awards for best paper presentation. Ma'am, please.
The best paper presentation award goes to Ms. Krishna Gandhi.
Thank you, ma'am.
Thank you, ma'am. And congratulations, Ms. Krishna.
Thank you so much, ma'am. And I appreciate the conference. All the expertise were also very well. And the timing was also appropriate, ma'am. I thank Principal ma'am and all other organizing staff for organizing such an informative conference. I would like to meet you all once again.
Thank you, Ms. Krishna, for your valuable feedback.
Thank you so much, ma'am.
Ladies and gentlemen, thus we conclude for time being. Once again, thank you all for spending your valuable time with us for these 2 days. We look forward to see you all again when the next move takes the stage. Thank you and have a nice day.